Good morning, everyone. We are starting our program. It's my pleasure to welcome all the respected speakers and all my dear friends on behalf of Organizing Secretary Dr. Rajesh Karyakarte sir, Microcon 2024 47th Annual Congress of Microbiology conducted by BJGMC Pune. As we have 18 workshops, Rajesh Karyakarte sir could not be here. So I am coordinating this workshop. I am Dr. Pooja Shah, Assistant Professor, Department of Microbiology, BJGMC Pune. Let's join the battle to defeat the superbugs. In response to this urgent issue, essential antimicrobial stewardship programs are important than ever. Today's workshop is designated to equip us with the knowledge, tools, and strategies to optimize antimicrobial use and combat resistance. We are fortunate to have experts and leaders, that is, our speakers in the field, who will share their insights on the basic of antibiotics, antimicrobial stewardships, extreme drug resistance organisms, quality indicators in AMSP, AST reporting, developing antimicrobial stewardship program, introduction to antibiogram and antibiotic policy, and HUNET. There is a small message from our HOD, Karyakarte sir. I would like to play this here now. Then we can start our program.
Good morning, all. I welcome you to Microcon 2024, the 47th Annual Congress of the Indian Association of Medical Microbiologists, organized by the Department of Microbiology, BJ Government Medical College, Pune, in the cultural capital of Maharashtra, that is Pune. We are delighted to have you join us for one of the most remarkable lineup of 18 pre-conference workshops at Microcon 2024. Our pre-conference workshop at serial number 22, titled Basic and Advanced Workshop on Antimicrobial Stewardship, organized by us in collaboration with Jehangir Hospital, Pune, is coordinated by Dr. Vikram Padbidri, Senior Consultant Microbiology and Infection Control, Jehangir Hospital, Pune, and Dr. Pooja Shah, Assistant Professor from my department. The faculty will provide you with basic principles of antimicrobial stewardship. They will also focus on XDR organisms and the additional tests required for their identification, interactive case discussions with this will help the delegates apply antimicrobial stewardship principles. They will also guide in developing an antimicrobial stewardship program for your own college and hospital. We encourage you to actively take part and understand the intricacies of these advanced methods that are bound to transform the future of modern medicine. Welcome again.
Now I welcome our first speaker, Dr. Vikram Padbidri sir, Consultant and Head, Department of Microbiology and Infection Control at Jehangir Hospital. He is a workshop coordinator from Jehangir Hospital. He is a clinical microbiologist with expertise in antimicrobial stewardship, bacteriology, immunology. He has taken many workshops on antimicrobial stewardship infection control practices, including hospital-acquired infections and outbreak management. He is also experienced in PCR, NABL, and NABH requirements. It's my pleasure to welcome you, sir, and I request you to introduce the workshop. Welcome, sir.
Thanks, Pooja. Well, that was very much me with a lot more hair. So I'll quickly take you all through what we expect today. Okay. How many of you all have actually done antimicrobial stewardship or are doing antimicrobial stewardship in your setups? Can we have a show of hands? Okay, 1, 2, 3. Just started. Okay, Dr. Sandhya. Okay, great. 3. So about 3 or 4 people. Okay. What we expect you all to achieve by the end of the day today is 1. Understand the concept of antimicrobial stewardship. Once you understand the concepts, everything else falls into place. Understand the role that a microbiologist is going to play in this whole AMSP program. Where does your role fit in? What are you expected to do? What are the additional things that you can do? Okay. Try and try and identify the action items that you can implement in your setup. We'll be having an exercise for this, and a few pointers that I would like to tell you all right away is, please keep a pen and notebook ready. Mention or just note down all the questions that you'll have during the various talks that you are going to listen to, and we will address those questions during the panel discussion or the open discussion that we have. Okay. So that will also help us to save on time, and we'll be able to address your questions properly. So this is our plan for today. We would be starting off with Dr. Kumar on antimicrobial stewardship program, where Sir will also tackle the role of the microbiologist in an AMS program. Okay, so this is extremely important for you all because this is going to lead the basis for today's AMS program. Okay, Dr. Piyush Chaudhary, our ID physician, is going to talk about the basics of antibiotics. Unfortunately, during a microbiology curriculum, we are rarely taught about antibiotics, and antibiotics is something that you'll need to know when you'll have an AMS program. So we'll briefly touch upon these antibiotics. Now, you may not be able to remember everything, but try and incorporate whatever you all can. Okay, then XDROs. This is the new menace that we have, and I'm sure all of you all know that WHO has said that the number of deaths because of AMR by 2050 is going to far exceed that of cancer and other causes. So XDROs becomes very important to detect, to know what to do, and follow it up. We'll then quickly talk about QIs in AMSP because any program, unless you have a quality indicator, you will never know where the program is going. Okay, like we give a 12th standard exam, we always know it's a 80% mila, 90% mila. If you just say, हाँ, pass ho gaya, it has no value. So QIs becomes very important in an AMS program. Then we'll have, excuse me, we'll have an AST reporting, brief about AST reporting, mainly the cascade reporting, synergy testing, and reflex testing. This is where the role of the microbiologist comes in, and rather than just reporting all the antibiotics you've tested, somewhere you need to put in the difference of what an MD microbiology person gives over a technician giving out the report. Okay. Then we will have an exercise of how to develop an AMSP program. So whatever you all have learned in these 4 or 5 lectures, we will be putting it all together, and you all will tell me how you all are going to develop the AMSP program. And then, excuse me, we have a panel discussion moderated by Dr. Piyush and all the speakers, where we will try and tackle a few things which have been left out, and then we'll answer your questions in that. Okay. Post lunch at about 2 o'clock, we would be having a group photo outside. So we'll also be having our top management coming in for the inauguration. So post the group photo, we'll have an inauguration for some time at around 2 o'clock. And we're already 15 minutes late. So probably this, instead of 1:45, this will be 2 o'clock. Antibiogram and antibiotic policy. More so, antibiogram is something that is totally in the microbiologist's domain. So you all need to know how to develop an antibiogram. So I would be briefly touching upon what the M39 CLSI guideline says about an antibiogram. And then we have something extremely important for every microbiologist. That is the WHONET. So we have Dr. Sangeeta Joshi, an expert on WHONET, who is going to talk us through this. I hope few of you have brought your laptops. Yes? Okay. Even if you've not brought your laptops, it's perfectly fine. Please try and understand how you can do it, because this is something that is extremely important for every microbiologist. Okay. Then again, we have an open discussion, and finally we'll wind up with the questionnaire and feedback. So you'll have, excuse me, you'll have 2 sessions, one at 12 o'clock, a panel discussion, and a second in the afternoon where you'll have a chance to ask all your questions. So please note it down in your notebook. Okay, and we can always have a discussion later. Okay, so welcome again to the workshop. Look forward to an interactive session, and hope you all leave the auditorium wiser than you all have come this morning. And one important announcement is no eatables and drinkables are allowed inside the auditorium. So please abide by that. Okay, thank you. Welcome, and I'll hand over to Pooja for the rest.
Thank you, sir, for introducing the workshop. Success is best when its shared teamwork turns individual efforts into collective achievements. Likewise, defeating superbugs is not a single man's job. You, being microbiologist, should know the role of microbiologist in AMSP, and for this, I will take your permission to invite our second speaker, Colonel Dr. Mahadevan Kumar sir. Dr. Mahadevan Kumar sir is a professor and lead microbiologist in AMSP at Bharati Vidyapit Medical College. He has expertise in AMSP and infection control. He has done WHO fellowship in antimicrobial resistance at Karolinska, Sweden. He has also completed Commonwealth Professional Fellowship in Clinical Microbiology and Infection Control in 2015. He established Antimicrobial Stewardship Program at Bharati Hospital in 2019. He has published around 59 articles and wrote 3 chapters of book. Today he will be sharing his insights on goals, importance and critical role of microbiologists in successful implementation and management of antimicrobial stewardship. Please join me in welcoming M. Kumar sir.
Good morning, everyone. I think we are together for the workshop after a long time, the national workshop, and this is the one of the pet subjects that I have come to like and grow with. And I'm glad to state that what I have established in Bharati Hospital is probably starting to show its effects. So better late than never. So let's start off. Today I'm supposed to speak about something on the role of microbiologist in antimicrobial stewardship. But before that, let me start with this. You may use some of these slides in your lectures when you start advising other people. This gentleman got the Nobel Prize in 1945, and that is the time he had commented during his acceptance speech that it may occur at one stage that a person buying it over the counter, as he called it, may underdose or overdose himself and create resistance. And we're already there. So this was the comment that he made during his acceptance speech. But it cannot be denied that modern medicine is built on access to effective antibiotics. But all said and done, there are some sobering thoughts. Earth is about 5 billion years old and the bacteria have been there for 4.5 of these. And we have been there for a very small, minuscule time. The bacteria are much more intelligent than us. Second point, infectious diseases are still the most common cause of death worldwide. Third point to remember, this has to be conveyed to the clinician. Antibiotics do not distinguish between beneficial and harmful bacteria. It is a blanket as far as antibiotic administration is concerned. And last but not the least, antibiotics do affect the environment as compared to other drugs that we consume. This is important to note. So this was the golden age of antibiotics, 1950 to 1970, following penicillin. They declared war against infection. About 50% of the antibiotics used were discovered during this time. And as usual, America put its foot into it. The Surgeon General famously claimed, we have won the war against infections. Let us move on to other diseases. So that's why you have lots of drugs coming up for obesity, hypertension, and all your lifestyle diseases. So infections went to the back seat. Unfortunately, the result was that our pipeline dried out, we can say. So after this golden period, as you see, the pipeline has hardly any hardly any drugs that were discovered during this time. It has come down to such an extent that there are just about a few drugs which are in the pipeline which have been approved or in phase 1 and phase 2. You can count these on your fingers, about 6 or 7 drugs only. So whatever molecule is being rehashed, it is a modification of the existing molecule and the bacteria promptly becomes resistant to it the moment it is used. The other part of the story is no new class of drug has been discovered till today, after 2010. And you have this timeline of antibiotic resistance. As you keep going through the antibiotics, you keep going through the resistance also. So that is where this 4.5 billion years becomes important. So the exposure to the antibiotics has to be controlled as far as the organisms are concerned. Then realize one more thing, where are we? We are here at the apex. We are the ones who are prescribing all the top-end antibiotics. If that is so, the problem is here in primary healthcare as well as the one who's boss the moment you move out 50 kilometers from the city. He's the boss. So India faces multifarious this kind of problems. The other issue comes in about India is supposed to be the breadbasket as far as generic antibiotics are concerned. Okhla, Najafgarh, maybe Nashik, everybody is manufacturing antibiotics. Everybody who's given a license is manufacturing antibiotics. And they are not taking care of the effluents. So these get into the environment. Another big contributor to the problem is our veterinary industry, where there is misuse of antibiotics. They use it as a growth promoter. They don't want to treat infections. They're using it as growth promoter. Mota chicken chahiye, that kind of thing. So that is where the other problem comes in, and all this creates resistant organisms which get into the human system. They come into the hospital. That is why you're finding so many ESBLs floating around now. That is the other problem. And as far as infections are concerned, Dr. Vikram mentioned just now that the number of deaths are expected to be around 10 million by the year 2050. And already when we look at the contribution of India, you find that deaths attributed to infection is more than the sub-Saharan Africa, or almost equal to sub-Saharan Africa, while in the rest of the Western countries, it is at a lower side. So that is why we require antimicrobial stewardship. So that means this is a precious resource that has been given to us. So when you start defining antimicrobial stewardship, there are various levels of definition given by various societies or institutions or organizations. WHO simply states a coherent set of actions which promote the responsible use of antimicrobials at a individual, national and global level. So that is what becomes important, and ICMR and IDSA also have given their definitions. But at the end of the day, it is going to be promoting the selection of optimal drug regime, dosing, duration of therapy and route that results in the best clinical outcomes for the treatment with minimal impact on subsequent resistance. That is what is important. So to briefly state, it is a coordinated program which promotes the appropriate use of antimicrobials, including antibiotics. Now, I have slightly shifted the terminology here. It is antimicrobials. So that means your antiparasitic, your antimalarials, your antitubercular also fall into this, antiviral also. How many of you have taken Fluvid at the first sight of a cold or prescribed? That is what is important. So Fluvid also will come into this category, because there are few drugs in the pipeline, as I already mentioned, and there is a need to conserve the existing drugs for the future generations to come. You have to improve patient outcomes, decrease the spread of infections caused by MDRs, and hopefully reduce microbial resistance in the long run. So these then translate into the goals of antimicrobial stewardship. First, but the best, is to achieve good therapeutic outcomes. It is not that by not giving cefuroxime or by giving meropenem you will have better effect. Maybe you could achieve it with even amoxiclav, but that is what is to be noted. A good therapeutic outcome is required, and reduce the drug adverse effects. To reduce treatment costs, a costlier antibiotic is always not very better than a cheaper antibiotic. So that has to be seen. Treatment costs have to be looked at, and prevent emergence of antimicrobial resistance. This I am repeating this slide again. So if you want to put it across to a layman, how will you call it? You will say, catch the right bug with the right drug at the right time for the right duration, and for the surgeons, right source control. You have a big abscess sitting somewhere, you can't keep pumping antibiotics, it will not penetrate inside the abscess, that we all know, and cause minimal harm to the patient. Simply put, right bug, right drug, right time, right duration, right source control, and minimal harm to patient. This is what is the essence of antimicrobial stewardship. And when you talk about the components, this becomes very important. Right at the top is your administrative support. If your administration is not with you, none of what you're going to say is going to have any effect on your so-called clientele. You have to have a team. It is not an individual who's going to do it. There is a team. I'll explain that subsequently. You have to have an infrastructure for the team, because there are certain data that you have to collect, data you have to present, so your infrastructure has to be there in place. An important thing is your antimicrobial policy for the institution. Antimicrobial policy cannot be decided as a general measure. It has to be kind of institution specific. So that means your antibiotic policy, what you create in a hospital, cannot be utilized for another hospital, because the resistance patterns may differ or the utilization patterns may differ. It has to be kind of customized. You have to follow a stewardship strategy. There are two types, as we must have already learned. One is formulary restriction, where tomorrow I publish something in the hospital and say meropenem will not be used without permission. So that means meropenem cannot be sourced from your pharmacy unless your HOD or a consultant who has been given the authority to sanctions it. The second method is prospective audit and feedback. There are advantages and disadvantages to both. Formulary restriction apparently creates problems for the clinician, where clinician autonomy is a problem. While in the case of prospective audit and feedback, maybe the compliance to the advice that is given. When you look at the antibiotic prescription and about 2-3 days later you audit it and then tell the clinician based on your culture results or something like that, it becomes a problem trying to convince the clinician to de-escalate or stop the antibiotic. So both have their advantages and disadvantages. So as a microbiologist, what can we do? First, and the best or the must, standardize your laboratory. Standardize your laboratory meaning get your quality control in place. Look at the automated instruments that you can use because that will shorten your reporting times. You have to quality control your culture and susceptibility reporting. And try and convince your administration that microbiology is not like biochemistry. If I put it in vernacular so-called Hindi language, कि machine में डाला, report निकल गया, sign कर दिया, खत्म biochemistry. Nobody will question it subsequently because the quality control is of a different nature there. You're running your quality control every day. Here we are dealing with live bacteria. Live bacteria will not behave the same way as chemicals. Secondly, the machines, after all, have been created by human beings. It's a question of GIGO. What is GIGO? In IT terminology, garbage in, garbage out. So if you have put in something wrong, it is going to give out garbage. That garbage cannot be taken as golden standard or the truth. That is where the role of the microbiologist comes in to sift what result has come. Is it worth reporting? Am I reporting to an odd organism in a sample which is not supposed to be there? Let's say, for example, you get coagulase negative streptococcus in a blood culture. So you have to now get back to the patient to see whether the patient is actually having an infection because of coagulase negative streptococcus. That's usually a skin commensal. So if you just report the skin commensal, the clinician is going to pick it up and say, you have given me the organism, I'm going to treat the patient. So that thing cannot be achieved if it is an automated kind of thing and everything goes into the HIS and it is seen by the clinician straight away without the microbiologist getting in between. Next comes the concept of diagnostic stewardship. Now, diagnostic stewardship assumes importance here because of this cycle that we look at when we are going to diagnose infections in a patient. So you have a patient, there's a clinical evaluation which happens and a sample is supposed to be sent. This is where a microbiologist can get to order the right test for the right patient at the right time. Golden hour of sepsis is first hour. So antibiotic has to go in. But the priority should be while you are setting up the antibiotic there, take the blood culture. This advice can be given by the microbiologist if he goes down to the clinician, tells him that it is important, yes, to give the antibiotic first, but at the same time, please take a blood culture so that the antibiotic that you have administered will generally render the culture maybe negative. So you will again be treating empirically. That empirical antibiotic can never be then de-escalated. So this becomes important. I'm just giving you an example of blood culture. There are other samples also which require to be taken invariably before administration of antibiotics. That becomes one golden point. Then when the diagnostic test is ordered, the microbiology lab then comes in that your quality control testing is done so that you can output useful result to the clinician. Then comes your right interpretation, the right antimicrobial at the right time. So that means empiric antibiotic has been started before the diagnosis starts. Once the diagnosis is complete, then you can advise the de-escalation or correct choice of antibiotic. Then you complete the cycle so that the patient is benefited. That is where your diagnostic stewardship comes in. So you would provide guidance on accurate, reliable diagnostic testing. Get rapid diagnostic tests which can be utilized for the patient's benefit. Any example somebody can give me of a rapid diagnostic test in infection? Yes, absolutely right. And in fact, people have gone ahead and maybe right now the cost is slightly high. They are able to do a sepsis assay from 3 ml of peripheral blood itself instead of putting it into a culture bottle. But that will take time to come. And this here also we are talking about the metros. But automated blood cultures, the systems are percolating down to even secondary level hospitals. So that is where we have to take advantage of this. Another thing which I would advocate here is test for respiratory pathogens, because respiratory pathogens mostly they are viral depending upon the season. So if you're able to catch a viral pathogen, you can easily ask the clinician to stop the antibiotic. That is what becomes important. So your respiratory panel PCR also will come helpful in this kind of situation. Next, as an and a microbiologist, we have those panels which are recommended by CLSI, whether it is disk-based testing or it is automated card-based testing. There is no compulsion to release all the antibiotics as a cafeteria method. What is a cafeteria method? Like we had a buffet today morning, one could pick up sandwiches or one could pick up poha depending upon what I was feeling like having that day. Please do not make microbiology AST reporting like this. It has to have the recommendations of CLSA followed, where groups have been group A, group B, group C has been described. So report your antibiotics accordingly. And that is where the knowledge of the patient's condition becomes important. It is not reporting that test itself. It is reporting that test in combination with the patient's status. So you should have an idea what the patient is admitted for, what is the situation for which the sample has been taken, and do we require to report the highest antibiotic that is required. So accordingly, a cascaded reporting can be done, and in case there is a problem, it can always be released subsequently. So release the minimum number of required antibiotics for that situation. You will be doing much better off. And then subsequently, after implementation of this cascaded reporting, you should review the prescribing to ensure that there are no unintended consequences. So that means everybody will not understand what is cascaded reporting. They might have a confusion. So that has to be sorted out by the microbiologist. Get into the habit of sending alerts for multi-drug resistant pathogens. So any of you working in NABL accredited labs? Yeah. Can anybody tell me what is an alert? Forget about microbiology. Generally, what is an alert regarding a report? Something which will affect the patient's treatment. It is a critical report, right? So that is what is an alert. Alert usually is more applicable in biochemistry, where small differences in, let us say, potassium, for example, may make a difference to the patient. It will be life-threatening. So likewise, as he mentioned, there could be a critical pathogen which is being isolated. So especially in the case of, let us say, blood culture, if a blood culture is flagged, you do a direct smear and then try and tell the clinician what you are seeing on the direct smear so that the antibiotic can be tailored at that stage itself. It is started to be tailored till you get the AST result subsequently. Second alert is for outbreaks. There are 2 or 3 patients in that time frame who are having a similar organism with a similar resistant. That should ring the bell, and possibly infection control should also be activated. That is where you try and prevent the spread of these multi-drug resistant organisms, prevent further outbreaks from occurring. Bottom, clear communication line with the clinician. Get friendly with your clinician. Do not sit inside the lab. That's I keep advising. My habit in my hospital is to go for my bench round, as I call it, in the morning. 9:30 to, let's say, 10:30, I'm reporting. I decide whatever I mentioned just now as to where the patient was, where the patient is likely to be later, what is he being treated with, and then correlate it with what culture has come positive. Subsequently, from 10 o'clock or let's say 11 o'clock onwards to 1 o'clock, I am in the wards, roaming around looking at the patients, along with the results that I have generated, or maybe half the results have been generated. Along with that, I go and look what antibiotic is being administered, does the patient require antibiotics or not, and then talk to the concerned clinician and advise him accordingly that this is what is being processed in the lab, this is what is the result which has come up, can we de-escalate, can we escalate, because escalation is also an issue. Then the next thing what Dr. Vikram mentioned, we'll be learning about it subsequently also, preparation of an antibiogram. Now antibiogram has got 2 connotations. In one connotation, the daily AST that you take out of a single organism is also called an antibiogram. Otherwise, you should be calling it a cumulative antibiogram of all the organisms that have been isolated in the past, let us say, 1 year. So the antibiogram generally, you can do it in 6 months or you can do it in 1 year. 1 year is a better bet because it gives you statistically significant number of organisms to be included in the antibiogram. When I say statistically significant, WHO has laid down that it should be at least 30 organisms or 30 strains of, let us say, staphylococcus for the AST or the antibiogram to be generated. Why does that happen? Because a crude example is there are 10 staphylococci, out of which 5 are MRSA. I have 50% MRSA in my unit. Is that right? 10 strains do not make sense. At least 30 are required to become statistically significant. So when you generate that antibiogram, you then incorporate that into your antimicrobial policy. Now, again, this was mentioned in the introduction, that the antimicrobial policy is an important document which decides what antibiotic or how antibiotic is to be administered to patients in an empiric fashion. Empiric means, what is empiric, anybody? We keep talking about empiric. What is empiric? Empiric is just out of experience. So this also you have to convey that empiric is only limited to the first 48 to 72 hours till the culture results are available. Once the culture results are available, then the empiric is thrown out and the definitive treatment starts. That definitive treatment has to be insisted upon, because we have had situations where you get calls from clinicians and say, I've already started meropenem, you have not given me the sensitivity for meropenem. That is where you would like to go and convey to them that if the susceptibility of meropenem has been suppressed, that means there are some antibiotics down the line which can be easily de-escalated to. And that also depends upon the situation. Sometimes you may have to continue with meropenem, that's a different thing. But that call has to be taken unless you know the patient, you cannot take that call. You cannot just blindly protocolize it. So we have been running this policy for the last about 10 years now. That is, it is running in its 10th version. And the policy contains the last year's isolates, as I mentioned, from each area. So I have kind of divided it into various units. So various units, it becomes important because giving an overall situation inside the hospital does not make sense. There could be a difference in the susceptibility pattern or isolation rates between medicine and surgery, between ICU, between medical ICU and surgical ICU. So you may have to stratify the antibiogram accordingly. So in addition to the isolates, try and create an antibiogram. Now this might look a slightly busy slide, but to make it easy to understand, look at the right side. These are the restricted antibiotics in red. So these will not be used unless the senior most person in the unit concurs or the situation demands based on AST. The general antibiotics in this portion, if you see, these are the ones which can be used without any problem. But when you see the coding, look at many of these pinks. These are antibiotics which will be useless. While the ones in the yellow and green can be used. Yellow, you may have lesser efficacy, and green is you will have 100% efficacy. So that is where we have landed ourselves up. You see generally the greens are here, which are the BLBLIs. Your third generation cephalosporins are generally useless when you talk about empiric therapy. That is the situation we have landed up in. But then yes, it is not too bad. But we have to preserve these red colored antibiotics. So participating in clinical rounds, where there are single microbiologists available, it may be a difficult task, but then as they say, catch the low hanging fruit first. So whichever clinician you find friendly or whichever department you find friendly, start with that department. Start taking rounds. Maybe you cannot match your timing with the round of the clinician. Take an independent round and communicate with the clinician that this is what I have seen. It's not that we have come into the microbiology lab, we forget our clinical acumen. We have been taught, as far as when we were in MBBS, that how to examine a patient, how to recognize certain things, and you are the ones who are trying to explain how to interpret lab investigations. So you are at the best place to kind of correlate. So please go and see the patient. Please go and examine the patient. Where there is a problem, the case notes are available. Now, if you point out that the case notes are incomplete, at least it will be an incentive for the clinician to complete case notes in a proper fashion. That becomes important. Coordinate with the AMS team for appropriate use of antimicrobials that I keep on mentioning. And in this case, I keep calling it AMS team, but I am the AMS team as far as my hospital is concerned. So I have to kind of encourage my team to go out and discuss with the clinician. Never leave out on this. Educate, train healthcare professionals on infection control and antimicrobial usage. And I mentioned this infection control here because these are two sides of the same coin. Without speaking of infection control, do not speak of stewardship. Without speaking of stewardship, do not speak of infection control. They cannot be independent. They have to survive together. So at the end of the day, you're going to rationalize. So when you say shorter duration of therapy, go back to Harrison. Harrison has mentioned certain situations, clinical situations where longer duration of therapy was studied and papers have been published where they have said shorter duration as compared to longer duration is equally effective. Liberal use of procalcitonin and CRP for guiding the de-escalation of therapy. So procalcitonin, especially when you do a serial procalcitonin, if there is a drop in procalcitonin, that says you can easily stop the therapy or de-escalate it. Similarly, CRP can also be used. The cost differential makes a problem at times in certain hospitals. The other part which I find here is overlapping spectrum. Any example? Commonly, people tend to give piptaz and metronidazole together. They have overlapping anaerobic activity. All penicillins have excellent anaerobic activity. No point adding on metronidazole. Ineffective antimicrobial. There are places where I have seen nitrofurantoin being used in pus because it is given in the AST. So that is where the role of the microbiologist also comes in, that if you are releasing a pus report, do not release nitrofurantoin, suppress it. It is meant only for urine. Let us say redundant antimicrobial or irrational combination. Any irrational combination somebody can say, which is not recommended by WHO, but then it is available, so people are prescribing. Example, Oflox, ornidazole. Favorite, O2. Oh, liquid oxygen wala kahani. Somebody knows? Ajit's famous dialogue, इसको liquid oxygen में डाल दो. Liquid इसे जीने नहीं देगा, oxygen इसे मरने नहीं देगा. So ofloxacin will take care of the bacteria and ornidazole will take care of the amoeba. So you are happy. Patient is also happy. Contribute your data to the National Resistance Surveillance Network. We have woken up after a long time, yes, but we are heavily into it. 2017, we had the National Action Plan on Antimicrobial Resistance, and we have this national network now with regional centers. So try and identify your own regional center. Like for example, in Maharashtra, it is GMC Aurangabad, which is the regional center for collecting the antimicrobial resistance data. So whatever you are generating from your data, you're putting it into WHO Net software, which will be taught today by Dr. Joshi, and then send this data across to the collecting center, which in turn is submitted to the national network. And from the national network, it goes to the GLASS. Who knows what is GLASS? Global Antimicrobial Surveillance System, Resistance Surveillance System, that is GLASS. So this data then helps us focus on where action has to be taken. So this becomes important. Put this up everywhere. Whether there is infection control or not, let this be done. This 5 moments of hand hygiene, you can also promote it, because in our hospital, the microbiologist is in charge of the infection control. So in most of the hospitals, microbiologists are doing it. So make this your mantra. Let this be propagated right through, so that this can be explained that at least 30 to 50% of all healthcare associated infections are associated with these 5 patient care procedures. So if you are careful and tell the people accordingly, we can try and bring down infection. As I mentioned again, teamwork. So I put this at top here since I'm doing the work in my hospital. May not be it is at the top. Somewhere around the ID specialist will be on top. Dr. Piyush is here. He's leading his team in this hospital. Another important component of this is the clinical pharmacist. It is not a B Pharm or a D Pharm. It is a Pharm D. There's a new degree which has come up. There's a 6-year course, a 5-year plus an internship. Most universities have tried to bring it in. And they are on the equivalent of, you can say, like a physiotherapist. They do an internship, so they also have a prefix of doctor. Now, these are the people who are now the backbone of my AMSP team, who are in the wards looking at 2 things. One is audit and feedback. That means within those 3 days that the antibiotic has been empirically started, they note the information, note the clinical details, and start putting it onto an Excel sheet. Subsequently, when the culture result is available, they are the ones who are seeing whether the antibiotic has been de-escalated or escalated. At the same time, they're looking at the dosing also. For example, dosing, when you talk about the latest about carbapenems, is a prolonged infusion. Never to give carbapenems as a short infusion, always 3 hours or more. So that is being monitored by our clinical pharmacists. And this has got into the system, so it's automatically going in. So nurses have been brought in. That is where your cross consultation, when I say with other specialties, this includes nursing also. So that is where you have to teach the nurses, because they are the ones who are on ground going to do it. Small example, fosfomycin sachet. How much is it given? Anybody about the dosage of fosfomycin? One sachet. Sometimes it is repeated after 3 days. So the clinician has clearly written one sachet today and one after 3 days, and that day the sachet has gone 3 times. So this has to be caught. So transcription, there was no problem, but the administration error was there. That is where your clinical pharmacist is going to help you. Then you have your antimicrobial champions from each department. It is not that all clinicians are unfriendly. Some clinicians are very friendly, so you have to pick them out. Make them the champions in their department. So because a clinician giving an advice to a clinician is probably more acceptable than a microbiologist at this stage, before we have become clinical microbiologists. None of us are clinical microbiologists at the moment. So in future, when we become actual clinical microbiologists, we are involved in treating the patient, that is when a clinician will accept your advice completely. So till that time, you have these antimicrobial champions helping you out. This becomes important. Infection control team and CSSD are an integral part of your AMSP, so do not lose them out. And you monitor. This will all be talked about subsequently when you set up the program. I'm just giving it as an introduction here. So you monitor adherence to the antimicrobial policy that you have set out. You can monitor usage by either daily defined dosage or duration of therapy. Duration of therapy is good for the institution because DDD is more of a procurement or a prescription related thing, which may not be true. It may not be applicable to pediatric dosing. So that is where duration of therapy can be slightly better when you're tracking antibiotic usage in your hospital. You can look at the clinical outcome. You can look at the financial outcome as to how much was the contribution of this antibiotic to the total cost of the patient. And this is a long-term thing which cannot be at a short notice. If somebody says the resistance is reduced, I will not believe it because we are not islands. We keep getting patients from outside. So never your antibiogram can reflect your reduced antimicrobial resistance unless you want to exactly cascade it. So I will leave you with this. Who remembers which movie is this? Diwar, absolutely. What was the dialogue? मेरे पास गाड़ी है, बंगला है, नौकर चाकर है, तुम्हारे पास क्या है? So our doctor sir says, मेरे पास antibiotics है. So this has to be conveyed. Antibiotic is not a panacea. It is not a panacea. So you have to conduct these in your hospital. Reach out. Try and reach out to patients also, patients and relatives also, because there's a lot of patient psychology which is involved. Like in my own hospital, clinicians say, sir, वो admit हो रहा है, उसको कुछ तो देना है. That compulsion comes from the patient. In fact, earlier they used to say, vitamin B लगा दो, वो yellow का कुछ जाएगा, at least patient psychology is satisfied. Maybe now we are using metronidazole because of that. So that is where WHO has given the theme for this year, which is educate, advocate, and act now. Otherwise, we'll end up losing it. Let us prevent antimicrobial resistance together. And just a point from my side, we have been having this program for the last 5 years in the hospital. So the university projected it as a best practice during our NAC assessment. And I was asked to present in front of the assessors, and they appreciated it quite a bit. And thanks to that, probably we have got our accreditation of A++ this year in the 4th cycle. That is the highest. Thank you. So any questions, please note it down. We'll tackle it later.
Thank you, sir, for guiding us and awakening us regarding our roles as microbiologists in antimicrobial stewardship. So remember, microbiologists are the key for effective stewardship. Now I want to introduce our next speaker, Dr. Pooja Shah, sir, who will be presenting us on the fundamental aspect of antibiotics, including their various classes, as well as key principles of pharmacokinetics and pharmacodynamics. Dr. Pooja Shah, sir, is a gold medalist in DNB medicine from Bhagwan Mahavir Jain Hospital, Bangalore, and has done fellowship in infectious diseases and HIV medicine. He has 32 publications. He is also a principal investigator for 9 clinical trials. His areas of interest include antimicrobial stewardship, pyrexia of unknown origin, drug resistance TB, HIV medicine, prosthetic and joint replacement related infections, travel medicine, adult immunization, and tropical diseases. His today's talk will provide us valuable insights on how antibiotics work, their effects on the body, and the crucial role these concepts play in treating the infections effectively. So please join me in welcoming Dr. Piyush sir.
Good morning, everyone. I think the context is nicely said by Dr. Kumar's talk on MSP. I, at the outset, would like to thank the organizers of Microcon 2024 and especially Dr. Vikram and Dr. Pooja for giving me this opportunity and for the kind introduction. So, my first and foremost, one disclaimer or rather acceptance would be that I know less microbiology than everybody else sitting in this auditorium right now. Okay, so because I'm not a microbiologist, I'm from medicine background, but in discussing the classes of antibiotics with respect to their mechanisms of actions, resistance mechanisms, and PKPD, the main purpose is to see how we can apply the basic knowledge of microbiology, pharmacology, and clinical medicine together in improving the patient outcomes, because as we see in medical schools, a lot of these things are already taught to us in second year MBBS itself, when the person doesn't know where they are going to apply it in future, and by the time the patient a person comes to final MBBS, half the things are already forgotten, because we just sort of ratify that just to clear our second year exams, and by the time they do MD medicine, 90% of the things are forgotten, and those 90% things, unfortunately, but most clinicians are later on learned from medical representatives bringing new molecules in the market, who are more into sales rather than into medical field. So I'll just briefly try to connect how we can apply these mechanisms of resistance, action, and PKPD for better use of antibiotics to improve clinical outcomes and as a mode of antimicrobial stewardship. So, in the beginning, I'll be discussing about classifications of antibiotics and their mechanism of action in brief, then how it can be used clinically for AMSP, similar with mechanisms of resistance, and under PKPD, rather than just discussing the PKPD indices like AUC by MIC, Cmax above MIC, or time above MIC, and all that, we would also be discussing about how we can minimize the resistance selection, how we can minimize the toxicities, then important aspect of penetration at the site of infection rather than just having in vitro susceptibility, and dosing in special situations like renal dysfunctions, hepatic dysfunctions, elderly people, people who are on multiple medicines, etc. So starting with the classification, I have not done it extensively. We'll just briefly touch upon the important classes. So most important has to be beta lactams. I mean the earliest antibiotics and the longest used antibiotics, and also if not for allergies and resistance, perhaps the most efficacious and most well tolerated group of antibiotics, which are essentially cell wall active agents, as we'll see later on. Then next is again another group which acts predominantly on the cell walls, so glycopeptides and lipoglycopeptides like vancomycin, teicoplanin. Then we go inside the cell at the ribosomal levels, so where we have aminoglycosides, macrolides. Then we have tetracyclines, okay, which act on 30S and 50S ribosomes respectively. Then we go to fluoroquinolones, which act on your say gyrase A and topoisomerase 4 enzymes. Again, sulfonamides, trimethoprim, which act on as an anti-metabolite, interfering with the folate metabolism in the bacteria. Then you have oxazolidinones like linezolid, which is again essentially mitochondrial effect. Cyclic lipopeptides like daptomycin, polymyxin B and E, which is colistin, which are mainly with the cell membranes, their action, and imidazoles like metronidazole. I might have missed a few, but these are the most commonly used routine names, and chloramphenicol, of course. So if we put all the mechanisms action in one slide, then at the top we have cell wall synthesis inhibitors, where most of our beta lactams and vancomycins and bacitracin, penicillin, all these things come. Then the ones which act on cell wall integrity are essentially beta lactamase inhibitors. Then DNA synthesis, metronidazole, DNA gyrase inhibitor, quinolones. Then down here we have 50S inhibitors like erythromycin, chloramphenicol, clindamycin, and linezolid. 30S tetracycline and streptogramins, and cytoplasmic membrane, as I told, polymyxin B, colistin, and daptomycin. Now, beta lactam structure: penicillins, cephalosporins, carbapenems, and monobactams. All of us are quite well versed with from our second MBBS. The basic differences are just in the changes in the side rings. The core beta-lactam ring remains same in all these four groups. Briefly, I'll tell how beta-lactams act because that is the commonest used class of antibiotics. So basically, we have this N-acetyl-muramic acid and glycosamine dipeptide chains which bind through the glycine side chains with the help of penicillin binding protein, to which the beta-lactam attaches and doesn't allow this binding of two dipeptide side chains. That's how it inhibits the formation of cell wall. So now, after seeing these mechanisms in brief, we'll see how they can be used clinically or as a tool for better use of antibiotics through MSP. So first and foremost is targeted therapy. So like Dr. Kumar had mentioned in his talk, that we should avoid duplication of cover. So two antibiotics providing same kind of cover. So that can be avoided if we know the exact mechanism of action and the spectrum of a particular class of antibiotics. We can remove ineffective antibiotic, like say for example he was mentioning community acquired pneumonias or respiratory infections. So nowadays with the advent of various PCR platforms, we are most often than not able to catch the viruses or the atypical pathogens like mycoplasma, which currently I think last couple of months everywhere we are seeing a lot of cases of mycoplasma. So if we sort of say empirically start the patient on something like a third generation cephalosporin with an atypical cover with a macrolide or say doxycycline, and a day later we know that mycoplasma is isolated, we should make an effort to stop that beta lactam, which will be cephalosporin, or in less severe cases maybe amoxicillin clavulinate. Then use of synergistic combination wherever indicated, that we'll discuss where. So this I think you all know better than me, the difference in cell wall structures of gram positives and gram negative organisms, and therefore even the cell wall synthesis inhibitors, they have different spectrum of efficacy against gram positive versus gram negatives. Like even taking examples of cephalosporins, as we go from class 1 towards 4, the gram positive coverage goes on decreasing and the gram negative coverage goes on improving, with the exception of drugs like cefepime or the fifth generation cephalosporin like a ceftaroline, which has more of a gram positive cover. So if we see antibiotics with excellent and modest gram positive cover, so here we have most of the beta lactams, extended spectrum penicillins, even carbapenems, mainly IMI would be slightly better than meropenem here, ertapenem not so much of course. Then glycopeptides like your Vanco, Tico, then linezolid, daptomycin, and also so many of these other agents like macrolides, tetracyclines, clindamycin, sulfa drugs like sulfonamide, trimethoprim combination, all of which although will be predominantly static when it comes to something like a MRSA infection, but they can be very much used as a step down therapy, especially if we use it in combination. So especially in situations like say osteomyelitis or a septic arthritis where you require prolonged therapy. So initial aggressive treatment can be given with a sidal antibiotic in injectable form, and it can be stepped down to a combination of two oral agents from these classes depending upon the sensitivity report. Now moving to gram negative activity, again carbapenems, monobactams, third, fourth, fifth generation cephalosporins, extended spectrum penicillins like piperacillin with tazobactam. All these things have excellent gram negative effect. And again you have macrolides, tetracycline, sulfur drugs and quinolones whenever sensitive. Now what is more important than these two slides is this, like was mentioned in the previous talk, that most of these two groups like extended spectrum penicillins like piperacillin, then your amino penicillins like ampicillin, carbapenems like meropenem, they all have excellent anaerobic cover except perhaps for bacteroids, so which again is a specific problem with intra-abdominal infections, that too in the first 3 to 5 days. So beyond that period there is no role for giving an separate anaerobic cover with metronidazole if the patient is on piperacillin, tazobactam or meropenem or imipenem, which all have excellent anaerobic cover. Now we'll see what damage metronidazole does. I mean, it's not such a benign thing as it is thought to be. I mean, and the damage is far more than just the metallic taste that the patient develops. Again, even other classes of antibiotics also have moderate activity against anaerobes. So again, if one of these is there in the treatment, then anaerobic cover is not required. Then talking of atypical pathogens, so just now like I mentioned, if mycoplasma is isolated, so it lacks cell wall. So any agent which is cell wall active should be omitted the moment you diagnose mycoplasma as the underlying cause of community acquired pneumonia. And it is a fairly common cause of community acquired pneumonia. If we leave aside pneumococcus, then amongst the atypical ones, this is one of the commonest. Okay, then next is organisms like Rickettsia, which are essentially intracellular organisms. So this microbiology knowledge we can apply while choosing empiric treatment. So if you like in and around Pune district, we see a lot of rickettsial infections. In many parts of interior of Maharashtra also rickettsial infections are very common. So during monsoon period, if you are suspecting say tropical infection and you have reliably ruled out something like salmonella through cultures, then there is no point giving beta lactams in such patients, because see amongst the tropical ones we are left with either the viruses like dengue, chikungunya, zika and all flus and all those things, or on the other side you have salmonella, rickettsia and occasional cases of leptospirosis, which are typically post floods and waterlogging and in certain professional groups. So amongst all these except salmonella, none of those requires beta lactams. Maybe yes, severe lepto also would require, but otherwise doxycycline would be sufficient for most of these tropical infections. So again there a double cover of a beta lactam like a third generation cephalosporin with doxycycline should be avoided. Then there are certain specific targets like say sulfonamides. It specifically is toxic only to bacteria because this DHPS is not there in the mammalian cells. So that's a selective toxicity only for bacteria. Aminoglycosides, again they act mainly on the 30S ribosome. So here the entry is dependent on oxygen dependent transporter. So any anaerobic organism is not covered by aminoglycoside. So if there is a scenario like an complicated intra-abdominal infection where you are giving aminoglycosides, then that is one scenario where we should add another agent which has good anaerobic cover. If it is a beta lactam or a carbapenem, then that is not required. But with these actions also come toxicities. So because aminoglycosides act mainly at the ribosomal level, so there is selective targeting of proximal renal tubules leading to nephrotoxicity, and plus they also have impact on free radical formation in the ear cells, which leads to ototoxicity. Again, amongst different aminoglycosides, some are more nephrotoxic than others and some are more ototoxic than others, like kanamycin, amikacin are perhaps more ototoxic. Similarly, because linezolid acts on the mitochondrial level, so when a patient is on linezolid, we should suspect and keep monitoring for any mitochondrial toxicities. So what are these toxicities? So they can have lactic acidosis, which can be at times fatal, neuropathy, optic neuropathy. So peripheral as well as optic neuropathy. So all these things should be monitored on persons who are on linezolid. This is more relevant nowadays with increasing MDR TB, where we have these longer oral regimens which starts with 600 milligrams of linezolid. And if you see our NTEP program, National Tuberculosis Elimination Program, so they recommend that after the initial 6 months where bedaquiline is done with, linezolid dose is reduced to 300 mg. That is because there all these mitochondrial toxicities or myelosuppression leading to cytopenias is far more common the longer we give linezolid for. And in spite of that, with this 18-month longer oral regimen, many people still end up developing peripheral neuropathy or cytopenias with linezolid, even with 300 milligrams dose. Then with the common mechanism of action also comes common mechanisms of resistance. So there can be class resistance like we see in say cephalosporins, where ESBLs or carbapenem resistance can make most of the beta lactams ineffective. Then there is class resistance like in macrolides. So if we speak with anybody who's treating mycoplasma this year, they would say that most of the mycoplasma are not responsive to macrolides this time. Whereas if you switch from your azithromycin, clarithromycin to doxycycline, the patients are responding quite well. We've also had quite a few of these patients this year, which could be because maybe around and post COVID period, azithromycin and clarithromycin has been used like water almost. I mean, any cough, cold and sneezing, even if allergic, people are taking azithromycin. So naturally macrolides are getting resistant because of that. CRS, we all know almost all beta lactams will be rendered ineffective with it. So in such cases, antibiotics which have different mechanism of action than the one which has become resistant should be chosen. So that's another reason why we should be aware of how each class of antibiotic acts. Now this again was mentioned in the previous talk, that Sir Alexander Fleming in his Nobel Prize acceptance speech, that time itself almost 80 years back, had warned us that inappropriate use of antibiotics will lead to resistance. So coming to resistance, we all know it can be intrinsic or acquired. Amongst the acquired, we again have chromosomal mediated or extra chromosomal. Now this chart tells us that bada hai to behtar is not true when it comes to antibiotic. Each class of antibiotic, including the topmost spectrum in terms of resistance for gram negatives, like say polymyxins, they are also inherently resistant to certain set of organisms. Similarly, on the gram positive side, even something like vancomycin, teicoplanin, daptomycin, they are also inherently resistant to certain other types of microorganisms. So this essentially helps us in two places. One is, if some sepsis patient has initially improved on a particular treatment and then developed fever after a gap of few days. Like recently, we had one patient who was being treated with colistin and minocycline for carbapenem resistant Acinetobacter lung infection after a prolonged ICU stay. After she was shifted back to ward, after a 4 or 5 days ephemeral period, she started spiking fever. So there, when the patient is on colistin, looking at this chart, I would know that there could be selection of one of these organisms, which is leading to the second sepsis, either through hospital acquired infection or otherwise. And as expected, she grew Serratia marcescens in her blood cultures. So this is relevant there, that the resistant organisms can be selected when all the sensitive ones are taken care of by the antibiotic which is working on them. Again, acquired resistance, it could be because of antibiotic inactivation, target site alteration, antibiotic efflux, or decreased permeability through loss of porine channels. So talking of antibiotic inactivation, this could be because of inactivating enzymes, which basically either hydrolyze and break down the antibiotic, or they alter the antibiotic structure, which prevents their binding with the target site. Coming to specific enzymes, we have most important beta lactamases. I think in the next talk we are going to listen a lot about MDROs, XDROs and all. So I'll not go into the details of all your amylar classification and all those things. Then we also have similar enzymes leading to antibiotic inactivation when it comes to aminoglycosides and chloramphenicol. So this classification I will not go in detail with, because I think Dr. Priya ma'am will be covering it in her next talk. This was once a time when we used to make such a chart to derive likely mechanism. We have come a long way from here with the advent of molecular diagnostics and detection of resistant mutants. So that again would be taken care of in the next this thing. Then the second mechanism is modification of the target site. So as we can see here, if there is alteration of the binding site, then again antibiotic is not able to bind that target site, and that leads to resistance. So this is with the ribosomal target. This mechanism can be seen for macrolides, tetracyclines, linezolid, aminoglycosides, or rifampicin. With the cell wall targets, it is the mechanism for VREs and VRSs. With the target enzymes, it could be a mechanism of resistance through penicillin binding proteins, or in cases of quinolones. And with overproduction of targets, which overwhelms the amount of antibiotic at the site of infection, that is a mechanism for resistance to sulfonamides. Then next is induction of efflux pumps. Now this is one of the very important factors, which is through collateral damage that these antibiotics cause. Like somebody who is exposed to something like quinolones. I mean, you all would be familiar with the story of called Dombivli fever in the late 80s or early 90s, with Salmonella typhi or enteric fever being extremely common in Dombivli region. So in these early 90s, pharma companies came up with quinolones, and they started promoting that this is a synthetic molecule, unlike the beta lactams which were derived from natural fungi. So the way beta lactams become resistant, this will not become resistant. That was the initial promotion 30 years back. But now we know that these quinolones not only induce efflux pumps which lead to their own resistance, but these efflux pumps also give cross resistance to carbapenems. Similarly, metronidazole exposure can give cross resistance to azole antifungals. So in fact, this is worse. with these synthetic molecules, they not only give resistance to their own class of antibiotics, but they can render some other entirely unrelated class also resistant. So that is very common with when it comes to something like a pseudomonas. Then decreased permeability to loss of porine channels. So this is mainly with respect to again pseudomonas, acinetobacter and imipenem resistant with mutations like OPRD and all that, which decrease the cell wall permeability. Then other acquired resistance specific to certain groups are for folate antagonist, daptomycin, where there is alteration of membrane potentials, thickening of cell wall. Again, this is very important for the MIC creep in Staph aureus or for the visas, where there is thickening of the cell wall, and that's why the antibiotic gets trapped there, and we have to use agents other than glycopeptides over there. So this will be anyway discussed in the next class. So how this mechanism of resistance can be applied to AMSP or to clinical practice. Again, like with cases of mechanism of action, we can have targeted therapy. So if you have ESBLs, then you can use BL-BLI combinations or carbapenems, we all know. CREs, again we have to go to novel BL-BLIs like say ceftazidime avibactam or aztreonam avibactam whenever it becomes available. Polymyxins, tigecycline, fosfomycin, etc. in various combinations depending upon which type of carbapenemase enzyme we have isolated or which mechanism of carbapenem resistance has been isolated. Again, MRSA, glycopeptides, linezolid or dapto can be used, or a specific beta lactam like a ceftaroline can be used over beta lactams. VREs, again here there is alteration of the cell wall target site in the DLR to DLR D-lactate. So this reduces vancomycin binding, but still agents which act differently like linezolid, daptomycin or novel agents like dalbavancin, which are now very much available in India, they can be used in these organisms. Efflux pumps, use of non-substrate antibiotics, so antibiotics which are not thrown out of the bacterial cell wall by these efflux pumps, they can be used. Porine channel loss, again polymyxins or synergistic combinations can be used. Now here with these two mechanisms, we sometimes see discordance between meropenem and imipenem. Like if there are no carbapenemases and there is predominantly efflux pumps, then the chance of meropenem being resistant is more than imipenem being resistant. Whereas with the porine channel loss, there is a higher incidence of imipenem resistance than meropenem resistance. So that way, knowing the underlying mechanism, we can still use another antibiotic from same group if there is no carbapenemases. So therefore, it's very important to know which type of mechanism is in play in that particular patient. Then other is to use personalized therapy, because nowadays all patients are going at n number of places, and it is not like say maybe 20-30 years back that a person coming to tertiary care from primary or secondary care wouldn't have received a higher antibiotic. I mean, we already are getting, once the patent got over, we already have patients coming to tertiary care having already taken ceftazidime avibactam. Forget about meropenem. Meropenem, though, last 10 years is used like water. Piperacillin tazobactam is already resistant in almost 70% of the isolates in gram negatives or Enterobacteriaceae mainly. So prior history of antibiotic exposure. So actually most of the hospitals which have a culture form, they have these columns for risk of MDROs. So whether the patient was hospitalized in last 90 days, any antibiotics were received, whether the patient is a dialysis recipient, a patient who is visiting a daycare center for chemotherapy, somebody who has indwelling devices. So all these things which increase risk of having MDROs, they are there on that form. So additionally, we can have a dialogue with the treating team or can access the patient's file directly and see what antibiotics the patient was exposed to in the past. Like say if I isolate say pseudomonas in a say patient with some implant related or implantable device related infection, and the patient on OPD basis has received quinolone, I'll be skeptical about carbapenems also till I don't document susceptibility because of that issue with induction of efflux pumps on exposure to quinolones. So such similar things, that is just one of the examples. Similarly, we can see cephalosporin exposure increases chances of ESBLs as well as CREs in that particular patient. So all those things can be taken into consideration. So this brings to carbapenem sparing strategies. So wherever feasible. So now we are already having certain drugs like say cefepime, enmetazobactam and all in the pipeline, which are now recently becoming available. At least the initial available literature shows promising results with these agents as carbapenem sparers. So even when one of the conventional BL-BLIs like piperacillin tazobactam or cephalosporin sulbactam is resistant, these BL-BLIs have been found to be susceptible in vitro testing. and they can be used as carbapenem sparers so that we can tackle the issues of rising CREs, which is on the rise across the country in last 5 to 7 years. Then this point again was mentioned in the previous lecture, that most of the studies, especially dealing with community acquired pneumonias, complicated as well as uncomplicated UTIs and skin soft tissue infections, are now showing that the previously said durations of treatment are not actually needed. I mean, something like a 3 to 5 day course of an appropriate antibiotic for UTI or community acquired pneumonia is as effective as a 7 to 10 day or 14-day course, with much lesser side effects, much lesser drug-drug interactions, and much lesser costs. The only thing is the initial choice should be appropriate, and in cases like say urinary infections, if there are digestion stones and all, or in intra-abdominal infection if there are any pus collections, so that source control should be adequate so that duration of treatment can be shortened as much as possible, except for few exceptions like say endocarditis, osteomyelitis, or implant related infection where the implant could not be removed. So in such cases, or maybe CNS infection where adequate source control may not be possible in a brain abscess patient. So in such cases, only longer durations are recommended. Now for resistance prevention, again we discuss carbapenem sparing strategies. Now in this last two I have particularly put in here is because many of our urinary isolates nowadays, even with ESBLs and CREs, are showing susceptibility to trimethoprim sulfamethoxazole. So cotramoxazole, which has excellent urinary penetration and a sidal effect against Enterobacteriaceae if shown susceptible, it should be explored as an important option in most of these ESBLs or CREs, especially when you're dealing with infections like UTI where their penetration is very good. But then in last 15-20 years, people have forgotten things like cotramoxazole, all this Bactrim, Septran, all that stuff, chloramphenicol, which were in rampant use in 80s and 90s. Then they become resistant. Now they are again showing susceptibility. Like even in CR Acinetobacter, many times we have cotramoxazole susceptible, and it has very good urinary as well as CNS penetration as well as lung penetration. You remember, it is a drug of choice for BCP. It is drug of choice used in some of the CNS infections also. So a CR Acinetobacter causing healthcare associated pneumonia, this could be a very simple and less costly choice if there is no sulfa allergy. That's the only issue perhaps. Otherwise, in short terms, it's a very well tolerated drug. Even in long term, like in our HIV patients or transplant patient, they end up using Bactrim for 6 months to a year till their immunity comes to normal. So it's a well tolerated drug. Then again, issues like AMC inducers. So if we see this AMC in certain bacteria is in a de-repressed state, and on exposure to certain antibiotics, especially third generation cephalosporins, sometimes even piperacillin tazobactam, there is de-repression of these suppressed mutants, and they can manifest and lead to clinical failures. So even if in vitro there is susceptibility to those classes of antibiotics, they should be avoided in that particular bacteria. So recently I had one complicated UTI patient growing Enterobacter aerogens, now I think called Klebsiella aerogens previously. So that is another AMC producer. So it was susceptible to everything. But there it would be wrong to use something like a ceftriaxone just because it is susceptible. Rather, we should use something like a cefepime, which has very low risk of inducing AMC. So amongst cephalosporin, so if we have this background knowledge, and if we discuss this with the clinician, because the clinician by the time they are in MD, they would have forgotten their microbiology. So that has to come from the lab, because in the report, even if we do selective reporting and don't report carbapenems, but cephalosporins would still be reported if they are sensitive. Piperacillin would still be reported. So they should not be using that if the mechanism detected is AMC. Now this again highlights the importance that in addition to phenotypic ASTs, we do require genotypic testing and vice versa. Both cannot replace each other. Each has its own advantages and disadvantages, which I am sure would be discussed in the subsequent couple of lectures. Now coming to the PKPD, I think the most favorite of my topics out of these three. So here again, as discussed in the AMSP lecture previously, our main aim collectively as a AMSP team, infection control team, microbiologist, clinician, irrespective of what is our designation, is to achieve clinical and microbiological cure, to have by using antibiotics which have action at the site of infection, minimizing development of resistance, minimizing antibiotic exposure and costs, minimizing adverse effects of antibiotics, including Clostridium infections, and shortening the hospital stay and overall healthcare expenditure. So how we can do this? So this everyone is aware of, that there are antibiotics which are concentration dependent. So their index is Cmax above MIC. There are antibiotics which are time as well as concentration dependent. So where area under the curve is important, where time factor as well as concentration comes in play. And there are antibiotics which are only time dependent. But what is important here is these three things which you all will be more familiar with. What we report with MICs is usually MIC 50 or MIC 90. So the concentration which will inhibit 50% or 90% of the isolates. But if we go higher up, then there is something called as mutant prevention concentration. So between MIC and MPC, at MIC 50 or 90, the isolate may be inhibited, but formation of resistant mutants is not inhibited. So we ideally want to target this, or bactericidal total suppression of the organism, and not just be satisfied with this thing. Now this becomes relevant clinically if we are treating infections at sites where penetration of drugs is not optimum. So infection across blood-brain barrier in the brain, infection like endocarditis where penetration of drugs may be less in the vegetations, infections in bones where again penetration will be less compared to the serum concentration. So the drug concentration achieved may be crossing MIC, but it may not be crossing the mutant prevention concentration, leading to development of resistance on treatment and clinical failures later on. Now briefly, these are different classes of antibiotics with their main PKPD parameter. So what this tells us clinically is that any drug which has Cmax by MIC as the ratio is usually complete doses given once in a day, with few exceptions like ciprofloxacin. Otherwise, by and large, they are given once in a day. Typically, these classes also have a significant post-antibiotic effect, meaning that if you are using one of these as treatment modalities, then the duration of treatment can be shortened further, because their effect, like something like azithromycin, something like a quinolone, even if you give a 3-day course, their effect in body will remain up to 5 to 7 days. So it is as good as giving a 7-day course of a beta-lactam. So they can be shortened to 3 to 5 days only. Even with that, we can achieve clinical cures. Then coming to beta-lactams, where the important thing is time above MIC. So how this translates in clinical practice is by use of prolonged or continuous infusions. Therefore, all beta-lactams, if you see, they are dosed 8 hourly, 6 hourly, frequent dosing. Critically ill patient, you give prolonged infusions over 2 hours, 3 hours, or at times even continuous infusions, calculating a 24-hour dose. You load it in a 500 ml saline and give as a continuous infusion across 24 hours. Because here we don't want very high concentration. We want concentration to be maintained above the MIC 90 for more than 50% of dosing interval. So the longer we give infusion, lower is the dose required actually. So you don't have to give higher doses in boluses. Rather, we can do give the correct dose, but in prolonged infusion when it comes to carbapenems and BLBLIs and other beta-lactams. Then on the contrary, something like colistin, polymyxin, vancomycin, all teicoplanin for that matter, they have AUC by MIC as their PKPD index. So they require a loading dose to achieve a therapeutic concentration, and then you have to dose frequently to maintain that concentration. So any of these drugs, if not given with loading dose, typically takes almost 1.5 to 2 days to achieve therapeutic drug levels, and we are talking of every hour leading to 6% increase in mortality in sepsis. And if we don't give loading dose, the actual therapeutic effect comes after 36 to 48 hours. So if loading dose is not given for these drugs correctly, then we'll end up losing most of the patients who don't receive that. So that is again important. Then again for aminoglycosides, it has been proven beyond doubt that instead of 2 or 3 doses of say amikacin, gentamicin or other aminoglycosides, a single complete dose breaching the Cmax is good enough for clinical efficacy. Multiple doses only increase the nephro and ototoxicity of these drugs. So multiple doses should not be used except when you are say using gentamicin with a beta-lactam for synergistic effect in treatment of infective endocarditis. Even there, in elderly patients with infective endocarditis, there are now trials which have compared beta-lactam plus genta versus beta lactam based combination, like say when you are treating empirically, if you give say ampicillin plus ceftriaxone to saturate different penicillin binding proteins to achieve cidal therapy, then that is shown to be non-inferior to ampicillin plus gentamicin with very less nephrotoxicity. So even in endocarditis these days, instead of using ampi plus genta, we are using ampi plus ceftriaxone awaiting cultures in culture or in culture negative endocarditis to minimize their nephrotoxicity, because already because of endocarditis also they may have glomerulonephritis as a immune mediated complication. Then another important thing which has to be repeatedly told to the clinicians that you interact with is please differentiate cidal from static. Very often you find MRSA reports where the MIC of linezolid and rifampicin is way lower than the MIC of vancomycin, tocoplanir or daptomycin. But that does not make linezolid a better drug than vanco and tico if it is MRSA bacteremia or endocarditis, because it is essentially a bacteriostatic drug when it comes to bacteremia, endocarditis or meningitis. Whereas you require there something which is bactericidal. So best bactericidal class is always beta lactams if they are sensitive. Then you have glycopeptides, daptomycin, quinolones, but there are certain exceptions. If we are treating MRSA lung or skin soft tissue infection, then there linezolid achieves excellent concentration and that is actually a drug of choice over and above teicoplanin and vancomycin when you are dealing with MRSA infections. Similarly, daptomycin, which would perhaps be a drug of choice if it is bacteremia and endocarditis with MRSA or VRSA, is useless when it comes to pneumonia because it is inactivated by the pulmonary surfactant. So these are all small points but which can have clinical implications. So that's why one size does not fit all. Otherwise every MRSA we would have given daptomycin. Why do we need other agents? So in such cases linezolid is far superior to dapto or vanco and tico. Again, similar thing with the gram negatives when it comes to tigecycline. If you are treating complicated intra-abdominal infections or necrotizing pancreatitis, gallbladder infection where tigecycline gets heavily concentrated, it is an excellent drug. But it should never be used for bacteremia. And second, now more from microbiology perspective, it should not be reported in urine cultures. Now we already do it, most of the labs do, but still there are many labs even in Pune who continue to report doxycycline, tigecycline in urine culture sensitivity report. Now these drugs do not penetrate in urinary system, so it should not be reported, because if a clinician who is not aware of this thing or who tends to say overlook this thing, just by seeing sensitive they may switch to this class of drug which may not be effective when it comes to urinary infections. Similarly, polymyxin B, colistin do not cross blood brain barrier. Between the two, again polymyxin does not get excreted in urine, so colistin is still required in spite of all its issues of heteroresistance and CLSI saying you use it only in combination or report intermediate and all those things. Then this I have already touched. Teicoplanin again, although it is very good for bacteremia, has extremely poor penetration when it comes to vegetations. Vancomycin, although very commonly people add vanco for meningitis, if you see its PKPD thing, it has a at best moderate penetration in the CNS. Beta lactams have excellent penetration most of the tissues, but here again we have to remember, especially in dealing with CNS infections post surgery or nosocomial infection, that your tazobactam, sulbactam, they do not have good CNS penetration. Sulbactam at least has some penetration, tazobactam does not have. So when you are having a nosocomial meningitis case, empiric treatment directly goes to carbapenems and we cannot use BLBLS. Again, this I think I've already touched upon. Only one point remaining here is in sepsis patients who are young, they have something called as augmented renal clearance. So in simple words, the drugs are cleared faster compared to a patient without sepsis in younger patients who do not have underlying kidney disease. So you end up requiring much higher doses and much prolonged infusions in such patients. Otherwise, we end up exposing the bacteria to lower than optimum concentration, leading to selection of resistant mutants. So this again we all know. This I think I'll skip for the want of time. One important thing is about role of local antibiotics. So this is for the CNS, because again because of all these factors, the penetration of most antibiotics across blood-brain barrier is poor, except for beta lactams, quinolones, linezolid, such drugs. So all these other agents, they can be used intraventricularly or intrathecally. So these are the usual doses. I mean, we did not remember all of this. We can deal it on a case-to-case basis. Then similarly in healthcare associated pneumonias where CREs or CR crabs and CR pseudomonas are increasing, there is some, although doubtful, role of nebulized antibiotics like say nebulized colistin or nebulized aminoglycosides. Infective endocarditis, again we all know why we use synergistic combinations, higher doses and prolonged courses there. One important thing these days, more and more people undergoing orthopedic implants, spinal implants, cardiac implantable devices, more and more people having chemotherapy ports, dialysis catheters. All these infections have the problem of biofilm. And we all know that the concentration of antibiotic required to inhibit an organism in the biofilm is 100 to 1000 times higher than the MIC for organism which is free in the blood circulation. And increasing the dose 100 to 1000 times is practically impossible. So there we can use either antibiotics which help in breaking that biofilm, which are mainly these, or in cases of say and implantable catheters, and if there is no alternative available, if it's a precious line, then we can use individualized antibiotic lock therapy. Again here there should be a dialogue between the lab and the clinician, that the 80s or 90s practice of giving Gentalock to everybody is no more correct. We have to see what is the susceptibility in that patient, isolate, and then choose antibiotic from the ones which are susceptible. This is again about dose adjustments in special situations. So that is one of the most important PKPD parameter that we should keep in mind, including the augmented renal clearance in younger people, but renal dysfunction in elderly, hepatic dysfunction in elderly, which are very much dynamic things when a patient is in ICU and being treated for sepsis. So on a day-to-day basis, now this is where our CPs, the clinical pharmacologist, help us a lot, because on a day-to-day basis the person's creatinine may be changing, creatinine clearance may be changing, liver enzyme values may be changing. So there should be somebody who goes back and checks the antibiotic dose every single day, and that is the important role of CPs. And this is, I would say, drastically improved in last 2 to 3 years since we are having a CP team here at Jehangir Hospital, because and these are very easily acceptable by the treating person also. I mean, compared to telling somebody to stop meropenem, the person is more likely to accept saying you reduce dose from 1 gram to 500. I'm sure Dr. Monica will present all these challenges in her talk on role of CPs. Then again, many people are on polypharmacy, so we have to bear in mind drug-drug interactions. Now this is very important in antifungals like voriconazole, posaconazole and all, which can have a lot of drug-drug interaction even with some basic things like pantoprazole, ondansetron, domperidone, etc., which are started even before the patient is examined. Patient walks to the casualty, one IV fluid, one pan, one MSET is already given, and then we may be wanting to give them say something like this posaconazole oral tablet or something, which the effect reduces by almost 30 to 35% with antacids and antiemetics, even with gastro-resistant tablets. So you end up achieving sub-therapeutic concentrations and treatment failures. Then this last point, I think within next 3 to 4 months it will become redundant, because we should hopefully have Aztreonam avibactam available by the early quarter of next year. Otherwise, currently the correct use, like some places they mix ceftazidime, avibactam and Aztreonam together in saline and give, or parallelly. But one of the recent papers which is going to be published soon, authored by Dr. Soman, so what he has found is that if you start ceftazidime, avibactam and half an hour later you start Aztreonam, then Aztreonam and avibactam are at their therapeutic peak at the site of infection. Okay, so that way, that is the correct way of using this combination, which is extremely important for our NDMs. So coming to the last slide, ultimately the selection depends on so many factors. What is the clinical syndrome that we are dealing with? What is the likely organism for that syndrome? Then as discussed in the previous talk and will be discussed in the formulation of antibiogram, what is the antibiogram locally in your hospital in that particular unit, even between ward, OPD versus ICU versus daycare and etc. Then PKPD properties of antibiotic, whether it actually penetrates at the site of infection or it is just sensitive on paper, like say tigecycline for urinary tract or colistin for CNS infections. Then what are host characteristics like renal, hepatic and other dysfunctions or other drugs. Clinical judgment in coordination with the recommendations in standard guidelines, because after all, contrary to what most Indian clinicians feel, that guidelines are made in Western countries sitting in AC cabins, but they are made after studying records of thousands of patients in terms of efficacy, safety, and resistance, everything. So they do have some relevance for sure, although we can individualize the therapy in a particular patient. Then cost of treatment is always a factor in our country when it comes to treating MDROs. But more than that, what is the cost of failure of treatment, which could be somebody's life? So we cannot just choose a wrong antibiotic just because it is cheaper than something else. Like my ID mentor, Dr. Soman, always says, the costliest antibiotic is the one which is not effective on the causative organism. And I'll close with his favorite slide. Like Dr. Kumar told in first thing, that microbes have been there much before us. They are in huge numbers compared to human population. So they are way ahead of us in terms of genetic mutation and surviving in extreme conditions. So you can fool all the microbes for some time. You can fool some of the microbes all the time, but we cannot fool all the microbes all the time. So we have to be very judicious in using each and every antibiotic that we prescribe to our patients. Thank you.
Thank you, sir, for your valuable inputs and refreshing our knowledge. So, to learn how to use antibiotics, one must learn how to not use the antibiotics. Coming to our next session, moving to the next speaker, we are privileged to have our leading expert with us who will be addressing a critical issue in the field of healthcare and infectious diseases, that is extensively drug resistant organisms, Dr. Priya Dhumal Madam. She is a senior consultant microbiology at Jehangir Hospital. She has been working since last 14 years on infection control team and has experience in tracking, analyzing and presenting XDRO's data in the HIZ committee meets, and also have contributed significantly in understanding of threats posed by drug resistance pathogens. As you know, XDROs represent one of the most serious challenges in the modern medicine, and they are resistant to nearly all the available antibiotics, making these infections difficult to treat. So please join me in welcoming Dr. Priya Dhumal Madam, who has experience in automated and diagnostic methods also.
Thank you, Dr. Pooja, for the introduction. So I'll be talking about the XDRs today, all the XDROs that we've been encountering and what we do in our facility here. Almost 30% of all the isolates that we get every month are, almost 10% of all the isolates that we get every month are XDRs. In my presentation, I'll be covering the definitions, the resistance mechanisms, detection, reporting issues, how to report, and tracking. Now, as we all know, extensive drug resistance is defined as non-susceptibility to at least one agent in all but two or fewer antimicrobial categories. That is, bacterial isolates remain susceptible to only one or two antimicrobial categories. Pan-drug resistance is defined as non-susceptibility to all agents in all antimicrobial categories. MDR is defined as acquired non-susceptibility to at least one agent in three or more antimicrobial categories. Carbapenem-resistant enterobacterials are defined by resistance to at least one carbapenem or the presence of a carbapenemase. A non-susceptible, what do you mean by that? So, it is an isolate is considered non-susceptible when it is tested resistant, intermediate, or non-susceptible when using clinical breakpoints as interpretive criteria. So intermediate is also considered as non-susceptible. Only acquired antimicrobial resistance is taken into consideration while defining. So example like Enterococcus, if we cannot take cotrimoxazole resistance as a criteria for defining the resistance in that organism, or ertapenem for non-fermenters, because they're inherently resistant to these antibiotics. Now this is a report. If you look at it, it is an E. coli isolate from catheterized urine. It is showing sensitive to colistin, amikacin, gentamicin, and nitrofurantoin. Now, I would like one of you to tell me what category of resistance or how will you define this E. coli? So who can tell me what will you consider this as? Which definition will apply to this strain of E. coli? Now, if we look at it, there are three categories. One is colistin, one is aminoglycosides, and one is a nitrofurantoin. Now, colistin is reported as intermediate because it does not have a susceptible criteria by CLSI, but the dose does not change like that of an intermediate antibiotic. So, this is also considered sensitive, and therefore we have three categories now. So, this comes under the category of carbapenem resistant and E. coli. Now, look at this isolate. This is also an E. coli from a urine isolate, from a urine sample. and it is susceptible to colistin and phosphomycin. Now, what will you categorize this as according to the definition? Anybody loudly? An XDR. This is an XDR strain because it is only two antibiotic categories that it is showing sensitive to. I will not go into too much detail of this because Dr. Piyush has covered this very well. I'll just brush up the beta lactams with you once. Now, the ones which are highlighted in yellow is what are the ones, the beta lactamases that we encounter with XDR organisms. Everybody is familiar with the Ambler's classification. So, the ones that we encounter in our reporting are the Ambler's classification A, B, and D categories. A producing OXA 48, OXA 11, and OXA 15. They hydrolyze carbapenems and ESBLs, and organisms which usually report these are Klebsiella, E. coli, and Acinetobacter. Then Ambler's A classification also has KPC2 producers produced by Serratia and Klebsiella species, and metallobeta-lactamases, which are your New Delhi beta-lactamases, imipenamases, and VIM types, which are produced by Pseudo-aeruginosa, Acinetobacter baumannii, Klebsiella pneumonians, Stenotrophomonas, Maltophilia. Now, these are resistant to all beta-lactams except Astonim. So, therefore, Astonim can be used for synergy, for testing treatment along with ceftazidime avibacter for NDM producers. Like he said, fluoroquinolone resistance is because of the production of genes presence of genes which alter these enzymes, gyrase and topoisomerase, which prevent attachment of fluoroquinolones to the DNAs, and therefore the DNA replication continues. Organisms which produce these are Enterobacter species, E. coli, and Klebsiella pneumoniae. Efflux mechanism is seen with E. coli and Klebsiella pneumoniae. Plasmid mediated resistance is seen where folic acid pathway goes unhindered because of modification in the dihydrofluorate reductase enzyme. Organisms which produce these are Klebsiella and E. coli. We are familiar with the VAN-A, VAN-B series. They modify cell walls and reduce affinity to vancomycin. Organisms which usually will report these will be Enterococcus and VRSAs. Now, coming to detection of these XDROs, I'll be covering Vitek2, Gene Expert, True Rapid CAR Test, and BioFire. Now, Vitek2 system, we all know, is a colorimetric, turbidimetric detection by using optical system, and it has a huge menu where identification and ASTs can be done. The report of a Vitek is something like this. You have the organism on top, and in the comment section you can see the resistant mechanism. Here it is saying VAN-A type of resistance, and sensitivity only to linezolid and tigecycline. Advantages of Vitek system is it is a sealed system, therefore minimum aerosols and spills and contamination occurs. Disposable waste produced is very little. Extensive identification and susceptibility menu is present. Technical training required is very little, and LIS interfacing can be done easily. Response time varies between 7 to 10 hours. Limitations is you need a pure culture for testing, and it is not reliable for colistin testing. You have to do a colistin microbiota testing separately for this. Coming to Gene Expert, we all know it's a real-time PCR, and it is again a single cartridge test where all the primers and the reagents, everything is in one cartridge. Turnaround time is about 1 hour. And this is how a CARBAR test from a Gene Expert, the report will look like. It does not give you an identification of the organism. If you look at the report, this is an NDM and an OXA 48 producer, this particular strain. Advantages of CARBAR, it is the turnaround time is 1 hour. It is highly sensitive and specific, and it detects all the genes responsible for production of these beta-lactamases. With limitations, it is costly compared to culture. Culture is always needed. It does not identify bacteria or indicate any viable bacteria, and it does not detect all carbapenemase genes. This is a new test that we've come up with. Is a true rapid test. It is an in vitro rapid diagnostic test. Now, this is an ELISA test wherein you have here it detects directly the enzymes onto the cassette. There are 2 cassettes given in the kit. One cassette detects OXA 48 and KPC and NDM carbapenemases. The other cassette detects VIM and IMP carbapenemases. This is how the test looks like. Now, if you look at there is a control band, there is an imipenemase and VIM enzyme line here, and the antigens, the antibodies are put on the nitrocellulose membrane in these cases. And here, this N band you see is positive, that is an NDM producer. It's positive for NDM enzyme. Advantages is turnaround time is just 15 minutes. It is very easy to perform and it is inexpensive. Limitation, it is a qualitative test and it may miss other resistant mechanisms. Coming to BioFire, it is a multiplex PCR technology where it detects a variety of pathogens, viruses, bacteria, yeast, all of them in about an hour, along with their resistant genes. These are the different panels which are available. You have a meningitis panel, a respiratory panel, joint infection, gastro, pneumonia, and a blood culture panel. Turnaround time is almost 1 hour 15 minutes for all of them except for respiratory, which is about 45 minutes. So basically in BioFire, what it does is it detects the amplicons when they are denaturing. So at that point of time, at a certain temperature, when they denature, the fluorescence reduces and it is detected by the machine and it produces what is known as a melting curve. Now these temperature ranges are different for each species. So that's how it identifies which organism has been identified. Advantages of BioFire, the turnaround time is about 1 hour 15 minutes. It detects organisms and resistant genes, thus aiding in initiation of therapy as soon as possible. It is technically very easy to perform. Detection of pathogens where antibiotics were already given. So sometimes your cultures may be negative. The patient has already started on antibiotics. In that case, BioFire is very helpful. Limitations in case of respiratory panel where multiple targets are present. It is a little difficult to differentiate between colonizers and pathogens. Also, we cannot sometimes gauge, they give a range of the resistant genes also. So you wouldn't know which gene applies to which organism. Another thing is the number of copies produced should be at least more than 10⁻⁷ to actually be able to collaborate with a culture. So therefore, a culture has to be done for every test of BioFire that is done. And it is expensive. Now this is how the report looks. So if you see, the number of copies and the organisms are on the upper bit. The highlighted ones are detected in this report. So it is around 10⁻⁴ copies per ml is what this report is saying for E. coli, Klebsiella and Staphylococcus aureus. It has detected CTX enzyme, it has detected MEK-A gene and NDM. So on day one itself, before the culture report, before the AST is being put from the colony itself, from the sample itself, the consultant will have an idea what they should start. They're looking at an MRSA in this case and a carbapenem resistant strain. Now coming to issues while reporting all these organisms, very often we find that a lot of samples like sterile fluids will grow an XDR organism, but there are no pus cells seen on gram stain. Secondly, urines which will have again not many polymorphs will grow XDR colonies in about more than 10⁵. Improper or irrelevant history on requisition form regarding sample is sent. Sometimes they'll send a urine sample and history will say headache or upper respiratory tract infection. Very difficult to understand whether this is actually a pathogen or a colonizer at times like this. Then again, no mention of site of collection in case of pus or swab is there. Previous antibiotic history is not given at a lot of times. BioFire report will show positive for a pathogen, but the culture will not be able to grow it. So what we usually do is we ascertain that all the growths that we have, we always do a direct gram stain of the sample. It really helps you sometimes to rule out contaminants. Also, you will have an idea whether there is an infection looking at the presence of pus cells. In case routine microscopy of any of the fluids is available, do refer to it, for especially like pleural fluid, ascitic fluid, looking at the protein levels, you will know whether it is an exudative kind of a fluid or a transudative kind of fluid, whether, there are any, looking at the total cells, you will know whether there is any pus cells in it. So it gives you an idea whether it is a true infection. In case of reporting urine, always check for delays without proper refrigeration, to avoid reporting significant counts of colonizers and contaminants. So a lot of times urine is collected in the wards, not sent immediately. or standalone laboratories have a lot of issues. By the time the urine reaches the lab, it's been quite a few hours. So that time you wouldn't know whether you're growing a colonizer or a true pathogen. Then for all urines, there are certain things like presence of pus cells, catheter status, immune status of the patient, or in case of pregnancy, even colony counts less than 10⁵ become significant. Whenever suspected a urethral or salivary contamination is there, ask for a repeat sample if the antibiotic has not been started. Reporting of XDRO should always first involve checking of a purity plate of a mixture. So whenever you have grown or you have a report from either you've done it manually, Vitek, any automation, you should ensure that there is a purity plate done of the strain so that you know that there is no mixture with an yeast or a gram-positive cocci, and therefore you're not getting a resistant carbapenem or colistin resistance in that. And what we do in our laboratory, we put up a doripenem disc along with the automation. So that always gives us an idea if there is a zone, a big zone for doripenem, and you're getting carbapenems resistant, there is a possibility that there is a contamination. So in that case, we repeat testing for the carbapenems by disc diffusion. So role of history and communication. Always speak to the consultant or resident doctor regarding XDROs. Taking relevant history related to sample or communicating colonizers can prevent a lot of unnecessary antibiotic usage. So every time you talk to them, you realize, oh, the patient is fine, but how can you grow an XDR in the urine sample? The patient is all okay. So at times like this, you can either ask for a repeat sample. If the colony count was significant, ask for a repeat sample. If the patient has not been started on an antibiotic, if there was a catheter in place, ask them to change it and send, or remove it and send a midstream sample. Similarly, gram stain of sterile fluid showing pus and bacteria is a thing. So another thing what we do is every time we get a blood culture positive, we do a gram stain of the smear on day 1. If the gram character is clear, we know it's a gram negative or a gram positive, we call up the consultant and inform them. If they want to do a biofire right away, then it is possible there. Similarly, for any other fluid like CSF or fluid, for anything we get where we feel that there are pus cells or there may be an infection, we always tell them to run a biofire. We report all XDROs, carbapenem resistant enterobacterials, VREs, MRSEs, carbapenem resistant Acinetobacter species, and PanDROs as critical callouts. And barrier nursing is always advised in order to prevent it from spreading in the hospital. Now, what we have noticed is all the XDRs mostly are only sensitive to either colistin or to ceftazidime avibactam or ceftazidime avibactam in combination with aztreonam synergy testing. So these are the 2-3 things that we have to do if there is an XDRO suspected. For microbroad dilution, we use 2 kits. One is this kit by Erba. It has, if you look at so it is based on turbidity testing. The first is a control well. Here, the first well is 0.25 up to which the turbidity is seen. From where the clear well is seen is taken as the MIC. Another kit from High Media, where there is a change in color. So the pink wells signify growth, and the MIC is taken as the purple color. That is here again 0.5. We track all our XDROs and their outcome on a monthly basis. Details of all patients growing XDR organisms are entered in an Excel sheet. We enter details like name, date, registration number, specimen, organisms grown, comment on the resistant status, whether it is an CRE, whether it is an MRSA, whether it is an VRE. So that is also put in there. And sensitive antibiotics, which antibiotics is it sensitive to, and the outcome of all the patients. Every month, the trends and the data is presented in the HIC meet. Our data looks something like this. We have these details: culture number, date, details of the patient, the specimen collected, bed number, so that if we need to track for which ward, where is this happening more often, we can keep an account of that. The organism, the comment with it, AST, and the outcome. It's presented in this format. So if we look at it, so these are our percentages given below. Pseudo XDRs are about around 60%. So now this varies depending upon the denominator, but this is the outcome of all the samples. How many samples were received on OPD basis, how many patients got discharged, how many are still admitted with us, and how many succumbed. These are the trends which we observed in our hospital. XDR Klebsiella pneumoniae is highest, up to around 70%, 60 to 70% strains of XDRs are Klebsiella pneumoniae, followed by Acinetobacter and VRE. Most of these strains are NDM producers, few of them are OXA48 producers.
Thank you, madam, for sharing with us insights into uh, detection method, resistant mechanism, issues of reportings, and steps to be taken while combating the crisis of XDROs. As healthcare system continue to evolve, the need for robust quality monitoring and improvement becomes more and more crucial. Dr. Monica Fusse brings a wealth of expertise in this area. Dr. Monica is a clinical pharmacologist at Jehangir Hospital with strong foundation in pharmacotherapy and improving patients' outcome through evidence-based study. She is involved in quality improvement program that align with both regulatory standards and latest best practices. She will cover defining and measuring quality indicators, define daily dose, and de-escalation. She will share insights into how these indicators not only support the compliance with national and international standards but also drive continuous improvement in the patient care and servicing. Welcome, madam.
Thank you, ma'am, for the introduction. Good morning, all. I will be talking on the QIs in AMSP. So let's head into the topic. What are QIs in AMSP? Quality indicators in Antimicrobial Stewardship program serve as a crucial tools to assess the effectiveness and safety of antimicrobial usage. These indicators help us to monitor prescribing practices, resistant patterns, and therapeutic outcomes, ensuring the optimal antibiotic use and enhancing patient care. AMSP is not just about prescribing fewer antibiotics or selecting specific drugs, right? It's about the continuous monitoring, evaluation, and improvement of the prescribing practice within our healthcare system. So, through our AMSP, our goal is means we our aim is to achieve optimize antimicrobial use, improve patient outcomes, reduce antimicrobial resistance, enhance patient safety, and promote evidence-based practices. The indicators are, this is already explained by Kumar sir. So indicators, antimicrobial usage indicators, we can count in DDD or DOT. Then AMR outcome indicators, change in AMR pattern analyzed by periodic AMR surveillance. Then clinical outcome indicators, morbidity and mortality. Then financial outcome indicators, antimicrobial cost per day, cost per year, and cost per admissions. So intervention categories means how can we escalate, de-escalate, or dose changes during our tracking of antimicrobial usage. So intervention categories are dose adjustment as per creatinine clearance. This is done in the patient with organ failure or compromised kidney. Dose adjustment as per guidelines. De-escalation as per culture reports. De-escalation for extended duration, and de-escalation for surgical prophylaxis. So this is our hospital data till now, how we could propose intervention and of whatever the number is accepted. So we propose 191 interventions for the de-escalation as per culture reports. Out of that, 132 were accepted. Antibiotic de-escalation for extended duration, we propose 56 interventions, out of which 164 interventions were accepted. Dose adjusted as per creatinine clearance, we propose 48 interventions, out of which 44 interventions were accepted. Dose adjustment as per guidelines, we propose 125 interventions, out of which 85 interventions were accepted. Total acceptance rate is 68.5%. And this is the trend of intervention in last 10 months of in our hospital. From January to October, from last 5 months, we can see the increase in trend of accepting interventions. And we could do total 1289 interventions since the MSP has been started in our hospital. Moving to a DDD. DDD is the defined daily dose, is a statistical measure used by the World Health Organization for standardizing the comparison of drug consumption between different drugs. It represents the assumed average maintenance dose per day for a drug used in the main indication for an adults. The DDD allows healthcare professionals and researchers to compare drug usage pattern monitor trends, and evaluate the effectiveness of the drug policies. In our hospital, this is done by a clinical pharmacist and not by the microbiologist. So how can we calculate the DDD? So in this is DDD per 1000 patients. So for vancomycin, dose is 250 mg, and within month, if total 10 quantity are dispensed, so we get the total mgs of my total dose in milligrams of vancomycin is 2500. So it convert in grams to we get 2.5. And ATC DDD, what is it? It is provided by the WHO guidelines, where we can check the DDD for individual drugs. And in that too, it is different for different route also, for like for parenteral and for oral. So for vancomycin, ATC DDD is 2, and we calculate the DDD by dividing total grams of drug used per month divided by total ATC DDD. So we get DDD here 1.25, and another is IP days. So for within month, we get DDD by calculating by dividing DDD by IP days. So we get here 0.208 for the vancomycin. Likewise, we calculate for the different drugs, and by comparing this data with previous month data, we can say the consumption of antibiotic. Means if we are we used antibiotic in lower direction or upstanding trends, so we can calculate the consumption of antimicrobials, different antimicrobials. Thank you. And in calculation, I can say the QIs in AMSP plays a crucial role to assess or to measure the effectiveness of our interventions and optimizing the drug therapy, drug outcome. AMSP is not only prescribing the lesser or fewer drugs, but it also check the effectiveness and the therapy of safe and effective therapy of the antimicrobials. Thank you.
Thank you, Dr. Monica, for letting us know how quality indicators can shape the future of advanced medical services. Now I request you all to have a tea. We will gather after 10 to 15 minutes. Coming to the most crucial topic of microbiology, that is AST reporting. We know that the more we use antibiotics, the more we lose antibiotics. With the extensive experience in the field of microbiology and clinical diagnostic, Dr. Vaibhav Dudat has dedicated much of his career to improve the accuracy and effectiveness of antimicrobial susceptibility testing, which is a crucial component in the battle against antibiotic resistance. Dr. Vaibhav Dudat sir is a consultant microbiologist and registered auditor for Consortium of Accredited Healthcare Organization, that is CAHO. He is experienced in multiple NABL and NABH audits. He has huge experience in molecular biology and HIC for a period of over 10 years. He is also exam paper setter in microbiology. Today he will be sharing his valuable insights on latest advancement of AST and vital role in its patient care. I welcome Vaibhav sir.
So, good morning, everyone. So, we'll be talking about the antimicrobial susceptibility testing. Its, you can say, relevance to the AMSP per se. As I've been already introduced, Dr. Vaibhav, thank you so much for the kind introduction, ma'am. So, to start with, I would like to give away a disclaimer. There is no conflict of interest to be mentioned here. I'm not representing any company or not being sponsored for this particular talk. So, we have been discussing and we'll keep discussing about the role of microbiology per se in AMSP and infection control as such. But just a brief introduction. How microbiology can help in AMSP and infection control. It is basically by means of identifying the causative agents causing particular infectious diseases, then optimizing the patient care by particular use of antibiotics or not using a particular one, monitoring antimicrobial resistant, its patterns and trends like Priya ma'am just mentioned a while ago, informing public health, particularly in terms of outbreak kind of situation and certain notifiable diseases, and surveillance activities both in terms of environmental as well as MRSA surveillance or some other surveillance activities that we can discuss in a while from now, which can be customized. This session will be limited to cascade reporting,
synergy testing of multiple antibiotic combinations, and reflex testing. So to start with, the cascade reporting, as the title itself reads, out of sight, out of mind. So basically it works on a principle that certain antibiotics, when not mentioned on the report per se and not informed to the clinician, that itself can lead to not using a particular antibiotic or set of antibiotics, and further avoiding the resistance development and other complications like C. diff and so on. So antimicrobial susceptibility testing results for a particular drug bug combination are obtained, but the results are not reported for broader spectrum, or we commonly call them as alert antibiotics, unless the bug is resistant to narrow spectrum ones. Examples commonly utilize one, cefepime, and that is 4th generation cephalosporin, 3rd generation cephalosporin. If they are sensitive, the further drugs, that is carbapenems, are not reported on the report per se. Of course, there are some exceptions which we'll come to see in the slides that are coming. Cascade reporting per se is a subset of selective reporting. So it's a useful tool for an AMSP, that is antimicrobial stewardship, as just discussed. By omitting AST results, certain antimicrobials, those antimicrobials are less likely to be used by the practitioners. The omitted results for secondary agents, however, can be reported if certain conditions occur or certain clinicians they need for certain patients. So in such cases, they can be reported as exceptions. Even the common guidelines like CLSI or UCAS or FDA or whatever we use, these guidelines also they mention about certain grouping of drugs. Like for example, CLSI, you can see it divides the antimicrobials into 4 groups: group A, B, C and U, as per their characteristics. So group A is appropriate for routine testing and reporting of results. Group B, they warrant primary testing but may be reported selectively. So the cascade reporting or selective reporting comes as a part of this one. Group C are alternative or supplemental and may necessitate specific testing, like some of the synergy drugs that we will come to see in the further slides. And group U are urinary antibiotics reserved for certain urinary tract infections. So I'm taking a risk of showcasing some of the results that we usually report in our laboratory. There may be some pros and cons and some fallacies which we can discuss later as well. So just as an example, if you see here the ones marked in green, these are the cephalosporins, 3rd and 4th generation cephalosporins. As these cephalosporins are sensitive in this particular, you can say, specimen, the further carbapenem reporting is avoided, except for ertapenem, which is marked in red. So as you can look at the sample type, this is urinary sample. So this particular patient had certain condition for which ertapenem was required for particular, you can say, treatment of that particular patient. So ertapenem was reported, otherwise other carbapenems were omitted from the report. If we escalate a bit, we have an E. coli which is ESBL producer now. In this case, we report the carbapenems. As we have cefepime, which is a marker of ESBL production, it is resistant. Moving ahead, if we get certain isolate like carbapenem resistant bug, E. coli again, in this case, as you can see, the carbapenems are resistant. So in this case, colistin MIC can be reported. So this is how we do the cascade reporting. However, since though these things look a bit you can say happening, or you can say helpful, there are certain drawbacks or cons as well to this particular cascade reporting or selective reporting pattern. Particularly when we talk about the antibiogram presentation or microbe data analysis, when it is to be presented in AMSP or HIC meetings, the antibiograms based on selective or cascade reporting, they have a risk of being representative of some particular patient populations and may not be suitable for extrapolation to other groups. Example, data for OP patient may not be representative for data of an IP patient if selective reporting or cascade reporting is followed. Similarly, critical versus non-critical care area. When analyzing the data, there could be differences in person sensitivity patterns, particularly if we are using any particular kind of algorithm or automated generated results. So in that case, the blank fields can create a problem since the antibiotics are not being reported. So while calculation, the software can have some glitches. So accordingly, it has to be adjusted, it has to be configured, or you have to analyze the data manually, which the problem we are facing at our end as well. So therefore, the antibiograms are not comparable between selective reporting or cascade reporting you can say hospitals and those who do not follow selective reporting or cascade reporting. Next part that we are discussing about is synergy testing. So basically, any two antibiotics or any two agents, when they are combined together, they can have different kind of effects on each other and in turn on the organism. The effects could be antagonistic, they could be additive, or they could be synergistic and escalating pattern. So basically, synergistic effect is the one where the applied antibiotics, when combined together, they have got better result in terms of outcome and MIC as compared to individual drugs used alone. So this particularly helps in AMSP by doing away with high dose chemotherapy or decreasing drug toxicity or AMR development in the particular against the particular antibiotic in a particular bug. There are multiple, you can say, types of tests or methods that have been reported and researched on for synergy testing. But I would like to restrict myself to the top 4 which are commonly being reported and tried and tested in research laboratories or diagnostic laboratories, which include checkerboard titration method, multiple combination bactericidal tests, then time to kill assays, epsilometer or E-strip test, which also is called as gradient diffusion test, and some lesser common known as broth method, agar dilution method, diffusion method or disc diffusion method or double disc diffusion, whatever, at times disc potentiation method, which is also a part of it, and saline dilution methods. So top 4 we are going to discuss about. The first, that is checkerboard method. It's a kind of a scientific method and relatively foolproof as far as the results are concerned that are available after the analysis. The antimicrobial combinations, they are tested at clinically achievable concentrations in two-fold dilutions. We will see in the next image that we have. The data produced are analyzed in terms of fractional inhibitory concentration index, that is FICI, that is calculated by comparing the values of MIC of each agent alone and in combination. The antimicrobial combinations that result in 4-fold reduction are considered to be synergistic, that is FICI of less than 0.5. So you can see here, this x-axis, it represents antibiotic A or agent A. The y-axis, it represents antibiotic concentrations of antibiotic B. So 0 to 256 antibiotic A, and 0, that is no antibiotic, to 8 micrograms per ml of antibiotic B. So the gradually increasing concentration, it shows gradual inhibition of the growth of organism. So these yellow, they represent growth of organism in terms of turbidity, and the blank ones, they show no growth. So as you can see here, 0, there is no antibiotic at this particular veil, the right hand corner, right lower corner. That means there is no antibiotic, so that serves as a growth control. And as we go above, the concentration of this particular antibiotic, that is antibiotic B, it goes on increasing, and at one particular point, that is 4, you get inhibition. So this is MIC 4 for antibiotic B, individual antibiotic. Same is the case with antibiotic A. As we grow on increasing the concentration, 128 is the point where there is inhibition of growth for antibiotic A. So antibiotic A has got MIC of 128 and antibiotic B has got MIC of 4. Now what we do is we calculate the fractional inhibitory concentration, which is basically a division factor. In this case, we see inhibition when both the antibiotics are combined. So for example, here at this particular point, we have the MIC of antibiotic A, which is 8, and MIC of antibiotic B, which is 1 when used in combination. So the ratio here becomes MIC of you can say combination divided by individual antibiotic. So this combination MIC for you can say antibiotic B is, since it is 1, and the MIC of this particular bug individually is 4. So 1 by 4 is the FIC for antibiotic A, and same is the case with antibiotic B, for which the combination MIC is 8 and the individual MIC is 128. So 8 by 128. So if we combine these two, 8 by 128 plus 1 by 4, that is 0.5, if this combination is, if this summation, it happens to be less than 0.5, the effect is synergistic, which in this case comes down to somewhere around 0.35 something. So this becomes a synergistic combination. Then if we move a step ahead, now since here we are talking about turbidity, that is visible growth, a step ahead, this is inhibition. If we think about the bactericidal effect, that becomes your next method, that is multiple combination bactericidal method. In this case, similar kind of checkerboard analysis is done and the subculture is done to see whether 99.9% killing has been achieved, and this particular combination gives bactericidal concentration. So synergy in terms of MIC, inhibitory effect, is your checkerboard analysis, plain checkerboard analysis, and when it is followed by subculture to see bactericidal effect, that is MCBT. The next is time kill assay. Now this is again a modification of MCBT. In this particular case, subcultures are done at serial intervals, that is at 4 hours, 8 hours, 10 hours, 12 hours and 24 hours. And during these subcultures, if there is some reduction in growth that is observed, which is again plotted in the form of a graph, and if we see some dip in the growth, if it is seen for that particular combination, that result is seen as a synergy. And when there is no dip, the combination is not seen to be synergistic. Now these are kind of research based methods and are rarely followed in routine commercial laboratories. The one that is routinely followed in commercial laboratories is the one that we are going to see now, the e-test. Now e-test again can be used in multiple ways and means to find out the synergy. The common one is the perpendicular one, in which two E strips each containing an antimicrobial of interest. They are kept perpendicular to each other. So what happens here is, you have two E strips with two antibiotics. Individual E strip is used to determine the MIC for individual drug as such. Then once you have an MIC, that intersection is used to draw a perpendicular. So for example, suppose this antibiotic A has got MIC of suppose 128, and this one antibiotic B has got an MIC of suppose 8. So 8 of this one and 128 of this one forms a perpendicular, you can say, angle where the drugs are placed, the E strips are placed, and then the synergy is noted in terms of change in the MIC now after putting these two E strips in perpendicular. So this is what happens in the perpendicular, you can say, arrangement. The second method, which is more commonly used, we also use in our laboratory, is when two strips are placed at the same place. So if we keep one E strip antibiotic A at one place, that is left there for 60 minutes. Now this 60 minutes time is subject to, there are some studies, some literature, some articles which say 10, some say 30, some say 60, but common you can say understanding or consensus is 60 minutes. So 60 minutes is a time for that E strip concentration of antibiotic to get diffused into the medium on the lawn culture. Then that E strip is removed after 60 minutes, and at this very same place another E strip of antibiotic B is placed, and that is incubated overnight. And on the control side, you have got that antibiotic A separate E strip plated on a long culture as serving as a reference. So that individual A antibiotic MIC is compared with this second set, which in which we are keeping the antibiotic B after 60 minutes, and the change in the MIC pattern is noted. And when the difference in the dilutions is more than or equal to 3 dilutions, then it is called as synergistic. 2 to 3 is called additive, and less than 2 is indifference. So this is the second kind of method that I just mentioned. So ceftazidime avibactam is placed, kept for 60 minutes. This ceftazidime avibactam is lifted up, and on the very same place azthromycin is placed, and this is incubated overnight. Another plate which has ceftazidime avibactam plate kept there overnight. So that serves as a reference. So you can say this is a reference and this is a synergy test. So here you can say 256 is the maximum MIC that can be reported. Here you can say the MIC is of around 6 or so. So that's the difference we note. Some other different types of e-strips methods, e-strip you can say methodologies for use are also reported in literature. This is a very you can say nice article which you can refer to, which gives multiple types of e-strip utilization methods, given it for your reference. Then as we just discussed about the CLSI one, CLSI also comes up with you can say defined and well researched and validated method for synergy testing, particularly for ceftazidime, avibactam and aztreonam synergy. The methods that we just saw, they are relatively technically demanding, also commercially. So CLSI comes up with a method which is easily validated, technically less demanding, and can be performed at any peripheral laboratory relatively easily. So this method goes ahead like is labeled as broth disc elution method. So as the name itself suggests, we have a broth, we have a disc, and elution is the thing, that phenomenon that is used. So here a Cashian adjusted Muller-Hinton broth is utilized, wherein we are keeping ceftazidime avibactam of 30 and 20 micrograms as a combination, and another you can say tube, it has got a aztreonam of 30 micrograms. Third tube which contains a combination of these two, and a growth control in which there is no antibiotic that is added, which serves as a growth control. So these tubes are utilized, and finally after overnight incubation the results are availed or seen. So this for you is a growth control wherein there is no antibiotic. This is ceftazidime avibactam. Here you have got aztreonam 30 micrograms per ml, 30 microgram disc, and here we have got a combination of both. When the turbidity is gone, that is no turbidity, that means the inhibition has happened. But again there is a drawback in this particular method. This is a qualitative method in which you cannot comment about MICs as such, which is not in the case with e-strips methods in which you can talk about the MICs and FICs. So that is the advantage of those methods. There are some other methods as well which have been tried and tested. So like this is a double disc method in which, just like e-strips, the disc is placed, ceftazidime avibactam disc is placed, and it is removed after 60 minutes when the disc diffusion happens, and at the very same place aztreonam disc is placed. Now, and then the difference in the zones of inhibition is noted. Another method which is fairly commonly used even in Pune by multiple laboratories is e-strip and disc method, in which an inverted D. So here for individual antibiotic ceftazidime avibactam, the MIC is more or less 256, no inhibition as such. But when aztreonam is kept nearby at 15 millimeters distance, so inverted D is seen, which indicates synergy. Again, this is a qualitative test. The problem is MICs or FICs cannot be commented about. If we go back into the literature, what we used to do in our PG times, the MICs or the you can say synergy tests that we just saw, they are more for clinical benefit, for you can say MIC and FIC to be given. What we used to do in our PG days for diagnostic purpose, they are also kind of synergy tests only. Like for example, double disc synergy test. Here in this case, this is an imipenem disc with an EDTA paper disc that is prepared. If there is an extended zone of inhibition, it can you can say identify MBLs for you, NDM for you. This is a pseudomonas, as the green color you can clearly identify. Imipenem with imipenem on which EDTA solution is poured. So the difference in zone of inhibitions can be identified as a synergy. Here, this is a combination test for detection of ESBL and AMPC production. So pardon me for this, you can say blurred image, but this is cefoxitin. This is cefoxitin plus boronic acid added on it. So zone of inhibition, the difference can indicate this is an AMPC producer, as the cefoxitin is an indicator for AMPC. This is ceftazidime and ceftazidime glycolic acid commercially available, which marks ESBL production. So these are also kind of tests that have been tried, but for diagnostic purpose. Now coming to the last part of my presentation, that is reflex testing. As the name itself suggests, it's a reflex test. One test result coming abnormal or any particular value should lead you to perform another test on the very same sample immediately. In ideal circumstances, there should be no need of communication or asking the clinician or the client or whatever. You should just directly perform the reflex test. That is the basic concept of it. But practically, it may not so happen because of various reasons, which we'll discuss in a while. So reflex test is the one the laboratory adds on based on the result of initial request test in order to optimize the diagnostic process. The reflex testing practically is performed when initial test results are positive or outside normal parameters, which are used to further identify significant diagnostic information required for appropriate patient care. Simplest form of reflex testing you can say is an ABST. Whenever there is growth, you perform ABST without asking to anyone. That is the simplest form of reflex testing. Another few examples could be HCV viral load following HCV serology, though not related to AMSP as such. Then it is a valuable tool for AMSP, especially when effectively used as advisory services for better patient care, particularly in the critical care patients. As I said, it totally depends on funding. For a standalone private laboratory, it may not be practically possible for going ahead with the reflex testing for each and every sample, as the costs are involved. So that particular, you can say, protocol has to be formulated by the lab, and a modified version of reflex testing in which a client is called upon to add test on the very same sample can be utilized as a modified form of reflex testing. There are certain pros and certain cons for this as well. The pros include it adds up to the clinical value as the wholesome reporting is done. It prevents further consultation as the sample is there and you are directly processing the second set of tests to add to the report. Repeat sampling is avoided and quick turnaround time can be maintained, as you need not wait for the confirmation of order, confirmation or receiving the sample again. However, cons are there are some clinicians who feel the particular test that is done as a reflex test was unwanted. Unnecessary excess testing has been done, particularly when the cost is involved. And there could be some tests for which consent could be needed. So without consent, should we go ahead for reflex testing is a question. So all said and done, there is a dilemma between idealism and realism as far as reflex testing is concerned. So some middle path has to be utilized. However, some common examples as we routinely perform in our laboratory may include, but not limited to, any positive growth culture that we get on a plate. It can be subjected to tests like MALDI of MS, which gives result in no time. Another method is whenever you have a patient in critical care area or some transplant patient or immunocompromised patient in which blood culture bottle has flagged positive. So immediately BCID panel or film array kind of test can be done, which aids in the result immediately. Within 2 to 3 hours, you get the result. Another example is whenever you have got a gram-negative growth, particularly in a critical care patient, tests like carbamazepine detection can be performed, which can help in further escalation of antibiotic immediately. So these are some of the common examples. These are my references, and at the outset, I would like to extend my gratitude to Dr. Maithili Kautikar, my director and mentor, Surgeon Commander CN Chaudhary sir, who has been my guide in my PG days, who helped me a lot in understanding the clinical microbiology, Colonel M. Kumar sir, who has been guiding me in the AMSP, particularly for the last few years, and particularly in the final years of my PG, he was very helpful to me, Vikram Padbidri sir, for giving me the opportunity and guiding me, and Dr. Sandhya Kulkarni ma'am, who showed me the actually path of clinical microbiology, and I am where I am for now. Thank you.
Thank you so much, sir, for your immense guidance on AST, from the methods of testing to interpretation and reporting of results. Now, I think the concepts of all of you are very clear. So, quickly moving on to the next session, which will be an activity on developing of the Antimicrobial Stewardship program. I'd like to hand over the mic to Dr. Vikram Padbidri, sir.
Okay, thanks, Pooja. All right. So we've been through about 4 or 5 lectures, and I do hope you all are brimming with knowledge. Are you all? I think along with my hair, I've lost my hearing also. Are you all brimming with knowledge? Thoda to? Thank you. Okay, so now the exercise that we are going to get into is something that you all will tell me. Okay? You all have seen what an antimicrobial stewardship program means. What is the role of the clinical microbiologist? Okay? You'll have seen how to detect XDROs. You'll have seen communication. You'll have seen an overview of the antibiotics and how PKPD plays an important role in how you're going to advise the clinician on which antibiotic to be given. Okay. So now what we're going to do is we are going to divide, or rather we are going to devise an antimicrobial stewardship program. You with me? Okay. We are going to divide it into three parts: simple, medium, advanced. Okay? Whatever interventions or whatever actions we are going to take, we are going to divide into three groups. Call it simple or basic, which is easily doable, not much of effort required. Medium, where you need a little more effort. And advanced, where probably you will not be touching on it at this point in time, but maybe 1 or 2 years later you will look at all those things. Okay? So as we call it as low hanging fruit is the first category, which is simple. So I just make the divisions here. Simple, medium, and advanced. Okay. If you want, you can write it down, or what we can do is once we have filled out this chart, someone can take a photo from here and put it on the group. Okay. Who's going to give me the first point? What would you like to do? One thing that you can go back and start.
Formation of team.
Very good. Formation of a team. Okay. Who would you like to be in your team? By default, microbiologist तो होना ही होना है, ठीक है? If you have an ID physician, excellent. Okay. Clinical pharmacist, if you have, well and good, you're pretty much on your way. But most of y'all may not be having these two people, right? So can you supplant an ID physician with somebody else? Excellent. Critical care physician, one of the most helpful people. I will share a few experiences of how we started our AMSP program about 15, 16 years back, and you will realize that time we didn't have an ID physician. Dr. Piyush was still doing his MD, I guess, at that time. So how you overcome hurdles without having particular things. Now, okay, you don't have a CP. What can you do? What is the role of the CP? What do you expect from the clinical pharmacist? Okay, audits. Basically giving you data on antibiotic usage. Can you use a nurse who can be designated as an antibiotic nurse, whom you can train on what data you want? You've seen the QIs which Dr. Monica has presented, right? Instead of you going out into the ward and collecting that data, a nurse could collect that data, give it to you, so you just analyze it, right? So team is important. Okay, next.
What you want from that particular team.
Okay.
Delegation of the.
Right. So now we'll keep the team aside for the time being. As an individual, without a team, what can you start doing? So let's start looking at it as a process. Okay. Sample comes to you. Correct. Would you like to do something to get a better sample? Okay, sample acceptance rejection criteria, that's fine. But anything else that you can do before processing? Excellent. Educate on sample collection. Okay, possible? By afternoon, most of the microbiologists are free, right? I think usually 11:30-12 बजे तक ही free हो जाते हैं. 1 to 2 or 2 to 3, can you go and take a lecture for the nurses on sample collection? Simple. Low hanging fruit. Okay. What will happen? What sir said, Gigo. Your garbage which was coming in will reduce. Thereby your garbage which is going out will also reduce. Correct? So it's training on sample collection. Okay, next. Acceptance rejection we have already tackled. In processing, anything that you can do? Okay, we'll get to quality a little later. Okay, processing of sample, transport, very good. So transport and processing. Anything else? Culture sample has come to you. Okay. Clinician calls you to say that, अरे this is a case of wound abscess and पस भेज रहा हूँ, जरा देख लो. Yes. Usually as microbiologists we've been traditionally aware that sample भेजे ना कल सुबह मैं growth देख के reply करूँगा. But no, direct smear is what is extremely important. Why is it important? Correct. You know whether it is GPC, GNB. What if there are atypical mycobacteria in that, nocardia in that? All these things make a difference. So not only gram stain. What we would recommend is for every pus, do a gram and a ZN. Okay? Alright. Next. Okay, direct smears day 1 done, day 2. सुबह सुबह रीडिंग इज लिया है. रीडिंग लिया अभी चाय पीने जाने वाले. Would you like to do something before that?
Inform the clinician what you see.
Correct. Inform the clinician about the growth. If he has called you to tell you I'm sending you a pus sample, correct? It is binding on you to inform him at various points in time of what you are seeing. So day 1 you said, okay, I'm seeing gram positive cocci. Okay, now one more thing what we talked about, reflex testing, what Dr. Vaibhav mentioned. Is there anything you can do about reflex testing here?
Primary antibiotic system.
Okay, anything else? What is the rate of MRSA in your labs? If you're seeing GPC in clusters or pairs, could it be an MRSA? So could you know in any way whether it is an MRSA the next day? There's something called as an MRSA chrome agar. So here is where your reflex testing comes in, that when you see a GPC on direct smear, put that sample directly onto MRSA chrome agar. So next day, if you see your pink colonies or yellow colonies, depending on which brand of chrome agar you're using, you know straight away it's an MRSA you're talking about. So two things happen with your MRSA. One, you're going to inform the clinician. If you're giving any cephalosporins, which is going to be most likely, stop it. Go to what? Which antibiotic? Panko, Tico, or which would be preferable in a pus sample? Dr. Piyush told you that. Linezolid may be used, right? Okay, so something like a reflex testing. This is just an example that we are giving, okay? Alright. Once you get an MRSA, then of course your AST and all those things go in. And one more important point you need to do when you know it's an MRSA is, in addition to calling up the consultant, anyone else you need to call? What Dr. Kumar said, infection control and antimicrobial stewardship go hand in hand. Okay, getting one MRSA in one patient may be okay. It is not okay if that MRSA spreads to 3 other patients. Okay, correct. So you have to inform your infection control nurse that contact precautions has to be put in place. Okay, so your reflex not only means test, also means info to the ICN. Okay, so far simple. Okay, anything else? Anything else that can be done? Let's say we've got a blood culture coming up. Blood culture, sorry, yeah? Very good, critical call alerts. Okay, so blood culture positive, what are you going to do? माइक्रोस्कोपी किया, जीएनबी दिख रहा है, आगे क्या? इन्फॉर्म टू द डॉक्टर, आगे क्या? प्लेट करेंगे, कल कॉलोनी देखेंगे, कल एएसटी लगेगा, परसों सेंसिटिविटी जाएगा. Okay, very good. BCID, if you have access to a biofire BCID, absolutely. If it's an ICU patient, you should be doing a BCID panel. Okay, you get an idea. All right. Anything else you'd like to do? Let's say you don't have biofire. Excellent. Direct. Okay, which antibiotics would you like to do direct? At least a few. Cephalosporins, maybe a carbapenem. Why am I asking for a carbapenem? Because if your carbapenem is resistant, next day you can do a reflex testing for carbar. So instead of giving out your report of carbapenem resistant on day 3, day 2 you are telling the consultant that look, I have got a NDM or an OXA producer. Does it make a difference if I say NDM or OXA producer? How does it make a difference? NDM plus OXA, what will you use? Combination of ceftazidime, avibactam and astronam. If it's only NDM, if it's only OXA, ceftazidime, avibactam. Okay, so here is where you can make a change for the patient one day before your AST actually goes out. Right? Okay, all right. Anything else? बस हो गया. इतना सब काम करने का आदत नहीं है. Come on, anything else? Okay, very good. History taking is something we should have probably done somewhere here. Okay, so here I will encroach on the medium and say history. Very important point. Without a proper history, do not release the report. Okay? You could have a situation where you have 50-60 cultures to report. Okay, in which case it is going to be difficult to get the histories of 50-60 patients. It may not be physically or feasibly possible. Okay, so what you have to do is at least look at the ICU patients. Those are our priorities. Okay, all right. So enough. बहुत हो गया. Yes sir, please. Yes sir, please.
Other than history, the other lab parameters also to look at, which are important for us.
Absolutely.
So CBC has to be seen.
Right.
Other investigations which have been done with reference to biochemistry, let us say some pleural fluid has come or CSF has come, the cytology biochemistry assumes important.
Absolutely. 100% right. What Dr. Priya also had mentioned in her presentation, if it's pleural fluid, look at whether it's an exudate or transudate. Then you know how to interpret the growth that you get. Okay? Or even to add on to that PCT, procalcitonin or CRP. Okay? So don't fight with your pathologist or biochemist. Be on good terms with them so that you get that data from them. Okay? Excellent, sir. Yes, please.
This is important because there is this trend now to put the sterile fluids directly into blood culture bottles. The biggest pitfall is while transferring, they manage to contaminate.
Correct.
So from a CSF, you are getting gram-positive aerobic spore bearers. From a pleural fluid, invariably cons grows because they have either not cleaned the place properly or they are contaminating it while transferring the fluid. So this history and the other investigations become important.
Absolutely. So keep one mic with you, sir. So this is something that is important for you all to note, that if the sterile fluid has been inoculated in a blood culture bottle in the ward and you grow something what sir said, a coagulase negative staph or a bacillus species or whatever, please find out how it was done, who did it. Okay? If you are transferring, please ensure you follow strict aseptic precautions so that you don't end up contaminating that blood culture bottle. Okay, enough? Antibiotics. Okay. So far so good. Before we come to the actual AST report. Yeah, Priya.
In the reflex testing, Candida chromagar also on day 1 if we see.
So similar to what MRS says, if you see yeast on the blood culture bottle smear, you put in the Candida chromagar. Okay? Good point. Okay, anything else? Yes. So history, you will need all that. Okay, what is the site? What antibiotics are given? What is the diagnosis? Or what is suspected? And so on. Okay? All right.
Does the microbiologist need to know the inventory of the hospital, like what antibiotics are there in
If you're reporting it, then definitely. But this is a one-time exercise. So supposing, for example, something like ceftazidime avibactam is not at all available in your unit, and you keep reporting ceftazidime avibactam, it is pointless. You need not even test it then. Or ensure your management gets ceftazidime avibactam, which would be a more prudent decision. Because in today's world, with the kind of XDROs we have, in fact, I think almost all ICU patients are on ceftazidime avibactam and astronam at some point in time. So this is something that you'll need to check once with the formulary. Okay?
And in fact, you should participate in the formulary.
Yes.
Creation.
Correct. So
You have to be a
PTC
part of it.
or pharmacotherapeutics committee which is there, microbiologists should be a part of that. Okay. All right. Okay. Coming back to our low-hanging fruit. Bas ho gaya? हाँ. Of the blood culture bottle. Yes, direct smears of any sample should be done. Because okay, wet mount you mean? Yes, you can do a wet mount of the urine on the stool. So these are two things you can do. If you have trichomonas or something in the urine, that will be picked up on your wet mount. Okay. Yes, please. See, it depends on your MRSA rates. Okay, now our rates are upwards of 50%. So we do it. For all. Wherever you see a GPC, we put an MRSA chromogar. Now an MRSA chromogar plate will cost you anywhere from 100 to 150 rupees. So what we do is, we just want to know whether there is MRSA or not. We are not bothered in having isolated colonies. So you divide your plate into 8. And you just put that sample onto one thing. You see the pink growth there? That's an MRSA. Subsequent AST is got from your blood agar and your Mekong, where you get isolated colonies. Okay?
Especially considering the present situation in our settings as well, we get the patient coming into the hospital with community acquired MRSA, and the percentage goes to above 60% in our very unit. So that chromogar does make sense.
Absolutely. I think so. This is something which even Sahyadri Hospital is seeing. And we are seeing it that most of our MRSs are community acquired and they're well below above 50-60% of the staph aureus. Okay, we're going to run. Unless you'll plan to stay overnight, we better move on. Anything else? Bas. Okay, chalo, this is good for a start. Anything in medium? Okay, antibiogram will actually should be here because it's mandatory, but I will put it somewhere between medium and advanced. So antibiogram leads to your antibiotic policy. We'll be discussing this in the afternoon, so I won't spend much time on it now. Anything else, Kishore? Anyone else? Okay, all right. So pretty much we've got what we are going to do. Okay? So when you'll go back, you're going to start off with all these things. Agreed? Okay? Okay, excellent. Yes, quality indicators. Yes, I would like to put it in medium, not in advanced. Why? Because, in fact, probably here also, because you need to know how you're doing. Okay. All right. I think we'll have to stop this exercise here, but this is a good start. Now, you all can go on building on this since you all know how to do about it. You all look at the process, see where you all can add something to what is currently being done. The most important bottom line for this is communication. You have to communicate the status of your culture or growth to the clinician so that he or she can take the decision to change the antibiotic there. Okay? Accepted? We'll move on to the presentation. Somebody can just take a photograph of that, if it makes any sense to you all. Okay. So, basically, stratify all the things that you want to do into 3 categories. Low-hanging fruit, mid-level and top level. Okay? Most importantly, prepare SOPs. Okay? Without having these things on paper, somewhere along the line in 6 months' time, you are going to forget 1 or 2 things. Okay? So an SOP has to be written out. What does the SOP say? What you are going to do, who is going to do it, how they are going to do it, and who are they going to communicate it to. Okay? And lastly, if there is any quality indicator to check on that thing. Okay? Whenever you want to put in place any program, spend some time in planning. Okay? Heard of this guy called Brian Tracy, anyone? Okay. He's got a famous dialogue which says, 1 minute spent in planning saves you 10 minutes in implementation. So plan it out. Okay? Because we finished the workshop today, go back, make your notes, but don't write your SOPs. Go back to your colleges, hospitals, spend 3-4 days, plan out what you're going to do, then write your SOPs. You will find the later implementation much easier. Okay? All right. Focus groups. Now, this is something where I'll start sharing what experiences we've had. This was way back in 2006 when I had joined her, and of course in 2002, and I was about 4-5 years old in the system. And we didn't even know something called antimicrobial stewardship existed. That came much later in 2016-17. So that time we had a very dynamic intensivist, Dr. Shiva Iyer. I think he's in Bharti right now. So in fact, he was the reason why I started taking rounds in the ICUs, because he was one of those people who was very sweet and always encouraged the microbiologists to come into the wards. So that time we realized that surgical prophylaxis was all over the place. People were giving whatever they wanted just because some MR who was propagating cephalosporin sulbactam knew everybody. Everyone was giving cephalosporin sulbactam for even a hernia or something like that. So he said we need to tackle this issue. So what we said is that, okay, let's tackle it. How do we do it? So we said we'll have focus groups. So for 1 month, every Sunday, we met different groups of surgeons. First Sunday was general surgery. Next was orthopedics. Next was GI, and so on. So all we did at that time was show them the guidelines, show them the data, and tell them that, look, what you're giving is excessive. You don't need to do that. Please come down to cefuroxime. Okay? And 100% didn't agree. But at least 50% did agree. Because somewhere along the line, now these people also attend conferences. They also know what other people are talking about. So they know that, okay, what you are talking is not something which is totally nonsensical. So a lot of them agreed. They moved on to cefuroxime. Now that time cefazolin was what was recommended. It was also available at that time. But at that time, people were not comfortable with cefazolin. So here is where the component of flexibility comes into your AMS program. You cannot be too rigid. If you are rigid, nobody will listen to you. You're going to fail. So we shifted to cefuroxime, saying, okay, we'll give cefuroxime. I still remember one of the orthopedic surgeons came and argued with me saying, why are you putting cefuroxime? Because he was one guy who used to give a single dose of Reflin and Genta for even his TKRs. Way back 2006. So this is where you may see some people. Now when you see people like this, make an example of them. When you talk to other people, say that, okay, this guy is giving a single dose. His SSI rate is almost 0. So it is possible. Okay? Alright. Now always remember what even Dr. Kumar said, you have to make the clinician your friend. Okay? One-on-one discussions are always better than group discussions. Because in a group discussion, once 2 or 3 people say that, हाँ ठीक है तुम्हारा guideline जो है, like you said, AC room में बैठ के वो बनाया है, Indian के लिए नहीं चलता है, इधर हम लोग वार्ड में क्लीनिंग करते हैं, वो घर जाके फिर वो 3-3 4-4 दिन नहाता नहीं है, इन्फेक्शन होने ही वाला है. So all this kind of arguments, once one person takes it up, everybody else follows suit, and very soon you'll find that 5 people who came to the meeting with a mindset that, okay, I'm agreeable to change, will not change. So always one-on-one or a focus group. 3 people, 4 people, 5 people. Okay? Don't make it a big group. Alright. Catch hold of the key opinion leader. Okay, like somebody had mentioned the intensivist. Most important person, because that person excuse me, dictates everything that happens in the ICU. And ICU is one of the places where maximum use or abuse of antibiotics takes place. So you get the intensivist on your side, 70% of your work is done. Okay? A management buy-in always helps. So when we had those focus meetings, at that time I remember our medical superintendent, Dr. Prasad, who's now in UB, used to attend every meeting. It was only for 2 hours every Sunday, but he used to make it a point to come in. And just seeing him there, he would not say a word. He would just sit there. But just seeing him there made a big difference to all the consultants because they knew that we mean business. So, key opinion leader who's preferably a clinician consultant, okay, and your management part. Let them just come and sit there and sleep. That's fine. But let the consultant see that, look, management is okay with this. Alright? Alright. Conduct a study. Now here, moving on with the same issue of surgical prophylaxis, we had Dr. Unni, who was our chairperson of the HICCM at that time, and she had a student under her for DNB, and she said we'll do a study. She agreed immediately to cefuroxime for LSCS. All the others were giving 5 days, 7 days, and so on. She and a couple of others said, okay, we will try with cefuroxime. And one of her students actually conducted the study where for almost a year, they looked at the SSI rate in those people who had cefuroxime and those people who were being given antibiotics for a prolonged period. And the results were striking. SSI rate was the same. No difference. Okay? And this is what you will probably see, or it may be marginally more in the single dose. But what we found was the organisms that were growing in the single dose tended to be more sensitive. And thereby, oral options were available. So this was something that came out as a surprise to us. And once this study was done, we showcased it to everybody else, and the remaining 10-20% who were there also converted to cefuroxime. Now they didn't give it for a single dose. I agree with that. Okay, 100% compliance nahi hone wala hai. But at least they used to give it for 1 day, 2 days, or 3 days and stop at that. At least it was not 5 days, 7 days, and it was not a third generation cephalosporin. So that itself was a big victory for us. Okay. Whenever someone agrees to what you are suggesting, please support them wholeheartedly. Now here again we spoke to the management and said that anyone who gets an SSI, for somebody who's giving a single dose, we will not charge for the cultures. We will do the dressings free of cost. So automatically this became an incentive for people to say that okay, let's try it out. Agar infection hua, to kam se kam patient ko kharcha to nahi hoga. Okay. We were discussing and with them continuously. Now in between, one of the obstetricians had an outbreak of few SSIs in LSCs, and she came in barging, and she's one of the more vocal ones. So she said that cefuroxime is not working. At that time, this concept of cycling was still hot. So she said, oh, we need to change, every 6 months, this, that, and the other. Tried explaining to her, but she didn't budge. So finally I said, okay, what we'll do is, for 3 months, you stop cefuroxime, and we'll go on to amoxicillin. She was okay with it. Meanwhile, what we found out was, there was a new crop of residents who were doing the closing. So, at the same time, we also told them that if the residents are closing, they have already assisted in the surgery, they will go out, remove their gloves, scrub again, wear a fresh pair of gloves, and come back into the closing. After 3 months, her SSI rate came back to 0. She went back to cefuroxime. So somewhere this discussion and dialogue has to happen with those people who are accepting your suggestions. Okay? You have to be flexible. Now at that point in time, if I would have said, no, you're not going to give amoxicillin, you will give only cefuroxime, she would have said, to hell with you. I'm giving cefotaxime. Maybe 5 days, 7 days. So I would have lost that one consultant who now is conforming with what we are recommending. Okay. Don't antagonize. Around that time, we used to have dialogues or talk to a lot of surgeons. And one of the surgeons was notorious for giving it for 5 days. And when I told him, sir, up a single dose dero, and he was like, yes, we are following what you're saying, absolutely 100%. Now, I knew that he was giving it for 5 days. But I couldn't tell him that, sir, mujhe pata hai, aap nahi de rahe. So, my dialogue was simple. Right? Sir, it is very good that you are following, but people are still giving for 5 days. It is an unnecessary waste of antibiotics. So, what happens is, indirectly you're trying to tell that person that, look, I know, I'm not going to say it, but please follow in that. Eventually, I think he went down to about 3 days. He didn't go to single dose, but he at least reduced 2 days. Okay, somewhere in reporting also sometimes, you have to be a little flexible. Now, one of our physicians actually starts off with meropenem every time there is a UTI. Priya's having a nice laugh because she knows exactly what I'm talking about. So he wants meropenem in the report, even if it is cephalosporin sensitive. So we released one report without the meropenem, and sure enough, he called. Said, I've told you I want meropenem. Why are you doing this? अरे patient को explain करने को बहुत difficult जाता है. I said, yes sir, okay, we'll report the meropenem, but you shift to cefotaxime. Yes, I'm shifting to cefotaxime. So we reported the meropenem for that particular time. We amended the report. Next time, we don't report the meropenem. So eventually, at some point, he will also lose. That thing of calling and say, okay, chal bhai, sensitive hai, I'll give cefotaxime. But in some places, we have to understand that the clinician also has to face the patient. Where the patient can very well ask that, you started on meropenem, the meropenem is not there in the report. So if he calls you up, if a consultant calls you up and says that, boss, isko please report kar do because patient pooch raha hai, accept it. Make that change. Okay? But don't do it as a routine. Alright. Sometimes you need to follow the process. This is the role of QIs. Sometimes you need to follow the process to check what is happening. This was actually a feedback that we got from one of the consultants who was sincerely following the cefuroxime for 1 day for all his cases. And he told me that my patients are getting 5 days of cefuroxime on discharge. I said, but so you are writing the discharge summary. He said, no, I'm not writing it, but they're still getting it. So then we went and found out what is happening, and we realized that for the discharge summary, there is a copy paste that happens. So by default, even if the consultant would not have written antibiotic in the discharge summary, 5 दिन सुपासेफ का लग गया है. ठीक है? The other issue which we found out was, if someone wrote Supasef for 3 days, they used to do it for 5 days. Why? वो strip 10 का है. तो 4 टैबलेट वेस्ट जाते हैं. So these kind of challenges you're going to find out. Okay. Now we are trying to speak to the pharmacy to give them a strip of 6, but there is a big issue with cut strips because they need to give the expiry date and all those details, batch number. So this is a fight which is going to be a long drawn out one. Okay, case study. I want feedback from you all now. Urologist gives surgical prophylaxis of levofloxacin for 15 days post a cystolithotripsy procedure. We have this consultant among us. Not here, but how will you tackle this? कैसे tackle करोगे? See, this is something that you're going to face. So what is it that you would like to, how will you tackle this thing? This case. Do you want to send him a message? Do you want to send him an email? Do you want to send him a court summons? Handshake stewardship. Okay. Communication. How will you communicate with him? You meet him on the ward rounds and say, hey boss, tu kya kar raha hai yaar? 15 दिन क्यों दे रहा है? Call him. Okay. You think he will answer on the phone? How will you tackle this? Now see, most of your role as an antimicrobial stewardship proponent is going to be handling these kind of things, which are more difficult. All this what we have discussed is simple, very simple. But the problem comes in when you have to convince somebody to change. So ideally what I would have done is call this guy for a cup of tea. Okay? Exactly, chai pe charcha. Talk to him about issues of MDRs, XDRs. American Association of Urology guidelines says single dose of fluoroquinolone for this procedure. In fact, they recommend ciprofloxacin, not levoflox. Third point, levoflox is an anti-TB drug. Do you want to really give it here? The Indian government is serious about stop TB. I think 2025. Now 2030. So you only have 5 years. और तुम 15 दिन दे रहे हो. So this is how you will try and tackle it. Now he may not listen to you. He won't give single dose. Believe me, he won't. ठीक है. What you need to tell him is, सर 15 दिन मत दीजिए ना, 7 दिन देके दीजिए. 1 महीना या 2 महीने 7 दिन देके देखिए. अगर इन्फेक्शन होता है तो we will support you. Give him 2 months. Let him come down to 7 days. No infections, which he most 99.99% he will not get. Call him back. All fine. चंगा सब. 7 days का सर 3 days करो ना. So what are you doing? What is your aim? Is your aim getting him to change to single dose today, or getting him to change to single dose after 6 months and following it for life? That is our aim. So this has to be slow and steady. Okay? All right. This is something that we had got during one of our focus groups. Antibiotics for dengue. And this I still remember I was taking a lecture for the residents, and residents are usually a little more amenable. थोड़ा उनको क्या बोलते हैं, बच्चा भोटिंग कर सकते हैं, which you can't do with the consultants. मटका कच्चा होता है. So that time क्यों दे रहे हो? What is the sense? And then one of them actually came over with this saying that, sir, leukopenia है ना, तो immunosuppression होगा ना. That was the first time I heard of this as an excuse. And he was not wrong, probably because his concept was that WBCs are going down, and we've always been taught that neutropenia hoga to immunosuppression hai. So he just put 2 and together and got 22. So this is how are you going to tackle this? Jaldi. Yes, chai pe charcha. Your clinician has to be your best friend. Once he's your best friend, चाय छोड़ो रास्ते में मिल जाता है तो भी बोल सकते हैं ये बंद कर, and he will do it. But to reach that level, you need a lot of hard work. ठीक है? And it will take time. So again, same thing. Immunosuppression is not caused by the leukopenia that happens in dengue. Dengue is a viral infection. Bacterial secondary infections are not very well known. So antibiotics मत दो, because again, antimicrobial resistance is an issue. ठीक है? Okay. All right. So finally, first chart out your plan. Okay. Write out your SOP. Involve the clinician and the management. Go slow and steady. Okay. Remember, this is a give and take relationship. ठीक है? No dictatorship here, unless the hospital is yours. In which case, do what you want. People will have to listen to you, and be patient. Okay, good things take time. Many times, we are living in an instant world, where we take an effort of 1, we expect 10. बराबर. So AMSP भी हमको लगता है कि अरे हमने आज 1 घंटे का काम किया, मतलब अपने को 2-3 घंटे का तो बेनिफिट मिलना चाहिए. ग्राफ ऐसा होना चाहिए. बराबर. लेकिन अनफॉर्चुनेटली the graph is always like this. There is always a lag period. You have to slog for the next 6 months. You will see no change. Nobody is listening to you. If they see you coming from this direction, they'll go in another direction. अरे ये बहुत एंटीबायोटिक का बात करता है. But there will be a tipping point. Anyone read this book called Tipping Point by Malcolm Gladwell? Nice book. Please read it whenever you can. Old book. There is going to be a time where suddenly things fall into place. And then your graph is going to shoot up. You have to be patient till you reach that stage. Okay? Today, wherever we are in antimicrobial stewardship, I'm not saying we're at a very high level. We're at an average level. But that is because of efforts that have started from 2006 onwards. So it is not that, we've started in the last 1 year and suddenly we've got so much. It has been the contribution of various consultants who've been there. Our first ID physician, Dr. Bharat, came in 2009 or 2010. There have been multiple people who have been involved in this. It's not only one person. It's always a team. So take people along with you and the time is right. Why is the time right? You'll have heard of UNGA, the United Nations General Assembly. For the second time, after 2016, this year, they discussed antimicrobial resistance as a major issue. Few weeks back or a month back, there was a meeting in Saudi Arabia where they came out with this thing called Jeddah commitments, where they expect every country to commit to certain things as far as antimicrobial resistance is concerned. So there is a lot of political awareness. Okay, sir had also mentioned about the Mahasar, that is the Maharashtra Surveillance of Antimicrobial Resistance Network. Dr. Joshi has also been part of that, and so there are movements which are going on to create awareness of antimicrobial resistance. So this is perfect for you to talk about in your hospitals. It's very unlikely that somebody will not know or not have heard of anything. Okay, there are multiple guidelines, which was not the case way back in 2006, 2005. There are multiple workshops that are happening. There are free webinars on YouTube. So please avail of all these things and take the opportunity. Finally, क्या बोलना है? लोहा गरम है, मारो हथौड़ा. Thank you.
Thank you, sir, for your quick and interesting exercise on developing antimicrobial stewardship program. Your knowledge and experience truly enhanced the session. I think such exercises are needed, and you should try to do it at your own institutions. Now, moving on to panel discussion, I request Dr. M. Kumar sir, Vaibhav sir, Priya madam, Monica madam to come on stage for panel discussion, and I would like to welcome Piyush sir to moderate the session.
The response, as Dr. Vikram mentioned, things started improving, and now people do call me up to ask for changes in antibiotic or with reference to any result that I'm putting out. So you should know you are available. Number two, have a backup. Sometimes you're on chutti. If you're on chutti, it doesn't mean that the stewardship has to go for a 6. So your backup should be able to tackle those questions and requirements that come up.
And surely, like you were saying, taking rounds helps, because the first argument from a clinician is मैं patient देख रहा हूँ, तू lab में बैठ के बात कर रहा है. So once they start seeing you in the wards, they know that you are assessing the patient yourself, and you know what is happening at the ground level.
In fact, I was mentioning in the morning to you, maybe the consultant gets to see the patient once in 2 days or 3 days. If you are going daily or you're getting inputs daily, you would be probably able to get a better graph of how the patient is proceeding. And secondly, you have instant access to all the investigations that I mentioned. So not just your culture, but the ancillary investigations also make sense. So wherever there's a graph which is going up, you can always intervene and try and de-escalate or stop the antibiotic. That is where it starts. That is where it starts. But then it is not to be tackled in that way. Dr. Vikram did mention in the morning. You got to gradually grab the low-hanging fruit first, instead of just directly trying to intervene. That direct intervention, especially in ICU, take it with a pinch of salt. Start slowly and then go ahead.
So although it is started slowly, but whenever such condition arises,
so that is where the flexibility comes in. You have to give a bit of leeway to the clinician.
And that's the place where you need management support also.
Yes.
That he has the authority to discuss with you about this thing. Otherwise, this we faced with CPs initially. Like all of a sudden, 2-3 years back, a team of CPs joined. They were taking around, they were seeing files and they were discussing. Tu kaun hai? Who has allowed you to see my patient's file? Why are you interfering? All these things start, but then once they have multiple interactions, they develop confidence in that person. And secondly, like sir was mentioning, don't start with septic shock and sepsis patients कि मेरो ही क्यों दिया, इसको पिप्टास करो, कोलिस्टिन क्यों दिया, मेरो करो. You start with surgical prophylaxis. Start with dengue patient, chikungunya patient, please don't give antibiotics. Start from there. There people are more likely to accept. Start with enteric fever. Just stick to ceftriaxone, don't give BLBLs and carbapenems. So such relatively less complicated cases, they'll start listening. Once they develop confidence in you, then they'll start listening even in more complicated cases.
And they have to trust your reports. So while you are doing all this, your lab should be shored up. Your quality control, your reports that are going out, they should develop a trust in it.
If I may, the innovations they are at times amenable to abuse. The softwares, the portals, etc., that are being developed. Many times people tend to develop shortcuts. कि जो भी clinical history and the treatment line and everything that you need to have, software में available है in the form of prepared summary. So many times the microbiologists tend to go into that shortcut कि इस software से history लेना है. So like sir said, go on the floor, see the patient file, interact with the clinician, then judge whatever history or details you are having with you, whether they are right or wrong. There is no point in using the shortcuts in that case. So
In fact, in the file also, you will find at times the notes are not complete. Sometimes you may look at the investigations as well as look at the patient, then compare and come to your own conclusion rather than picking up from the notes as such.
One-on-one interaction with the patient also
As well as
See, this now builds up over years together. Like when you're reporting, if you're speaking to certain consultants, usually you'll be speaking to the urologist more often, you'll be speaking to the physician or the intensivist more often. Over a period of time, they will develop some trust in you. Overnight, this does not happen, and then gradually they start actually agreeing to what you're saying. You cannot actually directly say don't give this drug or give this drug because we don't have the entire clinical spectrum in our hand that time, but you can only gently suggest that, sir, see, this is also sensitive, cephalosporins are also sensitive, see if you can de-escalate it to from a BLBLI to a cephalosporin if it's possible. This is how you suggest it. You can't take decisions initially.
And that is where we're going to speak about designing an antibiotic policy. While the antibiotic policy is being designed, do not do it alone. Take the relevant specialties into confidence. Do it in their presence with their inputs. That is when you will arrive at a consensus. Otherwise, it will seem as if something is being thrust on them.
Yeah, so moving on to Dr. Vaibhav, sir. So in all these things, what is the link or role between infection control and AMSP?
I think Sir has already covered it in the morning session, but I would just like to add a few things to it. Like Sir already mentioned, AMSP and infection prevention, there are not two different things. They are just two sides of the same coin. So either ways, AMSP cannot go ahead without the help of from infection control activities as such, and the infection control activities themselves are also paralyzed if AMSP is not being followed properly. So important, you can say, connecting links between the two. I would not say ki infection control activities they help in AMSP. I would say the connecting link between the two, connecting links between the two. So they include one is surveillance, as I was about to mention my presentation, but that thing got skipped. So for example, there are some patients who are immunocompromised, some hematopoietic stem cell transplant recipients or neutropenic patients, or we have recently started one project in one of our NICUs wherein we get after a few you can say weeks of hospital stay, some MDR they are developing either as an infection or colonizer, whatever. So certain patients can undergo surveillance activities. So these surveillance activities can give you, though you're not supposed to treat each and every MDR, but you can at least get a baseline MDR of your particular area. So these surveillance activities in the form of culture and also environmental surveillance whenever outbreak kind of situation or routine surveillance activities happen. So surveillance is an important connecting link between the infection control activities and your AMSP. Other thing is trend analysis of your MDRs and XDRs. So what we normally do is we analyze quarterly antibiogram, which includes two things. One is in general the total antibiogram, and second part is the trend of the MDRs month wise, floor wise. So each floor, suppose ICU third floor, month of July, August, September, what has been the MDR rate in general and particular specific MDR organisms like Acinetobacter or Klebsiella, whatever. So that trend analysis, that again becomes a connecting link between AMSP and your infection control activities. And of course the entire antibiogram to be discussed with the clinicians, Being a microbiologist, you are by default a member of the infection control committee, wherein the antibiogram is presented and that is discussed. That helps in updation of antibiotic policy, which is an integral part of AMSP. So these are the important connecting links I feel between the AMSP and infection control. To add to it is also isolation practices. Whenever we get MDRs, may not be treated, but the MDR being present as a flora of that particular patient warrants an isolation, though not treatment. So isolation practices, again, since it comes under the ambit of infection control practices, that becomes a connecting link between AMSP and your infection prevention practices. So I think these are important aspects. Otherwise, everything is connected, but most important links are these three. Yeah.
What we do here is every time we have an XDR or an MRSA or any of these, we always inform in the ward, or we also inform our infection control nurse. She will ensure that the barrier practices have started for that patient. So that is one practice that we do here. Our report also always mentions it.
Particular, you can say MDR kind of bugs like Clostridium difficile. If we get certain bugs like this, the cleaning practices, which again come under infection control, they change. You cannot use routine disinfectant surface cleaning practices for C. diff kind of bugs, wherein you need to go or switch over to hypochlorite kind of thing if you are not using already. So these things also form an important link.
Yeah, so now extension to what Dr. Priya discussed in her talk. When you isolate an XDR or a PDR in a patient who is catheterized or who has, say, endotracheal tube, TT, then what next actions do you take?
So, first of all, for a catheterized patient, we know that colony count as low as 10 raised to 3 is significant. Correct? So, what, like I said, the first thing is always make a gram stain of all the cultures that you've gone through. No pus cells, and you're getting a colony count 10 raised to 3 and above. You have to follow it up. But there is a possibility that if the catheter has been in place for a long time, it could be a colonizer. So it's best to call up the clinician, speak to him that this is what we have isolated. Sir, how is the patient doing? Is he symptomatic for UTI? Is he spiking fever? Okay, if they say, no, the patient is absolutely fine, then all you have to do is tell them, sir, we are releasing this report, but consider sending a fresh sample after changing the catheter, or give us another midstream urine sample after removing the catheter. So the catheter colonizer can become a pathogen in the future. So this is what we suggest here. Whenever we come across an XDR. In endotracheal and tracheostomy tube also, now there are multiple things, whether the patient has been given an antibiotic before the tracheostomy secretions come in. Again, history. How is the chest of the patient? Call up the ward, speak to the resident doctor or the clinician. Do you think, then they say, oh, the chest is very bad, but you have a Klebsiella and colony counts which are very low. So there again, gram stain, if there are lots of polymorphs and you have a growth, even if it's less than 10 raised to 5, we still follow it up. And we do report it. Again, we always write the colony counts and all the respiratory tract infections to help the clinician realize it could be a colonizer if the patient's chest is clear. Okay.
As a clinician, I would like to add 2-3 points here. One is what sir mentioned in the morning. Here comes the role of diagnostic stewardship. Like when you call back the consultant and he says patient doesn't have urinary symptom, why did you do urine culture?
That is
just for the sake of it. Because in many ICUs, I have seen, especially as you move away from tertiary cares, just because patient is in ICU and intubated, every third day ET culture is sent, every fifth or seventh day Foley's catheter culture is sent. Whenever any device is removed, they send tip for culture. So our lab has stopped accepting any tips of any sort of catheters which are sent for cultures. So that is the first thing.
This is one point which I wanted to stress on.
Yeah.
Please stop accepting catheter tips. Even if the clinician insists, say that it is internationally not accepted. If you have taken out the tip, then what are you treating? That is the question. Better would be to draw a culture through and that tip and then remove it.
Correct.
That culture will give you a better idea rather than culturing the tip.
And what argument we can use with them is, like the ICU team or anything, do you follow the same aseptic precaution while removing what you follow when inserting? The answer is no. So the removal is always contamination. Then they listen. Okay, I'll not send it. Second thing, all these colony counts, which a lot of intensivists and physicians give a lot of importance to, actually we need to understand that statistically speaking, they have excellent negative predictive values. They do not have very good positive predictive values. So just because ET or TT shows more than 10 raised to 4, that is significant, or sputum shows more than 10 raised to 5, the person may be heavily colonized because he might be on broad spectrum antibiotics, steroids, uncontrolled diabetic, prolonged hospital stay, prolonged devices, whatever. Person may be heavily colonized. So in such a case, if the colony count is less than that cutoff, that rules out that particular infection. But a higher colony count does not necessarily mean that it is a pathogen. It could still be a colonizer. Those colony counts are for ruling in the infection, ruling out the infection if the colony count is less, rather than confirming that infection is there when counts are high. And as with urine, if the person doesn't have new infiltrates on X-ray, recent worsening in oxygen requirement, although there is fever, but if there are no respiratory radiological signs or ventilator related worsening, there is no point sending ET or TT culture. If I hold a ET in mouth and sit in any ICU for 7 days, Acinetobacter is bound to grow. It is there in our environment everywhere. So that, and so in fact it is double disadvantage, that we are missing the actual problem and treating something which is not a problem at all, which could be a colonizer. Second thing, with urine culture, many staffs, especially in home collections, outside hospital collections, do not give instruction for midstream samples. So you have to look at epithelial cell count and tell them to repeat the sample if epithelial cell count is more than 5 to 6. Similarly, with sputum, our lab mentions that some index, yeah, if there is epithelial squamous cells are more than 25, so you disregard that sample.
Washington Murray grading or Bartlett's grading has to be.
Uh-huh.
In fact, we have tried to apply it for endotracheal tube aspirates also. We have had quite a bit of correlation.
Yes, should not be accepted.
No, if you're taking the device out, then why culture the tip? It's better to culture the blood drawn through the tube before removal. That is better. And to also a second peripheral line. Yes. Or a peripheral culture rather.
That's too bad.
Because if both the same organism not grown from both, then it is not the infecting organism. It's a colonizing organism of the CVP.
Probably the reason why this thing happens, the tip thing is, I would just like to add, we have moved as infection control practitioners from CRBSI to CLABSI latest guidelines, which say no tip needed, central line, peripheral line, and the 2 hour difference, central line flagging first.
That is actually to decide whether it is catheter related or not. But here we are looking at treating the infection.
Yes. So earlier versions of CRBSI in CDC, they used to have this tip plus peripheral. Yes. So probably these people are still stuck with that, you can say, criteria of CRBSI. That training or communication needs to be done from infection control practitioners, that the guidelines have changed now to define it as CLABSI. You need not have a tip to be cultured, then the things will stop.
Yeah, now coming to Dr. Monica, although many places may not have CPs yet, but in Pune now I think many hospitals have, because of NABH and all that, they have started recruiting CPs. Many are NABH accredited and tertiary care hospitals. So what difficulties do you face when you try and tell the consultants about stopping antibiotics?
Well, I guess this is the most challenging part of AMSP, that means to convince consultant to stick to guidelines, because most of the consultants stick to their experience and own prescribing pattern rather than updated guidelines. So at that point, we can't convince them to stop antibiotic or go as per guidelines. Secondly, for surgical prophylaxis, even for the clean surgery, they continued antibiotics more than 24 to 48 hours. So at that time also we convinced them to change at least IV to oral, and their reason is that they want to prevent SSI further, so they are continuing antibiotics.
Yeah, so here I think one common answer which especially senior surgeons give, मेरे 20 साल से मैं अमीकासी नहीं दे रहा हूँ, तू आज का आया हुआ लड़का क्या मुझे बता रहा है. बट सर देन योर काउंटर क्वेश्चन शुड बी, सर 20 साल पहले ESBL और CREs नहीं थे, which is there currently. So you cannot practice what you were practicing in 80s and 90s in 2024. As simple as that.
And
This has practically happened with me. I have my senior who was doing his medicine when I was doing internship. So now when I came and spoke to him, yeah, give me the benefit of clinical experience. I said, sir, that is exactly the statement I made. Clinical experience has got nothing to do with giving antibiotics. Antibiotics, rather your bacteria never listen to clinical experience. They listen to only correct antibiotic.
My
One more-
colleague also experienced the same, means he suggests one intervention to consultant, but she said, who are you? And my experience is more than your age. So at that time, we can't do anything.
A lot of times, I also feel senior consultants, they're so used to doing things their way that there are hospital, in fact, managements which actually bend to their will, and then this suggestion of changes in the antimicrobial prophylaxis, surgical prophylaxis, give this drug in rotation, 3 months ke baad dusra do. All these weird suggestions come about, and they've experienced that this has happened with them in other hospitals. Therefore, they feel that this suggestion is okay. So that is also another challenge that people face.
Anecdotal thing which I also want to mention, it's something like if you have a problem with your ECG, whom will you go to or whom will you be referred to? Cardiologist. If you have a problem with your sugar, ठीक है, endocrinologist, diabetologist निकल जाओगे. थोड़ा mental issues हैं, headache हो रहा है, चलो एक MRI करा लेते हैं. But antibiotic everybody knows. Antibiotic everybody is free to prescribe. So that's the clinical experience which we were just talking about. This has to be broken. Ki antibiotic ke liye bhi there are people available. ID physicians are coming up now. CPs are coming up now. Microbiologist is getting interested. Now I hope all of you are getting interested. So that's important. So only when you show your interest and you show your capability, only then somebody will trust you and listen to you.
No, another thing, in such a discussion, especially with somebody very senior, there comes a point which Vikram sir was stating, that you have to be their friend. So it should not look like you're somebody from the management or quality who is just taking a whip and trying to show your mistakes. You should be part of their team, that as a team we want to do it for the betterment of your patient. Because see, with all due respect, even the person who is prescribing that doesn't want to harm his or her patient. It is just that perhaps it is just medical field is so vast that everybody cannot know everything. Like, because one of our cardiologist persons is here now, the CRR person. So our cardiologists give ticoplanin post CABG and all that, thinking that I am doing something very good for my patient to cover the MRSs and everything. But perhaps they are not aware that ticoplanin takes 3 loading doses 12 hours apart to reach therapeutic level at the tissue. So what that one dose at the time of surgery is going to achieve? Nothing. He is giving it in good faith. Like we all say, it was done in good faith and everything. But then it is more harmful because it is not achieving therapeutic level at the tissue where you want it to be, because it requires 3 loading doses 12 hours apart. So the concentration is only going to come on second day, whereas your CABG is already done yesterday. So there is no point giving such a drug. So when such scientific arguments are done, I don't think anybody, whatever senior, would not buy that idea. But it should be with an attitude that I am part of your team. I am not somebody who is trying to point fingers at you. It should not be restrictive or a sort of a dictatorial this thing.
And according to culture also, they prefer to prescribe broad spectrum antibiotics than the narrow spectrum, and IV antibiotics or the oral antibiotics.
Unfortunately, oral options are quite restricted nowadays. That's the problem.
Yeah. So now, because we had this clubbing of yesterday's and today's session in single day, there was very less discussion on fungals today, which originally we had planned that 20th we'll do bacterial and 21st in the advanced one we'll do more of fungal. So we'll move on to the fungal things. So to Dr. Vaibhav, that do we treat candida in urine or respiratory secretions? Because that is again something as common as Acinetobacter coming in the endotracheal or tracheostomy samples.
Right, so candida in a respiratory or urinary specimen is a tricky thing. It's a very thin path that you can say thin line that you're walking on. Like Padbidri sir already mentioned about clinical history and correlation, that thing again comes in picture here. You have to know about your patient from which the sample has been drawn, whether the patient is neutropenic, whether the patient is immunocompromised or transplant recipient or something. And second thing, the allied things, like for example urine, you have to look at the colony count, you have to look at the pus cells. Same is the case with respiratory specimen, whether the patient is immunocompromised, neutropenic or transplant patient, and what is the neutrophil count in that particular cell, whether more than 24, that's what we follow, more than 25 neutrophils, less than 10 to 15 squamous epithelial cells we consider as purulent, and then we consider whether the sample is to be taken for processing or not, and the count of more than 10 is for 5. So when these criteria are met, then we have a telephonic communication with the clinician first. So and so yeast is grown from so and so sample. If the patient is clinically, the yeast is clinically significant in terms of patient's status, then in that case only it is to be treated. I will tell one practical example of us. I will club it with the long-term catheterization as well. So when we say catheterization as a long-term catheterization, many times the question comes, even NABH assessors also they ask, how many days do you keep the catheter? Do you have a policy to change the catheter if it is a long-term catheter? So guidelines clearly say, literature is available, 5 days plus. Every catheter has got 20% chance of colonization, and so 5 days 100% colonized. So theoretically 100% catheter gets colonized. We tried to do a study at our own unit. We followed 6 months data retrospectively obviously, and how many number of days the catheters were in situ with the organism grown, irrespective of whether that was counted as quaty or not, any organism grown from urinary catheterized sample. So that data when we analyze, we found that 7 to 10 days period is the period after which usually some infection that tends to develop. So that is the period which we defined as a you can say significant days of catheterization. And the organisms that we got in period after that, most common was pseudomonas followed by candida. Most often the candida was not treated because it's a second most common colonizer in our study, and I hope many of you must be having the similar kind of experience. So candida is very much known to colonize the urinary tract and the respiratory tract. You have to correlate with the clinical status of the patient, the colony count, and the purulent status or the pus cells in respective samples, and then only we can go ahead for treatment, or rather follow up, following the sample for reporting, and then next part is treatment.
And a repeated isolation after change of catheter.
Yes.
If you get a second sample after change of catheter which has candida, then it may be taken into account.
No, but even there I would like to beg to differ a little bit, that IDSA guidelines on candidiasis has very clear 4 points, fourth of which also has been removed in the recent guideline, that only these 4 category of patients require candiduria to be treated. They are very clear, and this is there in that guideline since last 15 years. Every update that has continued. One is profoundly neutropenic patient. Second is anybody who has recently, that is that preceding week or so, undergone or is about to undergo urogenital surgery. Third is a low birth weight neonate. And fourth, which is there in 2016 guidelines, not there in the later guidelines, is pregnancy. Any situation other than these 4, candida in urine need not be treated. Whatever is the colony count, whatever number of times you isolate it, because even a simple walk-in patient in OPD who has postmenopausal female, diabetic, poorly controlled, can also grow candida multiple times through her cultures.
It should not be treated, but it should not be reported also.
So that depends on whether you are a standalone lab or you are a hospital attached lab. Hospital attached labs, they have this comfort zone of talking to the clinicians. Must be many who are working in standalone labs, wherein you can call each and every clinician. So simplest way that you can do is, that's my suggestion, you can report no pathogen grown, and with a note, candida grown, advise the microbiology lab for further guidance or whatever.
In fact, I wish we could have shown some reports that we have. So what they do is, Dr. Vikram or Priya ma'am, they write specifically possible colonizer. Additionally, Like when we were at Hinduja, if MRSA grew, we used to get a paper with MRSA culture. That repeat culture after 72 hours, if it is still positive, rule out endocarditis, osteomyelitis, treat as a complicated MRSA bacteremia, etc. Similarly, in these patients, it can be written as a note. Candida in urine requires treatment only in 1, 2, 3, 4. Reference IDSA guideline 2020, 2016. What is the problem? And actually, more often than not, once this is there on the report, patient himself will question the doctor why you are treating. So take advantage of that.
And you are relatively on a safer side since urine culture is considered as a bacterial culture. Even if you don't report any sensitivity for fungus, no one will question
Absolutely
you why
okay.
didn't you
Yeah.
perform sensitivity. You have written down a note, the clinician will call you back, you can discuss, and then you can decide about whether sensitivity is to be done or reported or not.
And same thing now to respiratory tract. So the same guidelines also mention that even in the most immunosuppressed individuals, Candida almost never causes pneumonia. The fungi causing lung infection are Aspergillus, Mucor, PCP, histoplasmosis, none of which has fluconazole as drug of choice, although fluconazole is the commonest antifungal prescribed by pulmonologists even at our hospital. We have fought with them many times, discussed with them many times, but none of the fungus which causes lung infection is covered by fluconazole.
If I may, I would like to throw a counter question to you. Some of the clinicians they come up with beta D glucan value leveling at yeah, this suggests invasive candidiasis, so we need to treat. Any comment about that?
Yeah, so if the so there again we go to more like guidelines about invasive candidiasis. So there, if you have a high risk subject, so HSCT, hematological malignancy, solid organ transplant, onco patient on chemotherapy with neutropenia, dialysis patient, multiple devices, prolonged stay, broad spectrum antibiotics, steroids, TPN, pancreatitis, and so on. So if any of these factors are there, so the person's sheer chance of getting invasive candidiasis is high. So there a positive beta D glucan may mean you will start preemptive treatment, but there the source has to be searched either intra-abdominal or in blood or at sites where candida is known to cause infection. These colonizations in respiratory tract, urinary tract, stool for that matter, candida is there in intestines. Okay, it's normally there in our intestine. So this can only add up to your candida colonization index to again calculate whether the person is at higher risk of invasive candidiasis. So they can be just counted as one of the colonizing site and not as a evidence of infection. That positive BDG, if the BDG assay, again that will come to in next question, that like which BDG assay is reliable and which is not, because that again comes under the purview of microbiologist.
Could you please comment on Candida score? Because that is
Yeah,
very
so
beneficial.
then that way with these risk factors, then colonization index, so all this Ostrowski Jishner or Candida colonization index, these things can be used bedside in this group of patients. And there again we go through the thing that sir was asking in the morning, what is empirical? So prophylaxis, empirical, preemptive, targeted or definitive. So person has extremely high risk on prophylaxis like HSCT and all that, where the neutrophils are technically zero for the initial 2-3 weeks. Person has high risk and has developed symptoms, you are yet to get any biomarker or culture or histopath empiric treatment, which we would ideally not want, because that is what leads to more like misuse of antifungals and more antifungal resistance, and their options are even lesser than antibiotics. There are hardly 4 or 5 classes. Third is what we ideally want, and which is followed in many centers, even in BHSCT and onco, is preemptive treatment. So you have a high risk patient, biomarker comes positive, start treatment, and parallelly send all the samples before starting antifungal, because like pathophysiology wise speaking, BDG is supposed to come positive even before clinical symptoms and signs develop, the way cryptococcal antigen is supposed to come positive even before meningitis signs develop. So the way in HIV, so we'll use analogy, the way in HIV for CD4 less than 200, positive serum CRAG warrants reflex CSF testing even if the patient is asymptomatic. Same way, in a high risk patient for invasive candidiasis, positive BDG should warrant cultures and sampling to rule out invasive candidiasis. But that won't be urine and chest, because those are not the site where candida causes infection. It will be in necrotizing pancreatitis, so intra-abdominal collection could be there, some hepatosplenic could be there, blood culture positive could be there, spine could be there in dialysis patients, endocarditis could be there. All these are common sites. If neurosurgical patient, then only meningitis, otherwise even their candida is not such a common cause.
One more question. Suppose we receive some respiratory samples, we perform gram stain and ZN, we found multiple pseudohypes there, then what's it?
Same thing.
Colonizers, and mostly you have oral thrush also, so that can contribute to the candida release.
For culture, you have a liberty of whether to follow and report it or not. For direct staining, I think you do not have that much of liberty, that you are seeing and you are not reporting. You don't have that liberty, but there you can write the note at the bottom.
Possible respiratory tract colonizer, please correlate.
Yeah. So moving into more details about the fungal biomarkers. So to Dr. Priya, so are there any fungal biomarkers that can be used in helping antifungal stewardship, and how best they can be used?
So there are multiple fungal markers which are available, fungal biomarkers which are available. In our facility, we do beta D glucan and galactomannan. There is also PCR available. There are antibodies specific to for histoplasma or coccidioides and all these other fungi. But what we do here is a chemiluminescent assay, and galactomannan is a pan-fungal biomarker. So basically, it is a polysaccharide present in the cell wall of the fungi. As the fungi multiplies, the galactomannan is released, or beta D glucan, both of them are released in the serum and they can be detected. So we can either do a bronchial aspirate or a serum sample can be run, and we can determine the levels. Now with beta D glucan, the issue is that it is pan-fungal except for Cryptococcus and zygomycetes. All the other fungi can give it positive. Therefore, a culture, like he said, a fungal culture has to be sent for identification of which fungus it is. And in case of galactomannan, it is more specific for Aspergillus species. So then that way it will help. Again, like he said, positive results have to be correlated with the patient's condition, if he's thrombocytopenic or on chemotherapy and other conditions like that. And sorry.
False positives.
And false positives you can get in beta-lactam drugs. If the patient is on any beta-lactam antibiotic, then you can get a false positive. False negatives also you can get if the patient is highly icteric or the sample is hemolyzed. So those conditions can also give a false negative beta-D glucan. Another thing about all of these is that with almost a week's difference is there between detection before the clinical symptoms start.
Yes.
So, therefore, it is very useful, like he said, in all immunosuppressed cases where you can start the therapy beforehand.
So we have a protocol of doing it every third day in HSCT patients. We have a bone marrow transplant unit since last year. So in them, our hemato-oncologist does it every third day. That's what we have collectively decided. Again, there are two things, like I think the standard assay is actually Fungitel stat. What we are using is FASIS. I think Sahyadri also is using FASIS. Although as per the available literature, they say it doesn't correlate so well with the like approved method of Fungitel stat, but then we have found fairly good correlation. So whatever method we use, we should know what is the sensitivity, specificity, negative and positive predictive value. Because am I confident enough to stop antifungal if my BDG comes negative? That is also an equally important question, because missing fungal infection, invasive fungal infection, even by 2-3 days means patient's death. Okay, and then other thing in respiratory tract, Aspergillus and mucor, if you say only the fungal elements, they can be there even without infections. So there, getting a BAL galactomannan positive or serum galactomannan positive along with culture growing Aspergillus would have more meaning than barely the culture saying Aspergillus with galactomannan being negative. With the corollary that galactomannan sensitivity, even in a profoundly neutropenic patient, is only around 80 to 90%. In a non-neutropenic, non-HIV patient, it is only 30%. So you would not really want to stop antifungal if there is high suspicion just because galactomannan is negative. In HIV patient, non-neutropenic, it is around 50 to 60%. So even there, 50% of times galactomannan can be negative in spite of having clinico-radiological evidence of aspergillosis. Again, serum has better sensitivity than a BAL has better sensitivity than serum.
Also,
So,
it is a quantitative test, so also helps in assessment of treatment once it
yeah,
is
especially BDG.
detected. Yes.
And we've used BDG even for say PCP diagnosis and all that, because this staining and all is not always positive. And I'm sure even at Sahyadri, Dr. Raman Gaikwad would have used for histoplasma is quite endemic in our country. So if urinary histoplasma antigen is not available, you can simply do galactomannan on that urinary sample, because ultimately fungal structure wise speaking, it is the same fungal antigen, yeah, pan fungal marker. So
Like sometimes it happens in our lab that electronic test is positive, but the fungal culture is coming out to be negative. Then how to deal with that situation?
So there is a possibility at that time, maybe they're colonizers, they could be candida, they could be in the respiratory tract, or like he said, in the intestine. So many of these can cause the galactomannan levels to rise. But again, I think there is a cutoff. I think more than 80 is when you consider it is
that is
actually could be a
BTG
pathogen.
BTG you're talking. 80 nanograms is
Galactomannan.
for BDG, she's a galactomannan. So it depends on whether you take
How the
0.5 or
sample.
0.8. Huh.
Sometimes the value is so high, like it's more than 2, around 5, but still the fungal culture is coming out to be negative.
Yeah, yeah. So that way, in fact, that is the golden opportunity that the clinical sign symptoms have not developed.
That's
So if
what
the
you
patient is high risk and galactomannan is so high, you should start preemptive treatment.
So that is already
If you are sure of that there is no false positives.
that has already
patient is on antifungal that time showing the tears not or something, but culture is not growing that way.
Yes,
But
that
that's
is possible.
possible because of
Similar
the
can happen with
antifungal.
biomarker
Then it will
also.
not grow, na, because of the
Because some of these
antifungal.
high risk patients could already be on mold active prophylaxis with posaconazole or something, so they may not grow in the culture.
that can be one
That can be possibility. And other thing, for standalone labs, a lot of things also depend on what container was used, how it was
How was it
transported,
collected
and
also?
when it was processed. Because at Hinduja once, when I was there in 2014, so we newly, when galactomannan was available, we found that it was related to the container, that it was coming false positive. And the moment we change the container, all those values started coming normal. Secondly, with BDG, if we see the factors which give false positive BDG, they are almost same as the risk factors of candidiasis. TPN gives false positive, dialysis gives false positive, beta lactam antibiotics give false positive. All these are also risk factors for getting invasive candida. So that we have to do a lot of clinical correlation over there.
One more thing is, I think in such cases, the focus finding happens to be the most important step, because like candida, whether it is respiratory or blood, usually it is a secondary infection causing organism, secondary bacteria, or lungs are involved secondarily. They are not involved primarily, bloodstream or you can say lungs. So primary focus finding has to be exercised very much meticulously in such cases, when you are not actually getting any culture positive, but beta glucan is coming positive or galactomannan is coming positive. So in that case,
I think the next one which I had in the panel thing, I think more or less we have covered that. Are the microbiologists more comfortable with lab work rather than doing ward rounds?
Dr. Vikram has already mentioned two things. One is 10:30 chai pine ka time, and then 1:30 ke baad ghar chalo types. So that is not acceptable. I'll give you my practical experience. I go for a round in the morning, 9, let's say I start on 9:30. Bench round is till 10:30, 11 o'clock. From 11 to 1:30, I'm in the wards. So that is the kind of concept you have to develop. And while I'm reporting on the bench, in case something comes up, I'm always on the phone. So now I'm getting calls from NICU. I get calls from ICU. ये patient का कल हमने भेजा था, उसका क्या है? So real time I'm able to give them information. So unless you get this kind of communication link and trust for the microbiologist, there's no point in sitting in the lab and reporting. वो ज़माना गया. Another anecdote. I was a teacher in AFMC. So one new chap joins up. He must be about 15 years junior to me. हाँ भाई तुमने choose क्यों किया? Because we have that introduction kind of thing at the beginning of the course. So this guy introduced himself. I am so and so from so and so place. Why did you choose microbiology? No, I wanted to have a relaxed life. I'm telling you. नहीं तुम नहीं था. तुम नहीं था. So it was during his batch time. He will remember. So So that is no longer the scene. Micro has become a very active part of clinical treatment. So let us get involved. And the other point about standalone labs, as I keep on mentioning, actually speaking, standalone labs are a great disservice. It's not like biochemistry that you just put in the sample. Again, I'm repeating myself so that it gets into your head. It's not like biochemistry ki sample dal diya, quality control रहता, report निकल गया, हो गया, clinician keeps. Clinician के पास AST पहुंचने के बाद भी कितना problem हुआ, you all had a look. Where cefepime should be used, if you use ceftriaxone in AMP-seed, it's going to fail.
Correct.
Another example that I mentioned of nitrofurantoin being used for pus because it was released in the AST. Another thing is clinician looking for the lowest MIC and choosing that antibiotic. That also doesn't make sense. MIC is a surrogate marker. So if you can convey this to the clinician, only then you will be able to make your mark as a microbiologist. Otherwise, you're just...
So one step further on the MIC part, what Vikram sir has done here at Jehangir is outside of ICU and onco units, we don't report MIC.
Absolutely.
We just report sensitive, intermediate, resistant. If they want, they can call us, call the lab and ask. ICU we report, and neutropenic patients like a daycare sample or onco sample we report. But otherwise we don't report MICs for this very reason, because invariably TG cyclines and linezolid and all will have lesser MICs than actually sidal drugs most of the times.
Linezolid, another thing, we were discussing levofloxacin. Linezolid is again a second line drug, oral drug for tuberculosis, not to be misused. I have had clinicians telling me, surgeons especially, बहुत बुरा wound है, मुझे देना है linezolid. I said, what are you wanting to cover? No answer. बुरा है, देना है. It's a very strong drug. So you can understand the level of knowledge. That you have to improve by going across.
In fact,
you've got 6-7 classes of antibiotics. Rut low. That's all. You know your antibiotics. If a clinician is speaking to you about antibiotic, you can answer him in the same frequency. And you know what your bacteria are, and you know what your antibiotics are doing in the lab. So what they're doing in the patient is what you got to observe and be in parallel with the clinician.
In fact, recently we've actually encountered linezolid resistant enterococci as well. So a couple of them, 2-3 of them have come, and that's a bit of an alarm. Then you're left with nothing to give.
I think the chief guests are going to come around 2 o'clock. So I've got a message that we can actually extend by 10 minutes or so, because 15 minutes lunch won't be over. So if you have any questions, we can continue the discussion. Yeah. Yes.
It gives you with the... Don't have an AST. So one is, no, in our institute, all the transfer patients we screen, like MRSA screening is done, we screen for Candida auris routinely. We take swabs from groin, axilla and nasal. Okay, and as of now...
is in urine also. If catheter is outside, then even urine.
Then urine sample also. So we do screening for the Candida auris strains. When we have this doubt whether it is auris or it is that Dubomishoni, in that case we send it for Malditov. Once or twice we've had to send a strain for Maldi.
Maybe Dr. Vaibhav will have something to add about it. Yeah, because
so I would like to add 2 points in here. One is regarding Candida per se in our very own unit, particularly after this COVID era. 2020 onwards, we started seeing a lot of Candida. Maybe sampling was increased, so we were detecting it more often. So just tried to analyze the things statistically. So what I did was we had a data from 2018-19, 2 years. I compared that data with 2021-22. So 2 years before COVID, 2 years during COVID, and we got to know that Candida auris, like you mentioned, particularly suddenly rose from 4th to 5th place to second most common organism across the units. So that much Candida auris has increased. There were 2 important aspects to it. One is the rampant use of antibiotics and improper, you can say, surface cleaning activities. As the patients were in isolation, the wards were in isolation, unfortunately, though the surface cleaning activities were supposed to be more aggressive, they were actually lagging behind. That has happened universally. Another thing that added to it was emergency licensure of many of the chemicals that included surface cleaning agents as well as the antibiotics and infusion things and other stuff. So these things added to increased number of candida and candida auris per se. As far as the sensitivity pattern is concerned, though we do not have definite, you can say, MIC breakpoints, but CDC already has released in 2020-21 a document in which the references are given from FDA and their consensus guidelines to interpret the MIC breakpoints. They are not standard breakpoints, but you can interpret based on that CDC document that has been released on 2021. And second part is regarding surveillance. If you have a very you can say good system in place wherein the clinicians are not going to treat right, left and center every MDR that is grown, in such settings you can, I would advocate, definitely go for surveillance activities for patients like transplant patients, NICUs, especially preterm population, and the neutropenic patients. In fact, in AFMC we had a project that was done in 2012 to 14, sir. 12 to 14 में हुआ था ना. So I was fortunate enough as a part of residency to have processed some of the samples wherein all the neutropenic patients and the transplant patients, their swabs were taken to identify the VRE and MRSA rates. So these kind of surveillance activities, if you can perform at your very own unit and not treating these patients, that will definitely help you know a baseline. So if at all, suppose in for example in our NICU we have started surveillance stool culture. That stool culture gives us a baseline. If this preterm baby develops an infection some 2 to 3 weeks later, prophylaxis can be started based on this baseline, considering this probable MDR can be a causative agent based on which the prophylaxis can be more apt, more suitable for that particular patient. So surveillance activities in view of Candida and MDR is definitely a suggestible option, provided the antibiotics are not being abused.
Yeah, so that here also with the hematonco unit, with a mutual agreement and discussion, we do stool cultures as a surveillance. Because what happens every time the patient lands up with febrile neutropenia, they receive piperacillin, tazobactam, meropenem, plus minus ticoplanin over a period of time. So if such a patient who was on chemo and now going for HSCT, so we know baseline cultures. So tomorrow if sepsis develops, instead of starting with same meropenem, if I know there is CRE in he is carrying in gut, and gut is the commonest source of GI translocation and bacteremia in such patients apart from the lines. So if the surveillance culture is already showing CRE, we'll straight away go for ceftazidime avibactam plus minus aztreonam depending upon what was the sensitivity. Yeah, he wanted to ask.
Your knowledge, madam and sirs, these sessions were very excellent. I just want to ask Priya ma'am that considering the advantages and limitations of XDRO detecting methods right now, which one we should go ahead in view of no antibiotic available in future? Should we shift to biofire or should we consider with whatever things we have in our mind?
The biofire is a very expensive test. Okay, so to start off with, again, like if you know the trend in your hospital, if there are XDRs which are very frequent, like we know, हमारे ICU से अगर GNB grow हो रहा है blood culture में तो most likely carbapenem resistance आता ही है. So in those cases, like I said, the true rapid test that is there in smaller setups or standalone labs, so that true rapid kit is very useful. It will give you carbapenemase detection directly from the colony within 15 minutes, and it is an inexpensive test. Apart from that, if there is, now depends, if there's a ICU case, patient is very critical or like he said thrombocytopenic or anything like that, then you directly, if you want to run the sample, then biofire is useful. So it depends upon the need of the hour. So if the patient is stable, empirically antibiotics have gone in and all, and you can wait for the growth the next day, then of course you can, depending on the sample, if it's urine or something like that or tracheostomy secretion, which the patient is still stable, then go for the carbar cart test. If the patient is critical, then go for molecular tests like biofire or something like that.
The question was regarding now NABL always ask us turnaround time.
So
Turnaround time for biofire is the shortest.
Around the same, no, shortest is a carbar test, but what I said, depending upon.
No, I think we've got the idea of turnaround time wrong. Turnaround time is individually applicable to every test.
Every test has its own.
Every test. So it all depends upon what kind of testing you are doing to decide your own turnaround time. Turnaround time, there is nothing laid down that culture mein 3 din mein aana chahiye. It did not grow, so you spent more time trying to culture it. That is why blood culture is not declared negative before 5 days. But if an organism grows on the 5th day, then your report is going to go on the 7th day. So your turnaround time has to reflect that.
So turnaround time basically means how much time that test takes to run and give you a result.
No, ma'am.
So
Starting from the sample. I'm sorry,
so
I'm
from the
interrupting
sample
you.
collection,
Sample
okay.
to the report going to the, not inside the lab. Inside the lab is your own measure of how fast you are going to process. So that is where I come to this point of 24/7 processing. It is not कि samples come, they इकट्ठा होते
Dying
रहते हैं,
and
उसके
dying.
बाद line में लगाते हैं. No. Reporting also similarly, if possible, you should be doing it real time rather than waiting for next day morning. I face a problem on Sundays. Non-critical samples are not taken into account. So on Monday morning we come and find एक urine grow कर रहा है, the plate is now full of organisms. Multiple हैं तो उसमें से निकालना ही मुश्किल है क्योंकि वो Sunday को read नहीं हुआ था. It was a non-critical sample. You're getting the point? So that these kind of things, these are nitty-gritties on ground आपको देखना है. There is nothing called shifting over to biofire or shifting over to some kind of methodology till it becomes totally established. These are all not established yet. The only established thing is a culture and susceptibility by automated method. That has got established now. So continue, exploit the benefits of that. There we have tried to kind of shorten the timing by putting in some time points where direct gram stain you can do and then report, or carry out a direct AST till the time your actual AST comes up. That can be reported as a preliminary report. So these are the times which you're trying to shorten.
So I'll add to that. So what we do is sometimes, most of the times when our blood cultures come positive, and on a gram stain, if we see a GNB, now see, blood culture is again a critical condition. The patient needs treatment as soon as possible. So before this carbar and before all of these came, or if the patient could not afford it, we always used to unofficially just plate the sample directly and just put up the higher discs of antibiotics on the MH plate. And you have an idea. So at least you know which are resistant the next day. If it's a meropenem resistant, right away you could do the carbar test, or suggest they can give a BLBLI with astronum or whatever, however they want to start treatment, like that.
Just in addition to this thing only, I would like to add two experiences that we recently had. One is we had got two cases in which this MAC-A MREJ was not detected, which is a marker for MRSA production. In biofire, it was not detected. But in the culture setting, we got MRSA grown. We got two such cases. So now here, since the mutation is outside the target, you can say sequence, that has not been detected by biofire but seen on culture. So difference in genotypic and phenotypic can happen. Second example, there are multiple cases in which genotypically you see NDM, OXA and all that stuff, but phenotypically the same Pseudomonas, same Acinetobacter or same Klebsiella appears to be sensitive on the culture plate. So there, that can happen because of quasi-species or some resistances or heteroresistance, whatever, different concepts. We not go into academics of it, but genotypic and phenotypic differences do exist. So for this thing, the next thing important that we have been emphasizing repeatedly again and again, clinical history and patient status. We usually kind of classify the patient based on immune status, the types of hospitalization exposure they have had in last 30 to 90 days, and major surgical procedures whether or not they have undergone in last 30 to 90 days. So based on that, patient is typified between the you can say critical patient or type 3 patient to type 1, which is non-critical or OP based patients. So based on that, correlating it with the culture and your molecular reports, then only we have to decide whether we have to go for this alert antibiotic to be used, or just to go for the organism as a sensitive one, whether to rely on phenotypic one or genotypic one. So these things have to be correlated.
Yeah,
so
so this
that's
is,
I think
yeah,
because these things, the molecular things, are still till date used as screens. They are not definitive, they are not gold standard. Till date, gold standard is culture only. Right?
we can have that analogous to what we get in TB also. that even your CBNet, only RPO beta, whatever region it is targeting, only those mutations are picked up. And on the contrary, there can be some mutations which are just polymorphisms and which may not be phenotypically expressed. What happens in MTB? Now, the other issue with molecular, like one of the reports which Priya ma'am had shown, it had detected E. coli 10 raised to 4, Klebsiella 10 raised to 4, and the genes were CTXM and NDM. Now, which was from which organism? Because of late most of the tertiary care hospitals in Pune with CTXM 14 we have had E. coli isolates not showing synergy between CZA estrionam but showing susceptible to something like fosfomycin, whereas in Klebsiella, if there is Klebsiella and there is NDM, I know for sure that synergy would be usually there. So again, it doesn't end there. I mean, if the lab says Klebsiella, I am more comfortable empirically Klebsiella with say CRE, then I am more comfortable empirically giving ceftazidimavibactam astronam till the further synergy report comes. But if the lab says E. coli, then I'll be still skeptical because of these things. And other disadvantages is that mechanisms like efflux pumps, porine channel loss, and all will never be picked up, at least in these methods.
Molecular.
They'll just pick up the enzyme related method, this thing, resistance mechanism. So ultimately, like sir was saying, still you require AST. Because some people have this tendency that if biofire बेच दिया तो culture मत करो, culture किया तो biofire मत करो. Both have their own places.
No, culture is mandatory with all molecular tests. That has to be done. Biofire usually is more sensitive. In fact, if the patient has been given an antibiotic, you may not get a growth the next day in culture sometimes. Whereas biofire will detect. But then the issue with biofire is, other than sterile fluids, you can get a lot of colonizers and respiratory tract samples.
Detecting DNA. It's not necessary that it is alive.
It's whether it's viable or not, we don't know. Yes, so that's another.
No, so it is also for the microbiologist at the level of lab to decide what methods you want to have in your lab, because there are at least 8 to 10 other methods wherein that company person keeps on meeting us. ये मेथड कर लो, बायोफायर से आधा कॉस्ट है, वो मेथड कर लो 1/3 कॉस्ट है, and so many such things. But they may not all be many of those are in-house developed RT-PCR platforms, so we don't know exactly what quality checks are being implemented there, how reliable or unreliable they are. Plus many of them are not cartridge based, they are open methods, so the chance of contamination are far higher. So those issues are always there. And other thing related to our previous one of the questions about microbiologists and that thing, I think clinicians should be made aware to insist on a culture report signed by a microbiologist.
Yes.
Whenever I get a culture report in clinic, यहाँ पे तो ठीक है, hospital level पे, institute level पे it is different, but in my OPD patients coming to clinic or OPD, if they bring a culture report where I find something fishy in the sensitivity, I look at who has signed. It will be anywhere from DMLT, BSc Patho to Biochem to MD Path and occasionally microbiologists. So always spend 2 minutes there and tell them you get it from a lab which has in-house microbiologist. I don't want to, because of late, unfortunately, many pathology labs have started feeling that if we get Vitek 2, we don't need a microbiologist, which is not true. Like what you are saying for biochemistry, that may not apply to microbiology.
Not in that criteria, but on culture and on microscopy, if we are seeing gram-positive budding, it's like this, it's pseudo-hyphae. What is the importance of pseudo-hyphae in this?
No, so like Vaibhav sir had said, the smear report you still have to report. You need not carry on with the culture and sensitivity. But smear report, you will still have to give that pseudo-IFA seen on this particular smear.
Yeah, you can comment. You can comment.
Write that comment.
Because pseudo-hyphae means is an invasion sign.
So
Pseudo-hyphae is not an invasion sign.
it could be oral thrush also in that case.
All candida replicate by producing pseudo-hyphae. So it is not a sign of invasion.
Alright, so I think the chief guests are there. Yeah. So any other questions you can discuss over lunch or tea in the afternoon, or we have one more panel later in the evening. So about this particular thing, if you see criteria for healthcare associated pneumonia, or previously what we used to call VAP, they do not have culture as a major criteria. Actually, it is new onset fever not explainable by alternative cause, new onset leukocytosis not explainable by alternative cause, new radiological infiltrates again not explainable by say fluid overload, PE and other things, and fourth is recent worsening in oxygen requirement. So somebody who was on say nasal prong goes to NIV, goes to invasive ventilator, who was on pressure support goes to volume control, that way. And culture is not actually a criteria in HCAP definition. Clinical radiological factor has to be there. Culture is for more for surveillance purpose in those definitions rather than diagnosis of HCAP clinically. And then other thing there, as a member of IC group like infection control committee of your hospital, the other thing you can correlate with is how often you got ET or TT culture showing something positive, and how often your intensivist has signed a form saying we had a VAP. It should correlate. You can't be saying we have 0 VAP and treating 10 Acinetobacters with colistin. I think the chief guests are here, so we'll end the panel discussion now. The rest of the questions we can have in the subsequent panel. Thank you. Thank you all the panelists.
Thank you, Vikram sir. I would now request Dr. Pooja Shah ma'am to please come up on stage and to felicitate Dr. Gill sir and Dr. Jyoti Unni ma'am. Thank you, sir. I would now request Chairman sir, CEO sir, Dr. Gill sir and Dr. Jyoti Unni ma'am to please come up on stage and release the brochures. Thank you, sir and ma'am. I would request Chairman sir to please address us.
Good afternoon, everyone. It's such a pleasure to see so many of you here, and particularly young experts who can take a whole lot of knowledge away. Thanks to Vikram, we've been able to put this together. We love having people over from multiple hospitals, multiple spheres of clinical practice. So particularly happy to see you here. Thanks for the brochures, and the way they are packed, I doubt any microbe could have got in there. As we all know, this is a major struggle that the entire medical world, all over the world, has been facing, antibiotic resistance. For us, it's, well, I'd say unfortunately, it's been nothing new for us, because right from 2007, Vikram has been leading the whole charge against antibiotic resistance with a whole lot of steps that we have continued to put into place and gone on developing them. It was well before the term antimicrobial, what, how do I say it? I don't even know it. Antimicrobial stewardship was even coined. So really the term means nothing much to us because we've been at it for much before. And it's really a scourge and it's something which is scary. It is scary every time that we feel that we are unwell, and there is a tendency, fortunately, among a lot of our doctors here to avoid antibiotics. But one is scared that when the time comes to take it, and you have to take it, whether it will work, how long it will work, how many years it will work, how many generations it will work. So we have to be acutely aware of what we need to do to fight this. This is something not like a COVID that comes and goes. This is something that we have to face right throughout. And God knows what new things will be there, what new things will have to be fought. Or what we can do is we can anticipate. We can have very strong SOPs which will anticipate and be able to fight this scourge. So I'm really happy that all of you are here, and knowing the kind of speakers that we have here, I'm certain that you will be able to carry away something from here. But the main thing is not just to carry it away, but to implement it rigorously in all the areas that you all work, in all the institutions that you all work from all over the country. And Dr. Vikram is always available. So if you need to connect with him, he is always available, to ever ready to provide any kind of support with the tremendous experience that he's had over the decades. So I'd like you again to wish you all the very best and wish you great success in this very important fight, which is not seen every day by the common person, but is so important. And I think you need to highlight it to the clinicians that you all work with, that to be a little restrained in terms of prescribing antibiotics, and conduct sessions in your hospitals to show why this is so. So once again, I thank you all for being here, and I'd like to wish you all the very best in your endeavor to fight this. Thank you.
Thank you, sir, for your wonderful words. Sir, please be on stage. We would like you to felicitate Dr. M. Kumar, sir. We are felicitating our speakers. Thank you, sir. I would request CEO sir, Mr. Vinod Sawantwarkar sir, to felicitate our speakers, Dr. Sangeeta Joshi and Dr. Vaibhav Dudhat. Sir, Dr. Vaibhav Dudhat. Thank you, sir. I would request Dr. Gill sir to felicitate our speakers, Dr. Piyush Chaudhary sir and Dr. Priya Dumar ma'am. Thank you, sir. I would request Dr. Jyoti Unni ma'am to felicitate our speakers, Dr. Monica ma'am and Dr. Vikram Padbidri sir. Thank you, ma'am. I would request Dr. Pooja Shah to please come on stage. Dr. Vikram sir will felicitate her.
Just one word. Dr. Pooja has tirelessly been working for the last few days, and she's actually made our job much easier. She's the one who's done all the running around in addition to my team here. So please let's give her a big round of applause. And remember, I told you all about the obstetrician was heading the Department of OBGY who had done the study. Dr. Unni ma'am is the one who's started off the whole thing in 2006, 2007. Thank you. We'll now assemble outside for the group photo, after which we'll break for lunch. Okay, I'm sure all of you are quite hungry. The food will just taste that much better.
Welcome to all once again. Have you all enjoyed your lunch? It's my pleasure to welcome again our next speaker, Dr. Vikram Padbidri sir, who will be presenting an essential topic in microbiology and clinical medicine, Introduction to Antibiogram and Antibiotic Policy. In today's talk, he will be providing a detailed overview of antibiogram, which is a crucial tool that helps in the clinician guide the appropriate antibiotic choices. He will also discuss the role of antibiotic policies in healthcare settings to optimize the antibiotic use and reduce the antibiotic resistance. So, welcome, sir.
Okay. We're already running extremely late, so what I'll try and do is I'll quickly run through this presentation because more important than this, I want you all to actually spend time on the WHONET program. Antibiogram guidelines have been outlined by the CLSI M39 guideline. Okay? Anyone has this M39 guideline? Who has? Anyone knows how to get it without paying? Anyone wants to know? I think 2-3 years पहले का है. So M39 is available on Script D. Will you have heard of Script D? SC, just go to Google, type in scribd, okay, .com space CLSI M39. You will get the whole thing. You may not be able to download it, but you can read it on the Google browser. ठीक है? तो खत्म करें यहाँ पे lecture. Okay, someone had told me long time back that instead of feeding somebody, you teach a person to fish. You feed him for life. So मुझे लगा अगर तुमको स्क्रिप्ट डी का बोल दिया तो मुझे कुछ बोलने की ज़रूरत नहीं पड़ेगी. ठीक है. Anyways, okay. Now, what was mentioned in the morning by Dr. Kumar is that an individual report is called as a susceptibility report. Sometimes we call it also as an antibiogram. Okay. But what we mean by an antibiogram is actually a cumulative report which is comprised of multiple people or multiple reports which come together. Okay? So when you give out an individual report, you are benefiting that particular patient. But when you put together all these reports and analyze it, you will be benefiting multiple patients where an empiric treatment is required. So CLSI M39 is the guideline. What is antibiogram defined as? Generated annually, okay, for a single healthcare facility that summarizes AST results for that facility. Also called as a cumulative AST data report. It is antibiograms which is used to refer to other types of reports that contain cumulative AST data. I'll get into this in a little bit of detail. Okay. So right now we look at antibiogram. Okay. These are the rules for antibiogram. One is present at least annually. If you have adequate data, you can present it 6 monthly. Include only diagnostic isolates, no screening isolates. Alright, only verified final isolates. Okay. Now most important, include only the first isolate of the patient regardless of the specimen source. Okay? Madam will show you a little later in HUNET how you can select out only the first isolate. Include only species with more than 30. 30 is the magic number, statistically significant. Okay? Include antimicrobial agents routinely tested against the isolate for both reported and suppressed antibiotics. And report only percentage susceptible. Suppressed means what? Remember we had spoken about cascade reporting and selective reporting. So antibiotics which have not been reported in the patient's report should come into your antibiogram. Okay? And we'll discuss a little later why. Okay, so what information do you require for this? You need patient demographic information, age, sex, okay, maybe which ward he is in, specimen info, कौन सा है? Urine है, sputum है, catheterized urine है, midstream urine है, okay, organism info, name of the organism, genus, species, and then the AST, detailed AST, okay. So usually when you have a database, I'm presuming that most of us are going to use HUNET here. There are various sources from where you can get this. One is the AST instrument, like for example your Vitec. Okay, the advantage of Vitec is that it will give you all the data together, but the patient demographic data here is only going to be there what you enter into the Vitec. So if you don't enter the full name, you don't enter the age, you don't enter the registration number, none of that will be captured by the database. Okay. LIS if you use, again, if you've suppressed a particular antibiotic, you've not reported it, that data may not come up in the database. EHR or CDSS, again, same issue. If any report is suppressed, then you may not get that. But otherwise, in an electronic health record, you will get all the other patient demographic data. And lastly, of course, if you're using some external entries, then of course you're free to enter everything in that database. Now, just take a look at this. We just look at the first two. E. coli, this is the code in HUNET. The number of isolates, percentage of the total number of isolates which it caters for, and number of patients. Okay, so here we have actually got 1.3 isolates per patient of E. coli. So when I say that I'm going to take the first isolate of E. coli, how many isolates should I get? Correct, 653. Because the subsequent isolates of that patient are not going to be counted in my antibiogram. Correct? Agree everybody? Okay. Now this is the antibiogram. This is just a small part of the antibiogram which I have copy pasted here so that you all can understand it. These are all percentage susceptible. Okay? You have to mention the organism, the number of isolates or patients, and then the sensitivity for that particular antibiotic. Okay? This will actually be extending right up till here once you have all your antibiotics. Okay? Important point to remember is your number should be above 30. So ideally here you can actually omit out this Citrobacter causae. Now if I have Citrobacter freundii, which has 10 isolates, I could combine Citrobacter causae and freundii, make it 31 and then report this. But I will have to put it in as Citrobacter species and put in a comment saying Citrobacter species is equal to Citrobacter causae 21 isolates plus 10 isolates of Citrobacter freundii. Okay. Antibiogram in its true sense is what I just told you all. First isolate of the patient for the whole facility. Okay. This is used for empirical treatment for a patient who comes into the hospital. Means what? Patient has come into the hospital, develops fever, you're suspecting an infection, okay, you feel that, whoops, okay. You feel that you're going to grow an E. coli, you go to this chart and say that, okay, if he's got a urinary tract infection, ertapenem is 85%, which is good enough for me, I'm going to give ertapenem. Okay? But if the patient has been in your ICU for 20 days and he develops a fever, after he has received antibiotics for multiple days, this antibiogram will not help you. Why? Because these are the initial isolates that we have taken. Understand? Difference between a regular antibiogram. Okay? So regular antibiogram, first isolate, empiric therapy for patient when he comes into the hospital. Okay? Clear? If take only the first isolate. First isolate. What we assume is that the first isolate which has come in is going to be relatively sensitive. The ones which come in subsequently are the ones which are going to be resistant. Okay? So now, will this antibiogram help you for a case of VAP? It may or may not. Because VAP, you may get more resistant organisms. So there is where the concept of an enhanced antibiogram comes up. What do you mean by enhanced antibiogram? For which data are extracted, stratified, and displayed to answer specific questions. In this case, what is the specific question? Which antibiotic will I use for VAP? So what database am I going to take? Can I take database of all the organisms which have come from this thing? No. Why Acinetobacter? Maybe a colonizer. All the cases of VAP or all the cases of suspected VAP infections. If I'm able to get 30 of them together, analyze that data, that will help me to choose for a VAP case. This is called as an enhanced antibiogram. Okay, so this is in guide empirical antimicrobial in selected patient populations. Now this can be a case of VAP, it can be a case of neuro ICU or medical ICU, it can be a case of patients who have presented with cystic fibrosis. You can choose whatever strata you want. Remember one thing, your number of isolates should be more than 30. Okay? Clear so far what an antibiogram, what an enhanced antibiogram is? Okay. This is also known as customized antibiogram or specialty antibiogram. You can stratify it by location, type of infection. You can even look at it as a syndrome. So you analyze all the urinary isolates that become specific to a urinary tract infection. Okay. So you have a patient coming with a UTI, you look at the urinary tract data, or UTI infection data, and then you can choose your antibiotic. Okay. So this is called as a syndromic antibiogram. Okay. Now, see the difference between when we choose only the first isolate and when we choose all isolates. Okay. Now here, because of the sheer number, 652, 817, how much is 817 minus 652? Anyone good at maths? Roughly, I think about 100 and, thank you, 160 odd. Ertapenem 85% sensitivity goes down slightly to 84.3. So those 160 isolates have had higher resistance to ertapenem, because of which this has gone down slightly. Now if this number was closer, instead of 652 and 160, you had something like 400 and 400, this may have very well been half or 2/3. Okay, so this is why when you take the first isolate, you get a relatively sensitive pattern. When you take subsequent isolates, you will get a slightly more resistant pattern. Okay, now certain specific recommendations they have made that when you're reporting something like streptopneumonia, anyone gets more than 30 isolates of streptopneumonia? Okay, even I have not got more than 30 in a single year, but anyway, we always hope that we'll get. So penicillin, cefotaxime, ceftriaxone, you should mention the percentage susceptible for both meningitis and non-meningitis breakpoints. So you will have to have sub rows where you say streptopneumonia, meningitis breakpoints में कितना sensitivity है, non-meningitis में कितना sensitivity है, ठीक है? For staph aureus, you need to give all three. Staph aureus as a whole, MSSA separately, MRSA separately, ठीक है? And separate for urinary antibiotics. Don't combine what Sir said. Don't combine urinary antibiotics with everything else. Okay? All right. Breakpoints that are usually used are CLSI. Most of us, I think, are using CLSI. Okay. Which antibiotics do you include? those which are routinely tested. If you're using a surrogate agent, report the representative agent. So for example, if you're using cefoxitin instead of oxacillin, you report the sensitivity of cefoxitin as the sensitivity of oxacillin, and you don't include cefoxitin in your report. Okay? So report the representative agent, not the surrogate agent. Okay? For supplemental drug testing, don't include it in the routine antibiogram. Okay, now suppression cascade selective reporting. Remember, all suppressed results have to be included. Why? Because supposing you have 10 E. coli isolates, okay, 2 of them are ESBLs, okay? 8 which were sensitive, you have not reported cefoperazone sulbactam and piperacillin tazobactam, okay? Your sensitivity of cefotaxime comes to 80%, correct? ESBL producer, unfortunately, let's say with some other AMC or whatever, and those 2 isolates, you have cefoperazone sulbactam resistant in one, sensitive in one. What does your cefoperazone sulbactam sensitivity become? 50%. Is that true? No, this is misleading. Why? Because you have not included the suppressed results. If you include the suppressed results, all those 8 which were sensitive to cefotaxime are also sensitive to cefoperazone sulbactam. So your sensitivity of cefoperazone sulbactam is actually 90%. Got it? So therefore you have to include all the suppressed results. So when you're reporting for that one patient, you suppress the higher antibiotics or broad spectrum antibiotics. But when you're reporting for an antibiogram, you include everything. Okay? All right. Now this is a nice example where, okay, sorry. This is, I think, fluoxetine, okay. Amikacin, now this is where amikacin results are reported only when Genta is resistant. So if you look at Genta susceptibility, it is actually 74%. But when you look at amikacin susceptibility, you get it at 48%. Why? Because you have selected the subset of Genta resistant pseudoaeruginosa, not all pseudoaeruginosa, which is why you have got this false. Otherwise, can you believe that amikacin is 48% and Genta is 74%? Ho sakta hai? They should be somewhere close to each other, correct? So when you correct this, see what happens, 86 and 74. Okay? So this is why it is important to include the suppressed results. Now supposing you are doing an e-test and the MIC values come in, okay? The decimal MICs, usually we take it up to 2 points. So supposing you have an organism antibiotic combination where it is susceptible to less than 0.12, 0.25 to 0.5 is intermediate, and more than 0.5 is resistant. Now supposing you got an MIC of 0.125, kahan pe daloge? So here what you do is forget about the third decimal. Okay, consider it as only up to 2 decimals. So this becomes 0.12, fit it into this and mark it as susceptible. Okay. Now supposing in dilutions, okay, you're doing 1, 2, 4, 8, usually what we do is twofold. But in some cases, supposing you have by chance got something in between as a 6. What do you do in this case? You go to the next highest. That is, you consider it as 8. Okay. And the last is when you have off scale. That is breakpoint MICs usually. When you have something which is very low and you don't know whether to put it as, and your breakpoint says only less than whatever. If it is lower, you put it as sensitive. It is higher, you mark it as resistant. All right. So this is what I told you about streptopneumonia, meningitis and non-meningitis. So Staph aureus, here you can see 167. This is the sensitivity. Now when you say MRSA, look at the sensitivity, 47.1. When you say MSSA, look at 77. Now remember the example I spoke to you all about in the morning? GPC on direct smear. Do an MRSA chromogar if you know it's an MRSA. Now what is going to help you? If you know it's an MRSA on day 1, this line is what you're going to look at and decide on which antibiotic you can give. If you know it's an MRSA, till your sensitivity, 1 day before your sensitivity result is available, you can actually use this data and say that, okay, MRSA hai, my most effective antibiotic is going to be Clinda. Okay? All right. One more thing what you can do is when you're presenting the data is use a color coding. What Dr. Kumar also had shown. He had shown, of course, I think 4 or 5 color combinations. What is recommended is 3. More than 80% green, 60 to 80% yellow, and less than 60% red. Okay. Now, whenever you have a susceptible dose dependent category, okay, like cefepime, what you do is you have 3 options. You either combine your percentage susceptible and percentage SDD together, okay, mention it in the footnote as such, or have a separate percent S and separate percent SDD, or you show only percent S. Okay, so all 3 options, but you have to mention it in the footnote. Okay, intermediate you can include, but again mention it in the footnote as such, especially an eye with a topi. What is an eye with a topi? Where do we use it? Urinary tract infections. Okay. Now, whenever you have small numbers, less than 30, see if you can extend your data beyond a year. Go to 1 year, 3 months, 1 year, 4 months. If you're crossing 30, mention as such. In order to get 30 isolates, the data has been considered from the so-and-so date to so-and-so date into bracket 1.5 years or 1 year, 3 months. Okay, or you can use genus, like I gave you the example of Citrobacter freundii and Coserii being combined as Citrobacter. Can you combine Enterococcus faecalis and Faecium? No. Totally different resistance profiles. So do not combine those two. Okay? Alright. If there are any breakpoint changes like how CLSI usually does and troubles us, please use the latest breakpoints. Okay? And if you're using E cutoff values, mention the wild types with the footnote and the thing in the table. Okay. Now here again is the same thing. Ciproflox, Levoflox, similar. Ciproflox is in 92% susceptibility, 80% susceptibility. Now why has this happened? This has happened because we have combined urine and non-urine isolates together. So what has happened is ciprofloxacin has included both urine and non-urine isolates, but Levoflox has included only non-urine isolates. Can you get this kind of a picture? Where Levoflox is less susceptible than ciproflox? Usually you won't. Okay, they will be parallel, or Levoflox will be sensitive, but cipro will be resistant. Okay, so this is misleading. So this is one more point which you have to remember. When your data is ready, please go through it and look for these kind of pointers, which means that somewhere something is wrong. Okay. All right. So now when we look at the split, so E. coli all, this is what is the same thing which is here. Now look at E. coli non-urine. Okay. How much is cipro? Where's it gone? Cipro. 80. Okay. Levo is also. So now this is making sense. Correct? Urine isolates. Where is cipro here? 93. Not reported. This is now reflective of a proper antibiogram. Okay? Alright. Coming to enhanced, I've already spoken about unit syndromic and all. One important thing that you can actually do is blood cultures. This is something which is very interesting, that you look at all the blood cultures which have come positive for gram negatives and run an antibiogram on them. So you analyze that as a data subset and then see that which is the antibiotic you can give best. So the minute you have a blood culture GNB positive, look at your antibiogram for the blood culture positives and say this is my best antibiotic, so I'll try and give this. Next day your AST report will be available. Okay? Another thing which can be done is, as people start using the BioFire and the Gene Expert more and more, you can try and associate the resistance markers with susceptibility. So for example, those Klebsiella pneumoniae which have shown only NDM, what is their antibiogram? What is their susceptibility profile? Those which have got NDM with OXA, what is their susceptibility profile? So here you can then play around. And the best part of using this software, WhoNet, is you can actually play around with this as much as you want. Okay. Now coming to policy, this is basically a document which tells you which antibiotic you can use empirically while awaiting your culture reports. Okay? Okay, I'm going to stop the presentation here. I'll quickly show you all the antibiogram. Okay, now HUNET has got a very nice feature where it gives you a ready-made report. So till year before last, we were actually spending a lot of time getting out blood culture ka separate, urine ka separate, respiratory separate, enhanced antibiograms, which used to take me almost 2 or 3 months to prepare, but we used to do that. And then last year this year, I discovered this nice ready-made report which gave me everything tailor-made within about 10-15 minutes. So obviously, being a microbiologist, I took the easy way out. So here it goes. Data volume, okay. The micro lab, how many isolates, how many patients, isolates per patient, and forget the others. Then what has it given me? It has given me a split of male and female. How many male, how many female? Excuse me. Then it has given me a split of the location. ICU kitne, ICU category ke kitne hai? Wards in means what we have used for in is wards which are non-ICU, okay, and then outpatient or OPD. Then percentage of isolates by specimen category. So if you see urine, which is going to be probably the commonest thing, is the highest, okay. Then comes aerobic gram positive, how many we've got, aerobic gram negative, how many we've got, fungi, how many, and other results. Then organism wise. So this is the same thing that I had shown you in the earlier slide. Okay. Then from specimen, which was the most common organism seen, this is then now this is something which again you get ready-made. From urine, which is the commonest organism, blood, split of the top organisms, stool, soft tissue, body fluids, respiratory, genital we only had 2, and then the organism trends. So here it gives you, this is very nice, it gives you a split quarter wise. So you know first quarter how many you had, second quarter, and so this is actually going to help you in outbreak management. So maybe not so much for E. coli Klebsiella, but for Acinetobacter, you can actually see that one of the quarters you're having a high rate of isolation, which may be lesser later on. Okay, then we come to high priority organisms, which are the WHO thing. I'll skip that. This is the percentage RIS. Okay. Now this is for blood isolates. The percentage, these are the antibiotics. The percentage resistant, intermediate, and susceptible. All this has been taken from HUNET. Okay. So this is how useful HUNET is going to be. Urinary isolates, respiratory isolates, skin and soft tissue. I'm not showing you the details because I don't want to waste time there. These are the priority organisms again, and this is your antibiogram. Okay, so this is finally what you're eventually going to get. Okay, now these are gram positives, these are gram negatives. Okay, so this is the whole report. Now coming to antibiotic policy, you need to have an SOP for an antibiotic policy where you lay down certain guidelines of what it is, formulary restriction, de-escalation, etc., etc. I won't get into details of this. What I want to show you is the antibiotic policy chart. This is what has to be available at point of care wherever any consultant is going to see a patient. Now this is the surgical prophylaxis. Remember I told you we started in 2006-2007. At that time, this whole chart was only one line. You are going to give cefuroxime. So over the last 15 years, we have gone from one line to something like this, where you have clean surgeries, cefuroxime, single dose, optional antibiotic cefazolin single dose. If there is an allergy to beta-lactams, you give clindamycin single dose. Okay. So as you can see, most of the places it's cefuroxime. Now some places like a colorectal surgery, we have now used cefoperazone sulbactam, which is stat and BD for 24 hours maximum. Okay, so now we have changed. Actually, all this was possible thanks to Piyush. After Piyush joined us, we actually made it so comprehensive, and we also included the dosages and all these things, which was not there earlier. And then after this comes medicine. Now we have the syndromes. So if a patient comes to the emergency with community acquired meningitis, look at the age. Less than 50 years, what are the commonest organisms suspected? What is streptopneumonia, Neisseria meningitis, and Haemophilus influenzae, correct? What is to be given? 2 grams IV ceftriaxone. Duration, 10 to 14 days, 7 days for Neisseria, Haemophilus. This is what has been added after Piyush has joined us. So this is a major upgrade from what was earlier there. Now look at this. Whoops, sorry. Wherever there is a community acquired infection, you can use the ICMR guidelines. Okay, I think 2017 or 18, I think 19. 17? Yeah. So 2017 ICMR guidelines are good enough because usually community acquired, though there is resistance, they usually don't tend to become so bad or specific to certain areas. But when it comes to the hospital, look at this. Shunt, whatever, wherever you have a shunt or a post neurosurgical, this is actually a slightly older one, is based on our data. Okay. So meropenem, we found it to be the most effective, and vancomycin in divided doses. This is what you use to start after sending your CSF for culture. So while you're waiting for 2 days for your culture report to come in, this chart is going to help you to decide your antibiotics. That is your antibiotic policy. Clear? So individual patient report given for that patient, a compilation of multiple patients over the last 1 year helps you to get your antibiogram, which you will use for empirical treatment. Once you know it fits into a particular syndrome, that choice of antibiotic comes into your antibiotic policy. So we're clear about what an antibiotic report is, what an antibiogram is, and what an antibiotic policy is. Okay. I'll stop here and I'll hand over to Sangeeta ma'am for the most awaited and what is most important for y'all. Y'all better not sleep for this lecture. I know y'all have all eaten a lot.
So shall I wake you up? It's going to be very interactive, so I won't let you all sleep even after your heavy lunch. So at the outset, I must thank Dr. Vikram and Dr. Pooja for having me over for this workshop. And whatever you've heard till now, that is to make the antibiogram, to make the antibiotic policy, WHONET is one such software to make your life easy in order to produce these two things. So with the time being a little restricted, I will take you to the basics. We will do a bit of data entry exercises and analysis. Second thing I want to tell you is whatever I'm going to tell you is available on the website. So don't waste your time copying it or taking pictures because it's all there. I have also got it from there. So instead you pay attention and have any questions, free feel to ask. Third thing is, how many of you have actually used the WHONET? Anybody in the audience? Yeah, you have used? Okay. Only one? Only one? Okay. See a few hands. Fine. How many of you have got a laptop here? Oh, so many. And how many of you all have downloaded the WHONET in that? All of you almost. Any problems in downloading? Any problems? I got a message in the group that 2-3 days back that has been solved. Yes? Okay. So now we start. What I'm planning to do is I have my slides and we have the WHONET also loaded in this. So I'll do a shift between the two so that I'll explain with the slide and those who have a laptop can do it directly on that. So you can switch on your laptop and just keep it. I'll ask you whenever you want, whenever the time comes to do the entry. Is that clear? That's how we proceed. So a bit about the WHONET. I have been using the WHONET since 2007, right? And I must thank Dr. Rajesh Bhatia, who actually did the first version of the WHONET in the DOS. And he was my mentor for this whole thing. Yeah. So many of you, those who already have been using the WHONET know this, but this is what we'll briefly cover. One is I'll introduce you to what is this WHONET. We'll do a bit of lab configuration. I'm saying a bit because the rest you will go home and do it as per your own lab. We'll do data entry, analysis, introduction, and The last two things I will just talk about, we will not do in practice. We won't have so much time, right? So WhoNet is a free, firstly, remember it's free, because I know many hospitals say, oh, you're getting a software, how much do we have to pay? So remember, it's free. It's downloadable from the WHO website, or you just go to WhoNet in Google and you get the website. Second thing you must remember, you need the internet only for downloading, because this is another problem hospitals say, that, oh, our data will be shared with other, hospitals or worldwide. No, it's your data on your computer or your laptop. But for installing the WhoNet, you need the internet. So you could, if it's sometimes blocked, your hospital computer, you will have to get the permission of IT and download it, right? It's used in more than 80 countries in 53 languages. Hindi is not one of them. In India, we only have English here. And globally, you can see where all it has been used. The aim of having this WhoNet initially started off as making your own antibiogram, then your regional antibiogram like Mahasar, which is for Maharashtra, and Vinsar, which is for Delhi, and so on. CarsNet, which is for Kerala. So you can compare your data, say your hospital data, say Jehangir Hospital's data, with the rest of Maharashtra. That is the whole idea of having a WhoNet, if there is a central repository. Secondly, you can be part of many national or international global programs where you exchange your data in a confidential manner, which I will be showing you. And of course, to make a national policy on antibiotics or public health awareness, right? And the WhoNet also, now, earlier it was only human, now it's human, animal health, and we all know that, One Health concept, because the veterinary people use antibiotics for their feeds, which in turn causes resistance, which in turn you get resistance like salmonella. So it's a combined thing, but we will restrict ourselves to the human part, right? And how many of you have the White or any other automated program here? Many of you? Okay, I'll put it reverse. How many of you are doing manual data entry, manual reports? Okay. So your report to the patient, as I understand, goes manually, right? So for you, this WhoNet is going to be very useful. Also for the White, but for you all, is going to be very useful. Yeah. Others you can do manually. Either ways, it's going to be useful, right? Now, one thing is, like, people think it's only useful for antibiotic positive, say, cultures. But remember, if you can also take out a report in the WhoNet for the patient, and even negative reports can come into the WhoNet. I know institutions which are even putting their dengue reports. And when I was in Bombay, we used to put our TB reports in WhoNet. So you could, because where I was, we were a regional RNTCP center, and we had to send loads of data every month, sputum positive, 1+, 2+, how many were culture. Everything was from the WhoNet. So we could take it out, retrieve the data very easily. So it has multiple uses apart from your basic antibiogram, right? And as Dr. Vikram said, you could add what you want. This is a COTI, this is a WAP, this is from this doctor, say. Or this is from only neonates, this is only from pediatrics. Everything will come out in WhoNet at one shot. You don't have to waste time taking out the data. So this can be tailor-made, like MRSA, the MEK gene, or you want to put the OXA, NDM gene, you can get it out. You have to only configure it once, which I'll show you. Yeah, so as we all know, many people use the WhoNet. And, okay. So this is how, I'll just take you through the screens and then we will physically do it, right? So when you configure the WhoNet, the first thing is, this is already pre-configured, and this is one database which all the new people who have using the WhoNet for the first time can play around with. Nothing is going to happen. You will not spoil your data. This is meant for you all to practice. This is pre-fed in the WhoNet. So the WhoNet has these basic parts, which is, one sec, yeah. So your lab will come here. What is showing is the World Health one, but you will put your lab, say Sahyadri Hospital or whichever hospital, Ruby Hall, and you will give a code for it. We will click only human. We are not interested in food and environment. These are the important fields, of which antibiotics. Antibiotics means the antibiotics you are using in your lab. A whole lot of antibiotics are there. So we will configure some antibiotics, and I think all of us are using CLSI. So we will do the configuration as per CLSI. We are using e-test or MIC for some, DISC for some. We will do both, right? Then you have the location. Location is very useful to take out the enhanced antibiogram. OP, IP, outpatient, gynae ward, or say surgical ICU, and so on. Even in the ICUs, you can split pediatric ICU, neonatal ICU, and so on, right? Then you have data fields. Some data fields, many data fields are already there, but as I said, you can add on. You can say, I want to do the NDM gene or the OXA48 or whatever. You can configure it to your requirement. Alerts are already there, but if somebody is doing a project, say, on say something about penicillin resistant strep pneumoniae, so you could put it in as an alert, and whoever is reporting it will come. Yes, there is a penicillin resistant strep pneumoniae, which is an alert. Otherwise, all the alerts you don't have to touch. Now, again, I'm showing you, we'll do it manually. So in your entry, you have human, we'll stick to human. You have the patient details. You could fill in first name, last name, whatever you want. You can fill in date of birth or age. Then the second part is the location. Here you could see location, location type. Location means your hospital. Location type is inpatient, outpatient, and your department, institution. Specimen, I'm sure all you people, all the labs have a specimen number, right? So we put the specimen number, specimen type, specimen date. Reason, we are going to use diagnostic, so we need not enter that unless you want to do something for screening. This is the organism. This, if you want, you could fill it, like suppose there's a Shigella or a Salmonella and you want to put in the serotype. Here you have all the antibiotics. Is that right? So this is one, just the field, and there are, when you do it, you will understand. This is just a slide to show you that those who have a Vitek, right? You don't want to do a double entry. You must be giving the Vitek report to the patient. Yes? Okay. So this backlink feature, which is here, when you download the WhoNet, which we will do, this backlink comes along with it. And all it does is, you have your, say this is a Vitek, you connect it with the backlink into the WhoNet. So you don't have to do double entry. If you have entered your data in the backlink, you can directly take it in the WhoNet. Of course, there is no time for me to show it to you, but I'll show you where to get the information to do this. Is that clear? So you need not do a double entry again from the Vitek to the WhoNet. It will come automatically. And these are the systems which you can use a simple Excel. If you get your data in Excel form, you can use it directly into the WhoNet. Vitek, Microscan, Phoenix, and lab information systems can also go into the WhoNet. This is the data analysis, the most interesting and useful part for you all to make the antibiogram. So we have various, this is just an introduction. We will be going into details of this. You have the type of data. What Dr. Vikram said, you need the first isolate only. So your database will have all the isolates of the patient, but if you click this, one per patient, it will tell you, you want only first isolate, you say yes. So your problem of taking out your first isolate is solved just by clicking of this button. You will get only the first isolate. You could choose your organism. You want all organisms, you want only E. coli, you want only Staph aureus, please choose. You want, this column says you want from blood, urine, pus, you could choose. And from which period to which period. That's it. This is your basic analysis module. And the reports will come like this. percentage resistance. This is very, the font is very small, but just to give you an overview, this is the plain and simple what is sensitive, resistant, intermediate. You want to compare two antibiotics, right? Genta and amoxi, what is that? So you will get a scatter plot. Like this area is sensitive to both. This is resistant to one and so on. Very useful. When you're deciding your antibiotic policy and you're not finding enough isolates susceptible, you could go in for combinations. Which combination to choose? Your scatter plot will tell you. It'll also look like this. This is Amica versus Genta. So it's showing you this is susceptible, this is susceptible. So almost 86% are susceptible to both, right? And so which is better, Amica or Genta? This gives you, this is called a scatter plot. You also have resistance profiles to tell you what kind of pattern you are getting from the hospital B, nursing home, and so on. Like if you have, these are the alerts which I told you are pre-fed. So when you're entering data, it will tell you this is a CRE, this is an MRSA, this is a VRE, automatically. We are not doing anything. This is another very useful for those working in hospitals. When you enter your data, it will tell you there is an outbreak of Shigella soni, or there is an outbreak of MRSA or CRE. All this comes from the WHONET. And in India, of course, we have, these are various organizations which are using the WHONET GLASS, which was mentioned by Dr. Kumar in the morning. And now I think, we just finished this. This is the gonococcal program, which I'm not sure who's from Pune. Yeah, there is a gonococcal program going on in India, which has just started, and we are using the WHONET for that. Apart from that, we have the CARSNet and the others, Mahasar and so on. So first thing for you all to remember in a hospital is to tell your management it is free. Second thing is, your data is your data. Because I have faced this problem. How can we download it? Everybody will come to know. This is your data on your computer. You need the internet for exactly 5 minutes. That's it. Third thing is, you can do your antibiogram monthly, weekly. Of course, annually has to be done. But if you want to see the pattern or you have a lot of CREs, you could do it more frequently. And you can tailor it to your needs. You want to put your BioFire results or any other results. And those who are giving manual reports, I would suggest you use the WHONET and give a printed report to the patient because it's so easy. You can give negative reports also in this. And positive, especially the culture reports, giving it in a printed form makes more sense than just, giving it manually. So you all have all downloaded, right? For those who have not downloaded, I will just run. It's installed on your laptop. Can you see the icons? Fine. So those who have not downloaded, I'll just run through this. How many of you all are there who have not downloaded? Okay, fine. So when you go home, when you go to your laptop or your PC, it's all there. Where is the WHONET located for those who have downloaded? I keep saying now it's all there in the computer. So where is it in your computer? There is a place called C drive. In C drive, there is a folder called WHONET. If you go there, there is something called documents, DOCUMENTS, documents. Whatever I'm going to say, chapter-wise is there. You want to download, just go to documents and download. Follow the steps as it is. So need not copy it. I'll just show you how to do it, right? It's already done in this computer. So this is the homepage, www.whonet.org. I think this is all you have to remember. Okay? And most of you must be having newer laptops. Anybody has a very old, ancient Baba Adam ka zamana ka? No? Then, sorry? MacBook, it won't come. This is only tailored for Android. I mean the other one. So you have, they are trying, okay. They are trying for the MacBook. Yeah, what they were telling is if a MacBook has, see, I didn't understand it because I don't have a MacBook, but Dr. Stelling was telling that if there is a MacBook with some, you can do it. You have done it like that? Okay, then you take his help. I'm not familiar, so I don't know, but he said it is possible through that. Otherwise, for the normal PC, please download this one. They have asked you 64-bit or 32-bit. So if you have a modern computer, do the 64-bit, right? Don't bother how to find out. I'm not going into that. Just remember, if it's a new computer, just do the 64-bit. Yeah. So click on the 64-bit. It will say start installation and it will say download. Once it says download, the next thing which it says open or run. Some computers say open, some computers say run, right? And after saying that, you just say run. It'll come like this. Then you just press on install, right? And once you click on install, this question is always asked. Do you want the computer to make changes? It's a safe WHO program, so please say yes. Otherwise, it will not download. Just press on yes. Some computers may not ask this question. So this is the next screen which will come. I'm just going screen-wise, whatever happens when you press install. So again, say next. And it will go into, as I said, this will come in my talk almost 5-6 times. CNET is where your WHONet is going to be. C drive, sorry. So it is going to be in the C drive WHONet folder. Again, click next. You can also save it anywhere else. But what happens is you forget where you have saved it. Wherever you have saved it, your daily files and all will go. So we always recommend, and WHO recommends, to put it, keep it in the C drive automatically, right? So now it says install. Means it has gone there and you're asking it to install. It installs and you say finish. That's all. Once you finish, it says you have to say close. So once you have done this, I'm sure all of you who have done it would see these two things on your desktop. Yes, no? If you don't see it, there was something wrong in your process, restart, right? Once these two things come, your WHONet is there. These are shortcuts which are there on your desktop. And this is what you'll see. If it doesn't happen, then maybe your IT has blocked. Usually what happens is the IT blocks outside programs. So at home in your laptop, you won't have a problem. In your office computer, you may have a problem. Contact your IT team or try a different computer. Still, if you don't get it, help at whonet.org, but not required. Usually, I would say everybody gets it. If they have not done it, then it's the IT which is blocking it. There's a firewall or something of that sort. Right? So whoever has downloaded, have you configured the WHONet? No, you have just downloaded. Okay. So once you download and you open the WHONet, which I'll show you now, this is pre-fed. I told you the WHO TST file. This is the file you should, all those who are new to WHONet should keep opening, practicing. Nothing is going to go wrong. Just keep practicing on this, right? And here we will open our own new lab right now because all of you all are from different labs. Language, we're not going to be bothered. It's going to be in English. And that's it. We're not going to select fonts or anything. These are all the languages. There are so many, 58 languages, I think, but we stick to English. And when you're saying open lab means the lab which is already there, you could open it. New lab means you're going to make a new lab. This is a help file. In the help, there is a documentation. Everything what I'm talking is there. Everything. So, right? This is how the documents are. These are all the documents which are there once you open the help file or you go to C drive. So here, backlink, as I had mentioned, if you see here the first one, getting started, and choose your Vitek. There will be a Vitek somewhere here. How to configure your Vitek into backlink. It's here. Or you could, the simpler thing what I used to do was take the Vitek data in a Excel or a text file, TXT file, and then push it into the WHONet, which is very simple. So all you have to there, learn is this first module. Sorry. That is the backlink, getting started, and Excel and text files. So, I mean, this just as an info, I'm not going to be showing you. Right? So with this, we'll move on to actual working of the WHONET. Oh, I've switched it off. No, I don't know what I've done. Yeah. Any password? So till now you have understood how to install it. Any doubts in installation? Very simple. You should get 2 icons on your desktop. Okay. How to?
How to link it with Excel? Because we have data in Excel only.
So today there will not be time, but if you go to backlink, check the second tutorial 1 and 2. It will teach you how to link it with Excel. Very simple. Follow that. Keep your Excel open. Follow that line by line, and you can do it. It's actually so simple. So these are the 2 icons you can see. One is the WHONET, and near it will be the backlink. Yes, everybody has got? We will not touch the backlink today. We will only work with the WHONET. So please double click the WHONET. Whoever has got it, double click the WHONET. Yeah? Yes. So Dr. Vikram has already put his lab, but we will make our, if you don't mind, can I just make a new lab? Yeah. And I told you the TST file, which will be there on all your computers, right? That is for you to practice. And we will do our analysis with that file. We will not use any other file. So right now, I'm going to teach you how to open a lab. Click on New Lab. Right? Are you getting the screen? Those who have laptops can share with the neighbors, or you can just watch this. You're getting the screen? Yes? Please say yes. I can't move forward otherwise. India. Country is India. Put your own lab's name, whatever you want. I'm just going to put A, B, C, D. Right? Yes? No? Yes. Now every WHONET works on codes, be it a specimen, be it an organism, be it a location. So you have to give your lab code. Minimum 3 letters, maximum 10. So we'll just put A, B, C, whatever you feel like, right? Done, and we are clicking on human because we are going to do human isolates. We are not going to click on food and environment. So far everybody is clear? Can I move ahead? Okay. Now we click on antibiotics. This is called configuration. What we are doing now is configuring a file for our own laboratory use, right? So see this, we are using CLSI. You have an option of disk, MIC or e-test. Now you may ask, what is the difference between MIC and e-test? E-test also gives MIC only, but it has those in-between values. You could use them interchangeably. Preferably keep only one. Keep it as MIC. Whatever your e-test results come, keep it as MIC to avoid confusion. But you're actually doing the e-test, right? So first we will configure disk, then we will configure the MIC. Now when you come to this side, that is what I'm showing you here, can you see, let's take amikacin, right? Can you see amikacin? In bracket, CLSI and UCAST, 30. What is 30? Concentration of the disk. Okay. So let us bring it to your right side. Just click it single or double click. Has it come? Yes? Yes? Yeah. So whatever antibiotics you're using in your lab, you bring it to the other side. Suppose you have made a mistake and I have clicked say this, right? And I realize I don't want this. Go here and again click it back or use this arrow. Clear? Right? Okay. Now I want you to configure. Okay, we'll do a few configurations. We'll do one MIC now. MIC, vancomycin. Let's do vancomycin MIC. Now you're going to search a lot. Can you see one search button here where my arrow is pointing? Next to it you put VANG, VA. Has come. So you click Vanco and bring it to the other side. And we have put MIC here. So hence nothing has come. It's already CLSI. Yes, no? Yeah. Let's put one more MIC. Which one? Which you all must be using? Colistin? Okay. So take out the VANC, put colistin. This is an easy way to search. Otherwise, you can always go down and search. Colistin has come? Yes. Bring it to that side. Right? Now again, let's do one disc only. You want to do e-test? Okay. Which e-test you want to do? Sorry? Vanco we've already done. Let's not confuse. Penicillin for strep pneumoniae, right? So put penicillin, e-test. Right? Okay. So if you see this side, you have Amica ND. Now what is ND? What is N and what is D? D is disc. What is N? What is N? Before you all were born, CLSI was called NCCLS. So the N is for NCCLS. They have not changed it, right? But D is disc. Below that you see VAN NM. M is MIC and N is NCCLS criteria. Colistin is NM. Penicillin is NE because we have used e-test. So like this, you can configure. Another important thing here, you finished, you think you have configured, you want to go back and you will just press this cross, all your data will be lost. In WHONET, you have to keep saving your data. Otherwise it gets lost. So unless you press OK or save, don't press now. But if you press OK on save, only then it gets saved. Okay, so now let's just look at the, till here everybody can put in your antibiotics. Anybody has any doubt here? No? If yeah, you can add. I will show you. Modify lab is there. I will show you. I'll come down to that. But here, if those who are giving printed reports and you want, see the penicillin to go up, I'm just showing you. So you click on the antibiotic and say move up. This is for your printed report. For entry, it doesn't make a difference. Got it? So move up or move down, whatever. Now come to the first column here, breakpoints. Can you see breakpoints? Yes? Now when you click on breakpoints, it's asking you this diffusion. I don't think you'll do this. Just have a look at what is happening because you're not going to be working on this. Disk diffusion, MIC and update. So every year you must download the WHONET of that year. Please remember your data, your origin, like this is 2024 December almost. So 2025 WHONET, when you download, your 24 data does not disappear. It is there. But your CLSI 25 gets updated. Is that clear? So you must update it, just download it every year. And let's look at the disk. I'm just showing you an example of some disk diffusion breakpoints which are already there. You don't have to do anything. This is already there. Unless you're in a research lab and you want to put it, say, for me, my research lab, this is sensitive or resistant, you have to add. Otherwise, as a clinical microbiologist, you don't have to do. Similarly for e-test, right? But remember to update the whole thing every year. Expert rules are automatic rules, like simple things like what was said about cefoxitin and oxacillin, right? So if you want it, one sec. I don't know why this is not coming. Okay, we just take this out. Okay, normally the rules will come automatically. Oh, I have not put in oxacillin. That's why it's not showing probably. Okay. Can you see panels? This is what I want you all to do. First is you put your antibiotics for those who are doing manual entries. So those who are doing manual entry, please pay attention to this. When you're doing manual entry, you don't want yourself or the technical person who's doing it to see 30 antibiotics. Like suppose there is staph. You only want, say, 10 antibiotics for staph. You don't want a vancomycin for E. coli. You don't want a colistin for staph. So this is called a panel. If you configure your panel, only that what you need will show. So it's helpful to the, otherwise all 30 will show. So let's look at Amica. Do you need it for staph? No. Do you need it for, say, gram-positive urine? No. Gram-negatives? Yes. So we click here. Gram-negative urine? Yes. And then you can go on with this arrow and so on, right? Now let's look at Vanco. What all you need Vanco for? Staph? Yes. Strep? Yes. Pneumo? Yes. Viridins? Entro? Definitely. Colistin? Gram-negatives. Penicillin? Basically for pneumo. So this is called antibiotic panels. All those who are going to do manual entry, please put in your antibiotic panels. It makes it very easy to enter the data. Correct? And don't leave without saying okay. Right? Now profiles I'm not going into, that is much later. Can you see this print? So those who are going to do a print of the report, instead of giving a, you could choose an A4 size report paper and choose how you want to print. There are many options, you could just print it. So whatever you're typing, one report will get printed, right? Okay. Now we have configured around 4 antibiotics. What do we say? Okay. Otherwise we have lost this. Then we say save. Madam, to answer your question now, we have finished saving this. What do you want to save? What do you want to add? Just name one antibiotic you want to add. Tetracycline. So go to file. Now you want to add on. You have forgotten to add Genta, or doctor here has forgotten Tetra. So you go to file, right? Can you see something called modify laboratory? Click on modify laboratory. And we are in our same lab. Go to antibiotics, right? You said Tetra. So we'll add Tetra here. Tetra, CLSI. Now you've added, right? And then say okay. So you've added your antibiotic. You can modify it anytime you want, and you think you've added something wrong, take it out, no problem. But just press OK. Can I move ahead? Yeah. Next one is a slightly difficult one called location. So for that, I'll show you the PPT first. Yeah. So we have done this. This is just a revision of what we have done, right? Just see the slides. This is define your antibiotics. Everybody, yes? Okay. These are this I will give you as a exercise if we have time to enter these antibiotics. Configuration, breakpoint, as I said, we are not going to touch. You can look at the breakpoints. You don't have to update if you're going to do a every year download of WHONET. And these are the special rules which are there, ESBL and so on, which are already put. Suppose you're putting clindamycin and it's resistant, it will say inducible clindamycin resistant. This is your panel which everybody should do. Please enter your antibiotic panels, right? Okay. Now we go to location. So what I'll do is please follow me in the PPT, then we'll do it manually. So once you click on location, what do you see here? You will see the lab code, right? And you have the institution, which is yours only, department and type. Department means what? Department means medicine, surgery, pediatrics, gynae, and so on. Type means what? Inpatient, IPD or ICU, right? So certain things are already fed in this. Like when you're seeing departments, there are many departments here: surgery, medicine, transplant, and so on. You can add depending upon your burns unit, you can add depending upon your requirement. Similarly, location, if you see, is outpatient, inpatient, non-ICU, only inpatients, and so on, pediatrics, and so on. Right? So, can you all enter this little thing, those who have? Location name will be medicine, 5th floor. In the lab you have opened now, all of you all have opened the lab. Click on location. Click on location, right? Can you enter these 3 things? You can see this, all of you? Yeah. And tell me where you find a problem. I've given you 1 inpatient, 1 outpatient, and 1 ICU. In the institution will be your institution, and this code which is here, I told you every item in HUNET needs a code. So medicine, this is my own code. Medicine 5th floor, I have written Med 5. This is my code, it has nothing to do with HUNET. See, this is my laboratory, I have put this. Medicine ground floor, I have put medicine, Med GF, and so on. Any difficulty here? When you enter the department? No, institution will be your institution. What have you put your lab as? So whatever code you have put, no, for your lab. You have put some code for your lab, no? Okay, Doctor, I'm going live on HUNET. So what was the first one? Medicine? Medicine 5th floor. Here everybody has done medicine 5th floor. Then what is the code I have given? Med 5. Institution, when you click on institution, see on this box, see here where the arrow is. Your lab's code should come. Is it there? Not there? Yes. So click that. Department, you don't have to type. It should come here. You just look around, you'll find medicine somewhere here. Right? And what was the first one? OPD? No. Inpatient. Okay. So again, location type is inpatient, non-ICU, or inpatient. That you should be clear what you're taking in inpatient. Has everybody got this first line? Any doubt? Okay, we go to the second one. This is just for practice. Medicine ground floor, Med GF as outpatient. Department will remain medicine, and this will remain outpatient. I think the code is OUT. Right? Everybody has got this? Yeah. And the last one I had put up was pediatric ICU, PICU. It comes under ICU. Department will be pediatrics. Pediatric is not there? Department is, no, pediatric, sorry, department, and I was searching for PICU will not be there, it will come under ICU. Yeah. So you can either put it as pediatric intensive care or you can put it under pediatrics as ICU. Choice is yours. I mean, it's your hospital. You have to analyze the data. You have to know what you have put. As simple as that. Clear? So everybody can configure. Now, if your hospital has, say, 2 buildings, so in your location, you could also put, say, Sassoon Hospital Building 1, Sassoon Hospital Building 2. You could put that because the whole institution is Sassoon Hospital. So location could be that also. So as I said, it's your HUNET, it's your hospital. Do it how you want, how you're comfortable, and you can take out your data. You may have a medicine ward in both building 1 and building 2. You may want to compare the two, right? So you could do it that way. And before you exit, what you'll do? Okay. Unless you press OK, your data is lost. Right? So what have you done till now? You've made a lab. You've done the antibiotics. You have done the locations. Everybody can do this. Anybody here who cannot do this much? Anybody? Okay. Now we look at data fields. Okay. So in data fields, I'm just explaining to you and then we will see it. So you have your various fields which are already there, and you could modify the list. If you don't want a field, you could take it out and you can add any more things to it. So when you're modifying the list, these are all the things you can modify. Please see here. You could put clinical information, which is the diagnosis, hernia, hydrocele, lab coli. You could add that. You could add any more microbiology information if you want, like we just said, no? CRE, NDM, you could add that. Those who are belonging to the gonococcal program or others could add there. You have diagnosis, physician, you could put a gram stain here or an AFB smear, gene sequence. You could define your own data fields. So this is entirely yours. Some things are already there. You can do yours. And you could create another code list also. Like suppose you want to put a new diagnosis, COVID, which is not there. So you could create COVID and write CO19, and that is your new diagnosis. So again, it's yours, right? Now we'll just see here. This is how it looks. Move up means, again, this is for printing purposes or entering purposes. You could just move it up or move that field down. And these are all the fields which are pre-put. If you don't want something, you could modify it or just leave it blank. So you have country, lab, identification, name, sex. You could put both date of birth and age or just enter age. What is age category? Age category is adult, neonate, geriatric, pediatric, and so on. Location, institution, department, which we have done till now. What we have not done is specimen number, specimen type, and so on. So these are the pre-filled. Yes, it's already there. Carbapenem resistant, MRSA, inducible, and so on. But you could add on to this by just pressing this modify list, right? And add on what you want from here or what you don't want. Say, I don't want date of birth. I'm not interested. I just want the age. So I click on date of birth, bring it back. I don't want it. Unnecessarily, why to have a field? Or in the clinical information, you want date of admission? How is it useful, date of admission? Hospital acquired. So you want the date of admission. So push it this side. Click here and bring it here. Yes? It's already been selected. Diagnosis, you can bring it here if you want the diagnosis. Prior antibiotic therapy, yes or no, you could bring it here. So you create what you want. So you start with the basic, what I would recommend, what is already there. Once you're familiar with WhoNet, add 1 or 2 fields, in a week and practice. Clear? Anybody, any doubts till now? See, no point in asking me in the end. It's right here, it's in the computer, I can show you. Any doubt? Back people are very quiet or they are sleeping, I don't know. Done? Done it? Okay, okay. Any doubt till now? Any glitch? Any glitch, any problem? Why I'm asking is certain antibiotics sometimes give a problem, hence I'm asking. So you all have had no problem till now. Okay. So what do we press? Okay. This is also okay? You want to add anything? No. Right? I just press OK. All these code lists and all, don't bother. Just look at your main things. Yeah. And last column here is alerts. These are pre-fed alerts in the WhoNet. As I said, you don't have to touch it. If you just go down here, you will see the number of alerts which are there. Penicillin susceptible, vanco susceptible, important species, and so on. I don't think there is any alert which is not there. If you want something specific, or you're doing a project on Aeromonas, you want to tell somebody Aeromonas, if it comes, you could make an alert. Alert Dr. Shruti if Aeromonas comes. It will come up. Once Aeromonas comes, in the comment column, you write alert Dr. Shruti. So any Aeromonas, whoever is entering, will go and tell Dr. Shruti Aeromonas has come. I'm just giving you a very small example. So you could put an alert, you could tailor your own alert, right? Now, when the alert comes, it will tell you what is it a high priority? Do you have to save the isolate? Do you want to confirm the resistance by sending it to somebody else? And so on. Just press OK. We have not done anything. And at the end of it, we press save, right? So you have seen how you've configured your laboratory. You want to share your laboratory with your colleagues. Why do you want them to configure again? So you just press the second one. The third one, modify, copy laboratory and send it by email to your friends. It will be, where will it be? This configured file? C drive, WhoNet, bus. Copy that and send it so your friend can install it. Second thing is modify lab. I just showed you all how to modify anything, name, anything you could modify. Or you don't want this lab, like tomorrow Dr. Vikram will delete this lab because he doesn't need it, right? So regarding configuration, any doubts? Any doubts in this? Okay, shall we move or you want a break? No. Now we will actually do data entry. This is a hands-on thing. We have around half an hour left, okay? Because I want to do one analysis so that you all are familiar. Rest you can do on your own. Okay, so one is manual data entry, which is physically entering, and one is from backlink, getting the data, which I'm not covering. So we will create a new data file. Now, how often should you create a data file? A data file, although you analyze it, how often should you make an antibiogram? Yearly. But is it going to be useful if you're going to putting it yearly and seeing, oh, January I had an outbreak or March I had an outbreak? There's no use. So what we normally do is we present it yearly, but we make it monthly. You make your antibiogram for your lab monthly, but present it cumulative yearly. Is that clear? So that monthly you come to know what is happening. How many CREs, how many MRSAs, VREs, and so on. Yeah. So when we move to the data entry, this is what we'll do is we'll open a new data file. We are already in the lab, ABCD lab or whichever lab. New data file, and we give it a name. Okay. 1 sec, I'll do it live. Go to data entry, new data file. And how I do in my lab is, I give the name of the file as the month. It'll ask you the name. So for me to retrieve it, it will be SQLite is the program for the file, so we don't change that. Before the dot, can you see your name? Some ind ABC is given, whatever your left. So here I would give this is ABC lab, right? ABC of November 24. Is this clear? So give your file monthly names. This is just to make your life easy. You want to retrieve the data for August or September, you have to just go there. And then where does it save? See here, WhoNet data, it will save there as a SQLite, SQLite file. This is the WhoNet program file, we don't interfere. So far clear? So create a file with your hospital name and 1 month, whichever. Done? Done? Has the screen opened? The screen has not opened. Have you saved it? Once you save it, the screen should open. Open? Okay. So let's do some entry. I'll just see if I've given an exercise, then it'll be easier. Yeah. Can we all do this entry? In your own data file, please do this entry. Identification number 1, 2, 3, 4, 5. Please see the screen and do the entry. Tell me if you face a problem. Some people may not have done diagnosis, so leave it. What you have, you do. So we didn't configure it, no? You can configure it later. Whatever is not there, leave it. Able to enter? Location may also not come because you may not have configured it. Diagnosis नहीं आएगा, location नहीं आएगा because you would not have configured it. बाकी सब आना चाहिए. क्या नहीं आया? Yeah. Put any location. This is just an example. Feel free to do what you want. I'm just giving an example. If you have put any other location configured, you can use that. Done? Done? Okay, can I move ahead? Okay. How did you all get the organism? How did you select? You went all the way down, na? So just put search. Just put STA. Staff will come. PH. Right? So you click on staff aureus. Now I want to show you two things here. See the because this is what you will be using. Look at under organism, there is one extended and there is a short. Forget the glass. Okay? What do you mean by extended? Extended means all the organisms will come. All. See the names which you may not have even isolated. Right? And otherwise, and here you will also have just like things like acid-fast bacilli. Now suppose you want Enterobacteriaceae, only Enterobacteriaceae. What you'll do? So you will get, or Enterococcus species, you will get that. Enterobacter species, right? Short means what you're going to be using on a day-to-day basis, normally. So if your Vitek gives you some funny organism and you're not finding it, go to extended. So if you're looking at extended, you will also have all GPC, all GNB, and so on. And what was the other thing? Other things are fairly simple. Specimen Specimen type again. Specimen type, don't waste time, just put it on search, right? And you will get your specimen. And this will not have Foley's catheter because we are not supposed to culture Foley's catheter. Catheter tip is there. Catheter tip is there. So it will tell you catheter site, catheter central. So you could take it as blood from a catheter. This you will have to make your own interpretations, how you are going to, and keep it uniform. Suppose you want urine from Foley's catheter, here it is, urine from Foley's. Is that clear? Okay. So reason. In reason, there is AMR surveillance, there is diagnostic. So we all stick to diagnostic. If you are going to enter only diagnostic data, you don't even have to enter the field because you know it is patient data. Unless you are putting in screening data, then you will have to enter the field. Is this field clear? And look below. What are you seeing? Amikacin. I have put acroma. What was the organism? Staph aureus. Okay. Okay. So when you put staph, watch which antibiotic comes. Because we have configured only vanco. So the others like amikacin and colistin are not coming. This is the use of panel. That's why I said you must configure your panel so that the person entering does not have to search where it is. Clear? This is the advantage. Only what you put, cefoxitin, vancomycin, linezolid, teicoplanin, only that will come. Okay. So we have not entered all, but you could enter, we have entered vancomycin, right? So enter the MIC1. Right? Any comment? Nothing, because it is susceptible. So in the same thing, let us put the MIC8 and press enter button. I can hear ting tings. So you are getting some comment? What does it say? This is an important finding. See that it is not a lab error, means typing error or a lab error. Vancomycin or teicoplanin intermediate is something you will have to recheck. Is that clear? So suppose we put 32. Twice your error things will come. Suppose we put 32. It's come as resistant. But see your, here, what does it say? High priority organism, non-susceptible vanco, important resistance, save the isolate, infection control, alert, and send it to a reference lab. So automatically your WHONET is telling you whatever you have learnt in the morning. When you get an unusual CRE or an MRSA or a VRE, please inform infection control. Please be sure it's the correct sensitivity. If you have a facility, send it to a reference or another lab to reconfirm. Is this clear? This is the advantage of WHONET. Even if you're doing with backlink, these alerts will keep coming. Okay. And here a comment is your free text comment. You could put what you want. Okay. Okay, so the search, I have taught you how to search for the organism. Just put staph and you will get it. Antibiotic panel importance, I have taught you. Why is it so important? Yeah, now the question is, some people do disc diffusion and MIC. So should you put only resistance sensitive or should you put in the disc diameters? What do you think? Disc diameters. It's a pain, but you have to, it's better you put it. For the simple reason, we know that CLSI keeps modifying or changing the diameters every year. So if you have this, you have a permanent record that say in 2018, a disc diameter of 21 was susceptible, whereas in 2025, a disc diameter of 21 is resistant and 24 is susceptible. So you have a record. Is that clear? Even MIC, preferably put in the MIC values. People have a tendency to just, nothing is wrong if you just put in R and S and all, but putting in a value helps. So you could put in preferably do the zone diameters and not the interpretation. And this is the value of the zone diameters, which I was telling you. Also, assessment of test quality. Like over the period of months, you find that Salmonella typhi, which had a ceftriax zone diameter of say 30, in the same lab, in 1 month, it is becoming less and less. From 30, it has become 24. Interpretation is the same. Has your disk changed? Normally, it is 30, 31. Say, in your lab. Has your disk changed? Has it been stored properly? I mean, that is your quality control. So looking at a diameter also gives you an idea of how your QC is working, right? Interpretations, you've just seen what are the interpretations Dr. Vikram had shown you. Alerts I've shown you, automatically your alerts will come, depending on your quality, your species, your resistance and therapy, right? Right. So now we go back to the WHONET. What should we do first thing? So you can save, you can view, you can print. I'll just show you print, you all don't do anything. So it'll ask you, you want a clinical report, current isolate, or you want isolates from, say, this date to this date. I don't have a date, so it's not showing here. And you can print. And you can give this print with your sign to your patient. It'll come neatly typed. So that is another advantage here, right? So shall we save the isolate? Okay, we save the isolate. Again, it will tell you, this is a resistant isolate. Have you done this? Have you done this? It's going to remind you. So anyway, you have done everything. You're a good microbiologist. So you say, okay, right? Now, you realized you've forgotten to put, say, penicillin for this. I'm just giving an example. Like she said, you want to add an antibiotic. Can you see this? View database. Please see view database. Click on that. If you have saved, all of you have saved, then you should be able to see this isolate. Right? Click it and you say edit isolate. And you can add on whichever antibiotic you want or change the organism or whatever. Any doubts so far? So what you have understood is you can enter the data, you can modify the data, you can edit the data, you can print the data. Correct? Till now, any doubts? You all will be able to do this? Okay. You can also enter your QC data as QC data. Like I'm sure all of you all put in your ATCC strains weekly. So you could enter that data again to see if your disk is deteriorating, right? And you can see the database and exit. Exit is here. Here, can you see when you finish data entry, press exit and you just come to the main screen. Yeah. I'm not going to do any more data entry. So I'll just show you clinical report. Now we will do the most interesting thing, which is analysis. Something which you will hopefully enjoy and most absolutely useful for you all. Right. So now with analysis, we are going to work with the WHO TST file. We are not going to work with your file because you have only one organism. You can't do any analysis in that. So what you do is firstly, close your WHONET. Close your WHONET, right? Okay. So I'll introduce you to data analysis, then we will do 1 or 2 exercises. So we will open which lab now? Don't open now. I'm going to do it with you, but we'll open the WHO TST lab because all the data, there are, I think, 617 or 604 isolates in this, right? We will go to data analysis. There are 2 types of analysis. There is a quick analysis. Quick analysis, suppose you get a phone from the surgeon. How many MRSAs we've had last month? Just do a quick analysis, it will tell you. Right? But to make an antibiogram, you need the detailed data analysis. In the data analysis, what do you need? The type of analysis, the organism, and which data file. That is your basic antibiogram which he showed. But to do your enhanced antibiogram, we will need the specimen type, right? Whether inpatient, outpatient, and so on. So what are the analysis types we have here? These are all the analysis types which are available. Isolate listing. I want to know all the isolates which have come in this month. So it will give you a list. Percentage resistant, intermediate, susceptible, which is used for your antibiogram. Scatter plot, remember I showed you, is amikacin better or genta better? Or you can use is clinda better and cotrimoxazole better, whatever. Profiles, alerts, and cluster. Cluster is very important for those involved in infection control. This is very, very important. Next, we will click on organisms and you choose the organism you want to make an antibiogram. I have chosen staph and E. coli, and you could analyze it as one, and then we choose the data file for which we are going to choose the WHO TST file, not the file we have made. Shall we do this much? Right? So open your WhoNet now. All of you open your WhoNet. Which file you will open? TST file. Okay? Say open. So on top here, if you can see, you will know which lab you're in. Can you see here? WHO TST lab. So we are going to go to data analysis. Click on data analysis. Are you getting the screen, all of you? Who has not got the screen? Got it? Okay. Which analysis type we want? We'll do percentage RIS because that is required for your antibiogram. Correct? Yes? Yes. Which back you want me to go? Data analysis. Okay. We open WHO TST lab. Now we go to data analysis. Yes? Where are you stuck? Are you in the WHO TST file? Or are you in some other file? No, new file, you will not have any data, na? So there's no point. That's why I said we will go to WHO TST file. Okay, what we'll do is, if you get it, exit your WhoNet. Now open the WhoNet. Open lab.
Which lab? New lab or open lab?
Oh, it's not a new lab. We are going to work on the WHO TST file lab. WHO TST is there. Should be there. WHO TST, the second lab. Now open data analysis. Right? Yeah. So now what analysis we are going to do? Percentage RIS. So click there. Which type is, first thing which will come is percentage RIS. Say OK. Now if you just look at the screen, it asks you if you want tables, graphs, all antibiotics and percentage. We will not disturb this. This is default. Sometimes you want only table, only graph, but abhi don't do anything. Rehne do. Just say OK. Correct? Which organisms? Please select, all of you, Staph aureus and E. coli. If you don't know the code, you put the search. Slowly you will get to know the codes. Done? E. coli. Everybody has done? Everybody has done? So we are in the WHO TST file. We are going to analyze percentage RIS of E. coli and staph. Now here there is a box, analyze as one organism. You want to analyze as one? No, because one is GPC, one is GNV. So we just don't click it, we let it be. Here it is done. And we say, okay. Everybody has got the screen? Everybody has got the screen? Who has not got? Got it? Backside, got it? Done. So now what we have done, E. coli, Staph aureus, which data file you are going to choose? We are going to do a simple antibiogram, not an enhanced, right? Which data file you are going to choose? Click on data file. Are you getting these two things? Yes? Yes. So don't go to One Health. One Health will include food and veterinary. Just go to the first one and bring it this side. What happened? Not happening? Data file, yes, the third, this thing. Data file. And just choose, you will get two options or you may get three also. Yes, no? Yes, can I move ahead? Okay. Huh? Nahi? Why you haven't got? No, I know the problem here. You're not getting? You're not getting these two files? Okay. Just go back. No, that doesn't make a difference. Did you choose from files, data files? What came? This didn't come? Okay, just press down all files. On the right side, there will be all files. Okay, I'm going back. 1 sec. Huh? Okay. Data files. Till here you have got everybody? Okay, I'm clicking. Can you see here? All files.
It's asking file name. It's asking file name and folder. Different window has opened. Different window has opened.
Okay, fine. Then you just follow this. We'll come back to you later, right? Let's not. Yeah. I want you all to at least to see one. So we are putting this, right? Everybody has got this much? Yeah. So I say okay, and I'm going to begin analysis. So what have we seen? So I want you to see here. This is, it's gone up. This is E. coli. In my this thing, I put E. coli first. I have 86 isolates, everybody? E. coli 86 or staph? What have you done first? Staph, okay. Okay, staph 86 isolates. And are you getting all these antibiotics? Penicillin, cefoxitin and so on? Yes? You can see the breakpoints are already written. If there is a site which has been put here, unfortunately dog, minus animals also, okay, and you have a number. So 86, all 86 sensitivity has been done. This is percentage resistant, intermediate, susceptible. Screen is clear to all? Now come here. You want to see all the resistant ones. So you click on resistant, you will see resistant. You click on susceptible, you will see susceptible. Can you make out in the graph? Yes? Okay. You want to see particular antibiotic, click on Genta, you will get the pattern for Genta inhibition. The zones. Yes? Right? Now see here on top, can you see copy table? Okay. One tip here, when I work with HUNET, I always open an Excel and keep it minimized. So you can just say copy table, go to Excel, paste. Copy graph, go to Excel, paste. So your work is saved automatically. Yes? And this you can present directly also to your hospital antibiogram, or you could make your own colors and so on. That is up to you. So can you all take out a basic histogram, a basic RIS, all of you? Should be able to? Okay. But what use of this if I want to know E. coli in urine, say? So there is no use of having all the E. coli, right? So what we'll do is click on isolates. All of you all click on isolates. When you click on isolates, you see all the options here. What are we interested in? Specimen type? Urine? Okay. Specimen type. And say OK. Yes.
How to go back from these graphs?
Exit on top. Continue. There is a word called continue. Continue will be there. Right on top. And let's add one more thing. Let's add urine from OPD. Two things. Urine, E. coli, OPD. Is that okay by everybody? Huh? So OPD will come under which one? How to choose OPD? No, not location. Location type. Location will be medicine, surgery and all. So we choose location type. Right? Here when you click location type, what happens? You're getting all this. So we will choose outpatient. And say OK. Is that clear? I think my specimen type. Is your screen looking like this, everybody? Yes? Everybody with the laptop, is your screen looking like this? E. coli, Staph aureus. I'm going to remove staph now. I'm going to show you how to remove this. And we want it from outpatient, and we want only the urine sample. Till now, any doubts? Please ask now. This.
Location type and specimen type was again?
From isolates.
We have selected, but we have not got this in the box actually.
That means you haven't said okay.
Yeah, we've said actually.
Okay, do it again. No problem, do it again. Everybody else has got? Yes? So let's remove the staph. We don't want the staph. So click on organisms. And we'll click on staph, see what I'm doing, and bring it this side. We want only E. coli. Say OK. Everybody has got this screen? I'm doing percentage RIS for E. coli, for urine, for OPD. From the file WHO TST file. All these areas are filled, not filled. Yes? Can I move ahead? Yes. Okay. Now I'll say begin analysis. Now you all are getting this? All of you all are getting this? So what does it say? 15 isolates of E. coli. This is the susceptibility. It says some uncomplicated UTI, resistant, intermediate, susceptible, and so on. Is that clear? And when you want to come out, you just say continue. You want to save the table, save the graph, copy the table, copy the graph. Clear? Because you are working on the WHO file, not on your file. We are working on the test file. And I would recommend all of you to practice on the test file. So that whatever, nothing will go wrong. Don't be scared. Just click what you want. Press continue. Done? So all of y'all can take out an antibiogram from urine, from OPD, right? Now you take out antibiogram of Staph aureus from OPD. Same thing, delete all this. I want antibiogram of Staph aureus from OPD. Close the. So you go back to the analysis page. Exit, continue. Exit or continue, whatever. Yes, Staph aureus. Oh, very fast. Tell me, what is your MRSA rate? Anybody? MRSA rate of Staph aureus from OPD? MRSA or MSSA? MRSA. Okay. Everybody is getting 75%? Yes? Who has not got this exercise? Shall we move ahead? No, we'll come back. See, what happens is I have to finish certain things and we'll come back, those who have doubts, no? But the basic thing, if you're not able to do it, at least watch this. Yes? Can I move ahead? There are a few more things I want you all to see, hence. Okay. So now we want to remove all the isolate filters. Right? We don't want OPD, we don't want Staph aureus, we don't want urine. So you know how to remove, no? Filters? Okay. Now this is what Dr. Vikram was talking about. When we make an antibiogram as per CLSI M39, we need the first antibiotic of the patient. Only the first, correct? So don't work on your laptops. Please watch what I am doing. Can you see here, 1 per patient? Can you see? So if we click on 1 per patient, you get this screen. By isolate, by patient, or by time interval. So we will click by patient and we will see first isolate only. It is so easy. You don't have to look at your Excel and say kaun sa pehla aaya hai. You just click first isolate, the computer will take out. The WhoNet will take out. So making your antibiogram becomes so easy. Right? And then you have to say okay. And then analyze it. That's it. So your empiric antibiogram will come with 1 click by saying first isolate. But also remember your database, if you remember the example he gave, one organism had 800 isolates. First isolate means 670 happened. But your 800 is in your database. Right? So anytime you want to know your overall Staph aureus MRSA or E. coli, you have it in your database. But to present to the clinicians, you will use first isolate. Am I clear on this? For the clinicians, you will do first isolate. For your own lab, to know how your E. coli is doing, you will take all isolates. Right? Just cancel this. First isolate, all of you all can do. 1 per patient, first isolate only. Yeah.
Suppose patient X admitted to a hospital and multiple samples were sent, one urine, one
Correct.
sample, one blood sample. Then which sample or which organism will be considered as first isolate?
First isolate with antibiotic results. That depends on when you're entering in the system. Suppose you have 5 papers with you, blood, urine, respiratory, and you have entered blood. It goes by the time. It's very simple. It just goes by the time.
Blood will be the last one.
No, I am just giving an example. Same. Yeah. Huh? Sample wise is different, but first isolate with antibiotic results. Right? Suppose you have the same E. coli from blood and urine. It goes by the time. You might have entered urine first, it will just pick up that.
But when manufacturing happens, the urine there is different organism and blood there is
So that's what it's saying. First, isolate from the patient, whatever comes, that will enter first. That you cannot help, depending on your entry, right? So options, for making your antibiogram, you need the first isolate. All you have to do is click one button, and then you get it, right? Now, this has already been covered, so I'm not going to be talking about this. Yeah. So when you all become, your hospital will take part in the Indian or the Maharashtra program or wherever state you all are from. So you don't want to send the patient data, patient name, identifiers. You want to send your data. You want to say we had so many salmonella or so many Staph aureus, but you want to, this is called encryption of the data. So when we take part in, say, Mahasar or Winsar, where I was a part of, we used to encrypt our data. This process is called encryption. Again, very simple. So what happens is your name, your identification number, whatever you want, you can encrypt it, right? So for that, we just go to the WhoNet and don't do anything. I'll just show you. Data file here. Can you see this? Combine, export, or encrypt data files? Yes? Can you all see this? So when you click on encrypt this thing, it asks you to choose, which I'm not going to do now because I'm on the WHO file. So if you click this and say OK, there is a box here which says encrypt patient information, correct? So please don't click on this because your data will get encrypted. If you click this, what you will get is an encrypted file. The receiving laboratory, the Apex lab, will not be able to see the patient's name, hospital number, cannot identify the patient. What is the problem with this? You also can't identify the patient later once you have encrypted. So before encrypting, those who are going to be taking part in antibiotic networks, please save this file, what we made November, in another folder and then encrypt. Please remember this. Once you have encrypted, you cannot unencrypt it, right? So always better to either save it or save it in a different name. I can save it as WHO TST encrypted file. I'll do that and show you. But do not touch your old file, right? New data file, and yeah, I'm going to say encrypt, right? Okay, so we go to C drive. Now, where will your C drive be? You have a shortcut of your C drive? Left side. Yeah, okay. It goes to your C drive, WhoNet, data, and I made this as encrypt, right? Encrypt, can you see? Oh. Okay, I think I didn't save it as SQLite file, no problem. So it will come as a SQLite encrypted file and your original file will be there. So two options, either you save your original file somewhere else, then encrypt, or for the encrypted file, you put a word encrypt. But remember, if you have not done it, you will use your data. So that is the reason. And when you're taking part in any network, always encrypt your file and send the data. You are safe, right? So the other things are, I think you have done this analysis, run the analysis, choosing your options. Macros, okay. Macros, for those who are going to start WhoNet, macros are a facility which is there in the main WhoNet thing, where you can save. Every year you want urine E. coli, every year, from OPD, urine E. coli ICU. So one file, you save it as macro, you can keep using it every time. It will take in new data. Every time you don't have to enter. But that's later when you all are starting. Keep doing it every 6 months, right? So this is about the basic analysis, which I hope all of you all can do. I've taught them enhanced. Till enhanced, I've taught them. How, I don't know how we are with time. There's no more practical exercise. There is only one PPT if they want.
It's about 5 o'clock. If you don't have too many questions, we can complete the PPT.
It's a 10-minute PPT on analysis.
We finish up the PPT and then we'll look at any questions that are asked.
Yeah.
Timing, I have one question. Suppose in 2025 I download latest version of Pune, that is Pune 25, then should I have to use that version and left this 24 version, or this old data can be continued in 2025?
The data will remain in your C drive. Data is not going to go anywhere. Right? You can delete 23 version, no problem. Use 24 version, use 25. Your data is not going to go. Only your software will be new. Data is going to be permanently in your C drive.
So every year?
Yeah, please download the new one because your CLSI guidelines come in that. Otherwise, you have to update the breakpoint and all. Now, automatically it will come. So I'm not going to show you all anything. I'm just going to, I had given you a brief introduction about what are all the things analysis can do. So I'm just going to run through a few of them. Yeah. So the first one, I think all of you all should be able to do. And any problem, please go to the WHONet documents, read analysis and do it. And work always with your WHO TST file till your hand gets set to the various buttons, then you will be able to do. So isolate listing, what is the importance of isolate listing? If you read CLSI M39, it says that the top 5 organisms, or of course more than 30 isolates, have to be analyzed. How do you know which is 30 isolates? For that you do your isolate listing, and this is percentage RIS, then you do your, this we have already seen. Isolate listing. So we just do isolate listing and summary, and this is how it looks. You can choose an organism, you can choose a specimen, and this is how the whole list comes. Okay, now we have an encrypted file. Can you all see the specimen number here carefully? Can you see the specimen number? Yes? So in front of the number, can you all see something? An underscore? Under the specimen, at the end of it, can you see an underscore? So what does that mean? This is an encrypted file. So this is not the original specimen number, they have encrypted it. This is how an encrypted file will look. There will be a underscore and a dash or whatever, and at the end and the beginning. So this is your isolate listing. It gives you the complete list of what has happened in your time period. This is the summary of that, telling you had so many staph, so many E. coli, so many enterococcus, and so on. Little hint here, if you click on any of these top buttons, either it will turn into ascending or descending. Right? If you click on this, it will become alphabetical. So any heading you click, it will just be modified up and down. Is that clear? That's just for you to help in analysis. So isolate listing, you can get the top 5 organisms, then you decide you want to analyze the top 5 organisms from various specimens. You want isolate listings with alerts. How many MRSA were there? How many CRE were there? That also you will get in your isolate listing and summary. Alerts will be marked in red with the details. This, as I said, is very important for infection control personnel. If you do a summary with cluster alerts, it's all there in the main analysis module. So here, as you can see, you're having a diphtheroid. You have many diphtheroids on one particular day. So there is something wrong here. There are there are many Klebsiella pneumoniae coming one day after the other. So this could be either wrong identification or wrong collection of blood. This could be an actual, a patient-to-patient nosocomial infection. So a cluster alert gives you the beginnings of an outbreak and gives you an alert saying something is wrong. Why are so many diphtheroids which never happened? Suddenly, very few are there and suddenly one day we have so many. Is it a new phlebotomist who's collecting the blood? Or is it something actually contaminated? Or is the blood bottle contaminated? Something is wrong somewhere. So this alert gives you a very valuable input. Scatter plot, I had mentioned, you could choose any two antibiotics and see their effectiveness, right? And this will give you like this, either in measurements. So I have taken erythro and cefoxitin. How many of my MRSAs I can give erythromycin? So this is an MRSA here, cefoxitin, this is sensitive, this is resistant, and this is erythromycin intermediate, susceptible, resistant. So if you see all my MRSAs, there is nothing which is erythro sensitive. So if you choose your antibiotics, two of them, you want to know is Clinda better or erythro, you could just plot it like this in MRSA. So this is the use of a scatter plot. This also gives you individual ones, right? This gives you the overall percentage, measurements and interpretation. We find scatter plots very useful when we have to decide on combinations. Absolutely, for like, piptaz is better or cefoperazone is better when you have a ESBL. So just do a scatter plot and see what is happening in your hospital at that time. Sometimes Klebsiella, piptaz seems better, E. coli, the other one seems better, and so on. This is for pharmacy. It's not, they have compared Genta with Amica, and they found that both are, for the clinical pharmacist would be able to help here. So they found that 85.9% both are susceptible, but Amica you have some more susceptibility also. That was in brief about scatter plot. A resistance profile tells you what kind of resistance is this. So we have, this is MRSA. We have organisms which are only penicillin resistant, penicillin plus erythro, and so on. So it gives you how many isolates, what is the profile of them. This is all for analysis more, not for an antibiogram. And it will also tell you the cluster of a particular, this is useful for cluster detection. If you find an MRSA which is unlikely, but say erythrosensitive, and suddenly you find another MRSA which is erythrosensitive, there's something wrong, there is a cluster. So there is a patient-to-patient transmission. Any unusual pattern, right? Alerts, we have already seen, I'm not going to cover it. So you have high alerts, low risk alerts, important species, high priority, and so on. It will automatically come, we don't do anything. When you're entering the data, it comes, right? It will show in red. And cluster alerts, again I'm repeating, you get very useful data from this cluster alerts, especially if you don't wait for a year. I said you do it at monthly intervals and see what has happened in the month of 15-day intervals. You will come to know what's happening in your hospital, right? So this was in brief about analysis. There is really no time to go into each one of them in detail, but please play around with this, take the WHONet TST file, use it, nothing is going to happen. Just practice each and every button. That's how I learned it. So I'm sure you will be all benefit. Thank you.
I would like to extend my heartfelt thanks for your excellent presentation on WHONet, madam. Your deep knowledge of the subject and hands-on approach made this session both engaging and practical. The clarity with which you have explained the concepts and guided us through the software will undoubtedly help us in applying WHONet effectively in our work. We truly appreciate your time and effort you have invested in preparing and delivering such a comprehensive and informative session. Thank you so much, madam. All are requested to please submit the post-test questionnaire before going and fill the feedback form also. You will receive certificates through email. Dr. Esther Prabhakaran has sent you the certificates, kindly check. Now moving on to valedictory function. Dear esteemed speakers, honored guests and my dear friends, now it's time to celebrate the conclusion of our AMSP workshop, a journey that has brought us together in the fight against antibiotic resistance. Over the past few hours, we have been engaged in the enlightening discussions, sharing valuable insights and forged connections that will undoubtedly propel us our efforts in combating the antimicrobial resistance. I would like to thank my HOD and organizing secretary of Microcon 2024, Dr. Rajesh Karyakarte sir, for giving me the opportunity to be the part of this workshop. I would also like to take a moment to express my heartfelt gratitude for our chief guest who took out their valuable time and inaugurated the workshop. I would also like to thank the speakers for sharing their knowledge and guiding us through complex topics with clarity and passion. A special thanks to Dr. Vikram Padbidri sir along with his organizing team, which includes Reena, Twinkle, Sonia, for audiovisual Sagar, for food Sachin, and Venkatesh especially for housekeeping. They have helped a lot in the morning also while arranging the things, for their tireless efforts in making a workshop a success. Your meticulous planning and execution has ensured a smooth and making experience for everyone, sir. Looking forward to be a part of more workshops like you in future with you. I wanted to take a moment to personally thank our postgraduate student, Dr. Esther Prabhakaran, for your incredible support and hard work in helping to prepare for the workshop. Your dedication, attention to detail and proactive approach has truly made the difference. She used to sleep at 3 o'clock daily. Today also she took just 2 hours of sleep. She has worked very hard. We have explored and covered both the topics of workshop, that is basic and advanced antimicrobial stewardship, in a single day. It was heartening to witness the enthusiasm and commitment displayed by all the participants in tackling the pressing issue of the antimicrobial resistance. As we conclude, antibiotic stewardship is a team game with patient at the center, and it's our teamwork that will make the dream work. So let us carry forward the knowledge and connections that we have gained. Let's play a vital role in this battle. I sincerely urge you all to take insights from this workshop back to your institutions for advocating better practices and implementing strategies that we have discussed. Once again, thank you all for your active participation, your passion and commitment for this crucial cause. Looking forward to meet you all in the inauguration ceremony of conference. Its inauguration of conference is today at 7 p.m. It might extend to 7:30, I guess. And the conference is from 22nd to 24th. So let's meet there. Thank you, sir. Thank you all.